The third annual conference of MRA, Association of Rheumatology, Maharashtra, organized by API Solapur and API Latur. The scientific program and interaction in the conference will be extremely beneficial to both hardcore rheumatologists and to the physician who encounter the patients first. And patients are the ultimate beneficiaries. Thus, briefing of the theme of conference, rheumatology to the grassroots. I shall now call upon Dr. Mukund Rai sir, organizing secretary, to further proceeding and brief of the conference.
It gives me immense pleasure on behalf of the organizing team as such consisting of Maharashtra Rheumatology Association, API Solapur and API Latur. I welcome you all for this MRACON third annual meeting of the Maharashtra Rheumatologists. I welcome Dr. B.G. Dharmanand, our IRA president, who has come from Bangalore as the chief guest, and he is present the most earliest to reach. He is Dr. B.G. Dharmanand. He reached at 6 o'clock in the morning today. This conference was planned in 2020 and in 2021 later, but both years it was postponed due to COVID situations. Now we are able to gather it this year. We are fortunate enough. I welcome all the delegates. Now we'll start with the session after lighting the lamp. Okay. So I request we'll have first the words of wisdom from the masters in rheumatology. I request the hall management to start the session.
Now we are going to proceed with the scientific program. Our first session for discussion in MRACON 2022 is Words of Wisdom. The first session is Counseling Patients in Rural Area by Dr. V.R. Joshi sir, the senior most and fatherly figure in rheumatology, the Director of Research, Consultant Physician in Rheumatology, PD Hinduja Hospital, Mumbai, Honorary Rheumatologist to Governor of Maharashtra since 1999. He has received prestigious multiple awards and has multiple papers and poster publications in national and international journal. He is the editor of JAPI and has given many orations to students. We'll start with the audio and video slide. May I call upon the chairperson for the session, Dr. Ravindra Shah sir, physician from Solapur, Dr. Ashok Ganu sir from Latur, and Dr. B.G. Dharmanand sir, IRA president and today's guest of honor.
Which to me is significant on more than one count. For example, it's the first annual conference after the pandemic, an indication that our lives are returning to normalcy. API 2 cities have come together to hold this conference. This will encourage more cities to hold similar conferences and increase the awareness of rheumatology across Maharashtra. I congratulate Dr. Mohini, Ganu and members of the organizing committee for their commitment to hold the conference despite the prevailing uncertain conditions. The conference is an evidence of growing interest in rheumatology amongst our physician colleagues, whom I expect to be our partners to provide the much needed care to patients with rheumatic disease. Unfortunately, I will not be able to welcome you in person. I wish you all a memorable and enjoyable conference. Long live MRA. Respected chairpersons, Dr. Shubhda Karkarge, Dr. Mohini Garnu, organizing committee members, it is both a pleasure and an honor to address the conference. Thank you. Unfortunately, my health does not permit me to do so in person. Dear colleagues, let me welcome you to the conference. These are difficult times. We have come to the conference with sadness in our hearts. We remember our colleagues who sacrificed their lives in the call of duty or succumbed to the virus. We have lost our dear and near ones, our patients, and the millions who we never met or will never meet. Let us observe a minute's silence. We have come to the conference to update our knowledge, but more importantly, to renew friendships, make new friends, and relax. I intend to look at MRA, what it is not, and what it can be. MRA is possibly the youngest regional association of IRA, only a few years old. This is true as far as MRA is concerned, but not for rheumatology. The seeds of rheumatology were sold in Maharashtra at Nair Hospital when late Dr. M. Desai established the first rheumatology clinic in India. The year was 1959. In 1966, IRA was formed. Following the death of Dr. M. Desai, there followed, as often is the case with organizations, a tussle as to who will be the boss, who will run the show. It was an uncertain period, a painful period. With this unpleasant experience, I was not interested, wrongly I must confess, to form an association. We had to wait for Dr. Chopra to take the initiative. Thank you, Dr. Chopra. Thanks are also due to Dr. Nachiket Kulkarni and the committee members for efficiently navigating MRA during the pandemic. MRA is in its formative years. It is the right time to know ourselves, our strengths, our shortcomings, define our goals, chart a plan of action, and act. In short, commit or visualize where we as MRA will be, say, 5 years or 10 years down the line. Though young, we have a healthy membership. But do we have at least one rheumatologist in each district of Maharashtra? I don't think so. This should be one of our goals. Our reach should be far and wide. This can be achieved by augmenting our numbers, especially amongst the neglected areas. This will not be easy. It is unlikely and wrong to expect a trained rheumatologist to settle in smaller and underdeveloped places. The solution is to create a cadre of internists come rheumatologists by training senior experienced internists from these places. Surely they can take care of run-of-the-mill cases. There is nothing radical about this suggestion. We have amongst us internist rheumatologists who are doing a great job. We have to shed the dogma that only pure rheumatologists should treat patients with rheumatic disease. That certainly is true for complex rheumatic disease, The million disorder question is, are we game for it? Presently, we have a few centers that offer training in rheumatology. To the best of my knowledge, these are confined to Mumbai and Pune only. We have to develop training centers in other cities. It is possible. Each one of us is a possible teacher. We have few rheumatologists trained in clinical rheumatology. We need more. Presently, to the best of my knowledge, there is only one center that offers DM in rheumatology and clinical rheumatology. Then we have more such centers. We have poor visibility and impact at the national level. This is reflected by the papers published in JIRA and other journals, contributions to publications from India, participation in national conferences, orations, awards, contacts and collaboration with foreign experts. Without such activities, visibility and impact are not possible. Participation in IRA matters is also necessary. Protect and further our interests. It's not been always so. Somewhere along the line, we seem to have lost our way. My wish list is long, but I will restrict to one more. It is to make a conscious effort to improve the quality of research, both clinical and laboratory. Presently, few centers offer MSc and PhD by research. These programs automatically improve the quality and quantity of publications. We have to do collaborative studies, share data to have large data sets. I realize this sounds like a sermon, a fault-finding exercise, or daydreaming. Call it whatever you may like, but then those who lose dreaming are lost. And if we do not know where we are going, we will go nowhere. We want to make MRA a leading association. I end wishing you a memorable conference. Long live MRA. Thank you. Dear all,
Thank you, Dr. V.R. Joshi, sir, for your wonderful words of wisdom on patients counseling, which is an important aspect in today's practice. Now I invite Dr. Lata Bichile, ma'am. She is a stalwart in the field of rheumatologist, a former professor and head of the medicine, GS Medical College and KM Hospital, Mumbai. She is founder of patient support group, Mission Arthritis India for patients with arthritis. She is a founder of a leading learning platform, Room 360, to educate and empower doctors and professionals with integrated patient care approach. She has worked extensively in rural areas of Maharashtra for awareness in arthritis. For the topic for discussion is treatment challenges in limited resource and settings.
Good morning, everyone. I come from a place called Ambejogai. I got my MD degree in Government Medical College, Aurangabad. I migrated to Sion Hospital, Mumbai. There I worked with Dr. Yojana Gokhale, Niharika Gill, and we three of us established rheumatology services in Sion Hospital and LTMG Medical College. I got trained under Dr. V.R. Joshi. So what I am today is only because of Dr. V.R. Joshi. In my all career of rheumatology, I was closely associated with Dr. Arvind Chopra, who pushed me into BJD India, and I could contribute in clinical studies from my rheumatology unit for the Ayurvedic medicines, and he has published the papers on that. I think with this brief introduction, the only guilt that is there in my mind is that I could not serve the patients from my area, and these people and the patients from this area, they have shown immense love on me and to my husband, Dr. Sunil Bichile. Let me say, respected chairpersons and friends and this August gathering at Solapur, I am indeed very much thankful for inviting me to speak on challenges in rheumatology in resource-constrained areas. What I'm going to cover is some introduction, the workload, difficulties in diagnostics, what are the treatment opportunities that rural patients are missing, and what we must do to to dissolve these disparities. India has seen tremendous improvements in the healthcare system, particularly in infectious diseases. There is a lot of awareness on non-communicable disease, and there is less investments from the government policies, and these illnesses contribute to morbidity and mortality to the extent of 63% because of cardiovascular, respiratory, cancer, and diabetes. To our surprise, even though there is a burden of rheumatological diseases, it is still underreported, and I think we all are responsible for it. As Dr. Vyazushi said that we must come together, collect our data, and do publications. In this August gathering, Dr. Arvind Chopra is the only one rheumatologist from our area who has carried out a lot of epidemiological work. All these illnesses, they give rise to disability of inflammatory diseases, and that's surely because of delay in diagnosis and initiation of treatment. And I think every person has a right to receive this initial treatment to decrease the deformities. It's also not understood by many of our colleagues who are not in rheumatology that these chronic illnesses who remain untreated, these are the patients who develop coronary artery disease, vasculopathies, and that is also important cause of stroke in myocardial infarction and stroke in young patients. Rheumatology for a patient or for a clinician must understand that is a branch of internal medicine, and everyone should have that insight and some information about managing these patients. I don't blame the clinicians, but I will blame the educational systems where there is a good curriculum to train the undergraduates and even the postgraduates. Let me tell you here to all the physicians, there are more than 100 to 120 illnesses that present as arthritis or arthralgia. Besides that, we have got autoimmune diseases, and there is a lot of awareness of autoimmune disease with a rapid course downhill from the surge of COVID pandemic. Other diseases, degenerative diseases, and we find a large number of patients who are living beyond 75 years. So we will have something like epidemic of osteoarthritis, osteoporosis, fractures, and so on. Rheumatologist is a doctor who deals with many patients suffering from aches and pains, and I think that Arvind Chopra will try to convey from his epidemiology work. And also I know that those doctors are working in rural areas. They deal with the patients who are working on roads in various schemes and even farmers. We also have some atypical diseases which are not very common, like scleroderma, vasculitis, and myositis. Let me say it here that with the recent COVID endemic, we are going to have an increased load of patients with interstitial lung disease, and every physician has to know the aspects of ABCD of ILD, and he has to take the help of a pulmonologist. There is going to be an increased burden of avascular necrosis in patients with COVID who had thromboembolic manifestations in their ICU stay. And we know that in our group, there are doctors from Pune who are reporting the AVN at multiple sites, particularly in the foot. Long-lasting fatigue is an important debilitating manifestation, and we should have some protocol how to convey the patient, how to overcome this fatigue without much drugs. Aches and pains, and there will be a lot of skin manifestations following this COVID. In Maharashtra, there is chikungunya is prevalent, and there are innumerable patients with chronic inflammatory arthritis in rural sector who have got a mindset when there is an arthritis, there is no treatment. I think Mohini Ganu will enlighten on this in her topic. Population of Maharashtra is 12 crores, and from the studies of Arvind Chopra, A.N. Malviya and other centers, the RA prevalence itself is 2%. So we will have, from a single disease, around 24 lakh patients of arthritis, either seropositive or seronegative. And let me tell it here, I may be wrong, but there are only 36 rheumatologists in Maharashtra. And we just heard from V.R. Joshi that he is expecting at least a good rheumatologist, a clinician with interest in rheumatology to handle this workload. Rheumatic diseases affect 6 to 24% of Indian patients, data from Lucknow. Till 2016, there were only 2 training centers. Now there are 6 centers that offer DM, DNB fellowships in rheumatology. There is Dr. Yojana Gokhale here, Kavita Krishnan. I think there are other teachers here who are conducting these training programs. I think we will have to widen our vision, our efforts, and even registrations for those who are beyond 40 for getting training in rheumatology, and I think IRA can take a stand in this. I must say that there are still inadequate or non-existent rheumatology, which is very serious, services, and also immense inadequate skilled health professional workforce in many rural sectors. Global burden and Indian burden of rheumatology. Global burden of disease survey showed rheumatic and musculoskeletal disease as the 4th highest global impact on disability adjusted life years. For example, when a lady has a claw hand or she has got deformed RA, she finds very difficult to work in the morning to meet the demands of the family. Second leading cause of disability as measured by years lived with disability. Take an example of a JIA girl or a boy at the age of 5 goes into adulthood or goes into a man and he has deformities of the hand or the feet or a knee being replaced, that will be the duration of year that he has lived with disabled life. I think this increased burden is due to delayed in diagnosis, due to poor education, social, cultural beliefs, poverty and limited access to health care. Despite sustained growth and development over the past few years, there are many unavoidable challenges for the management of rheumatological diseases. These are complexities of illness. A patient of RA may develop an ILD. A patient of lupus may develop a lupus cerebritis, or she will develop a foot drop. These are, for example, the complexities of illness for which the clinician has to be updated. There are risks of infections because they are on immunosuppression. Picking up infection and management or prevention protocol or a vaccination will be an answer to it. And we find a session of this type in the next 1 or 2 hours. Associated metabolic illnesses. Most of our patients, they are osteoporotic, they are vitamin deficient, they develop diabetes, they develop psychological illnesses. Besides that, every house in India has a diabetic patient, and this will add to the morbidity of rheumatic illnesses. Inadequate disease knowledge, right from MBBS entry till we become a physician. Therefore, and also changing epidemiology of rheumatic diseases due to rapid urbanization. When I went to Ambejugai last week, I didn't find the ladies or my friends of my age staying in Ambejugai. When I heard it, they said that none of them are here, they are all migrated to the better places. This shows the lack of even simple things in a place from which I come. What are the challenges that we have to face? Lack of access to a rheumatologist, which is the root cause. Access to uniform diagnostics, access to timely therapy, disease awareness, patient's perspective about the illness, and this is the biggest hindrance even for me in a place like Mumbai, as I deal near about 70-82%, I deal with from Maharashtra or Marathwada. My practice really in Mumbai is not from patients from Mumbai. Once upon a time, I used to get patients all over India because I had a chance to work in KM hospital and all poor patients used to be there. So my urge is to have a rheumatologist at smaller taluka or district places. Patient migration, because of COVID, we saw the problems on migration. Let me say, when we migrated from Ambejogai to Sion Hospital, I had a lot of inferiority complex about my dressing, about how I present, about the way I used to talk to my fellow colleagues. This can happen in a lady or a girl who is about MD and ready to deal with the diseases. What must be happening to the patients who don't know even how to talk, and mannerism, which is given lot of importance in day-to-day practice, at least in metropolitan cities. Diversion of patients to other pathies, I don't want to talk on this, but I think this diversion occurs because of lack of knowledge at the level of MBBS. I don't blame even physicians. And most of the patients do not know who is a rheumatologist, what he does, and how he is going to treat me. And I think such meetings and yesterday's program of patient awareness will definitely fill up these deficits. Lack of access to rheumatologists and well-organized team approach is one of the reasons for even morbidities, and not to forget is premature coronary artery disease and early deaths. Challenges: lack of access to diagnostics. Early diagnosis, judicious treatment with treat-to-target approach right at the onset of symptoms is crucial for a good prognosis. I know that when we worked in Sion Hospital, myself, Yojana and Niharika, we implemented triple drug combination. Way back it was discussed. I am very proud to say here that most of our patients, it worked like anti-TNF, and we are still using it in our clinical practice. And I think these protocols must be circulated by MRACON or even IRA for the physicians who have got inclination towards training or getting involved into rheumatology care. With the correct treatment, disease can be halted today or put to minimal disease activity into remission within 6 to 9 months as per the ACR-ULAR protocol, and we will have to take workshops for the joint count with patient demonstrations. In contrast, most patients visit family doctors and of all pathies right from Unani down, and so therefore these patients, they never receive, and they receive only symptom modifying treatment. It's nothing like I got a headache in the morning and I go to a doctor and he gives me an NSAID or a paracetamol. This symptom modification doesn't work in RA. It might work sometimes in, say, it is called as something as a muscle pain or something. Therefore, awareness has to be there. During these initial weeks, let me tell here that we have to do appropriate laboratory tests, and the request of the laboratory tests depend upon the knowledge of the doctor and local availability of tests. If an MBBS doctor advises, say, lupus panel or arthritis panel, it creates a lot of confusion instead of solving the problem. In resource-constrained situations, good clinical history, physical findings, and a thought process will give rise to a differential diagnosis from infection versus autoimmune diseases. And the clinical diagnosis is dependent upon training, education, and experience of an individual doctor. In this era of competition, when a student in MD, when he does the house post, he starts thinking of a DM in one specialty. So he is not very much focused, and that has really become a problem to conduct even UG and PG courses at medical institutions. Therefore, we have to change the mindset of student when he enters for MBBS or a MD or a super PG courses. Laboratory helps, let me say, they only help in the diagnosis. Common laboratory tests, as we know, these are common things, ESR, CRP, LFT, RFT, but I think you have to take a pause, interpret the report and verify your diagnosis before you ask for higher tests. According to me, rheumatoid factor, anti-CCP, ANA, these should be the basic tests. And once they're positive, that should be enough to make a diagnosis. And I'm of the opinion that the panel for lupus, myositis, scleroderma, vasculitis should be discouraged from the primary doctor, because that creates a confusion and patients are excessively they're drained by their finances and they feel that why have done these tests when the doctor is not in a position to interpret it. These tests are costly and they need the laboratory experts. However, I am of the opinion that every district has got an ICU where patients of MI and other medical emergencies are admitted. So I am of the opinion that at least ANCA, antiphospholipid test, is appropriate in ICU setting when the individual is trained in the approach of a given case. Imaging modalities, ultrasound, CT, MRI, DEXA are not uniformly available in rural areas. These tests play important role in optimizing clinical assessment, diagnosis and therapeutic interventions. If there is monoarticular stenosis, arthritis, fluid that can be tapped and a diagnosis can be reached, provided the clinician knows how a synovial fluid of RA looks on looking at it, how to look for a pus cell and how to look for AB, and he has to have a supporting laboratory. Ultrasonography is a reproducible investigation, and I think there are a lot of radiologists, young radiologists, who are doing a fantastic job. Other tests are costly in resource-constrained situation. Access to therapy is dependent upon nation's health policy. Medicine availability, which are now available everywhere, government funding for some investigation, for some medicine, financial position of a patient. If 1/3 of my patients of rheumatology need biological, they're all supporting themselves from a pocket, because the financial position of even in a family like Ambejoga in Latur has gone up because of mass education. Insurance funding. Treatments are modifiable as per the insurance coverage and scope for self-funding, and we're happy, all rheumatologists are happy that we have got a lot of experience on biologicals, biosimilars, and these days now even tofacitinib. Lack of access to therapy. Hence treatments with biologicals, biosimilars are out of patients' grasp, because usually they cost more than 1 lakh to 1.5 lakh for a course of 6 to 9 months. 1 in 10 or 1/3 of patients of RA, I am of the opinion that every spondyloarthropathy patient should receive a biological. Refractory lupus vasculitis require biologicals, and how we are going to make it available through patient's voice. Currently, Indian patients are being rescued with biosimilars as they have brought down the prices. There are certain patient schemes and pharma companies are generous enough if we request them to support a patient at least for 6 months. This therapeutic armamentarium of biologicals to me looks as a lack of disparity of treatment. And I find a lot of ethics when I say, if you can't afford it, just continue the basic drugs. I'm also of the opinion, I may be wrong scientifically, but in my personal experience, when biologicals were not available, how we treated spondyloarthropathy and how we were happy that time. Because our aims from simple edema, bring it down with the biosimilars, has changed nowadays. And we are looking at our patient from a scientific point of view and our self-experiment. There is nothing wrong in changing our own ideas. And I am of the opinion that there is a need to overcome these deficits and disparities. How we can do that? By strengthening the patient voice, changing the mindset of policy makers, for which the organization IRA, MRA, and patient support groups will have to work together and include biologics and biosimilars under government schemes. Let me say it proudly here that When first Enbrel was launched or even Remicade was launched, I used to go and visit, or I used to ask them to invite me for a lecture in Railway Association, ESIS Association, and there are so many associations where funds were there, but there was no one to guide them. So I told them that send the patients to me when I was in KEM. I used to attend their patient, go and show to their administrator, and I saw that these biologicals are brought on their schedule. So one can do such voluntary work when you are occupying a post in medical colleges. Challenge, we'll have to change the mindset of policy makers. What are the treatment considerations? Patient care, patients, caregivers, ourselves, rheumatologists must discuss the harmonized priorities for intervention to alleviate symptoms and independent function. Debility means the patient is becoming dependent on somebody for day-to-day work, even for his clinical work, even for his office work, or even for finances. Treatment goals between patient and a provider may not completely overlap. Example, a poor patient who works in an automobile repairs, he is happy for his AS pain when he is given an NSAID 2 times along with some anti-muscle spasm or muscle spasm reliever. But to me, I find that this patient should receive a biological. So I will be unhappy while treating this patient. But the patient is satisfied when he says, when I lie down on the floor, if I am able to lie down on the road, repair an automobile, I am happy with your treatment. Madam, you are so good, but I am not happy. So this is a sort of disparity. So whether to incorporate patient perspectives with higher priorities, when appropriate to preventing function at a patient selected level, rather than a treat to target approach, but ethics matter. Therefore, I must say that we must include the patient mind perspective. We must keep the patients mobile. We should give them medication, at least basic, all in combinations, try for biosimilars, and knowing the multi-complexity of a given patient. Example, a patient of RA going into ILD on MRI, I will have to change the disease modifying drug. This becomes the multi-complexities in a given patient. Nowadays, we are treating the patient with the target. So treat to target approach has shown therapeutic target defined and obtained it quickly, during which the disease is active and structural damage is readily covered. That means my duty is to stop the structural damage by hook and crook, by giving steroids, multi-DMRD, if possible, add a biological or a biosimilar. This is called this window period, once missed, which most of our rural patients are missing, gives rise to long, poor outcome. Advocates of treat to target, like we all rheumatologists in this hall, have disregarded personalized medicine versus the main goal of disease abating activity, regardless of mechanism implied in the drug chosen. This leaves a scope to prescribe biomarker. We must understand a precise biomarker before a therapy is instituted or it is selected. But most of these biomarkers, they are not available to us, and therefore most of the patients, they miss the opportunity of a personalized treatment. JAK inhibitor, now they are widely spread, they are easily available, the price is affordable, and they act at the inhibiting intracellular signaling pathways. And I must say here that the JAK inhibitors produced by most of the pharmas has opened a new treatment options to many patients. Other potential advantages of JAK, I think all of us know, rapid action, even effective as a monotherapy, absence of immunogenicity, that means they never develop an antibody to a patient or a drug. Treatment limitations, in spite of major advances in therapy, we are still unable to recognize beforehand which individual patient will benefit more from a given drug. Who will be refractory to the treatment? If I know it in advance, I will be able to choose a selected drug. Who will develop toxicity or intolerance to a drug? A matter of deep concern to us when patient has less knowledge or less education about the side effects of the drug. With major treatment benefits, few shortcomings are emerged, and these are significant direct costs on the healthcare system. Most patients often consult an orthopedic surgeon, a physician, a post-MBBS practitioner, and very few visit rheumatologists. By the time they visit us, there is always a delay of few months to 3 to 5 years, and it is still existing for rheumatology reference. Long waiting time in rheumatology OPDs may be at many multiple medical colleges, including Pune, Bombay, Solapur, and everywhere. And there is a concern of loss of a leave for a patient who is working, and therefore they refrain from attending these good setup of rheumatology and good setup of free diagnostics in most of the areas. So what are the recommendations to improve this care? There is a need to increase awareness of relevant symptoms of arthritis, autoimmune disease, and is essential to be done as is done in CA breast. Every woman in a village knows how to look for a CA breast. Or acute MI pain, because there was a lot of awareness about acute myocardial infarction, asthma and hypothyroidism. There is a need to cut down the delay in diagnosis and initiation of DMARD. It must be a national program as is done in tuberculosis, and we need a good ambassador. Why not a doctor who has spent so many years like V.R. Joshi and others, at least from Maharashtra, to be an ambassador for spread of anti-rheumatic drugs. Through many Facebook live sessions, I think there should be dissemination of knowledge through media and newspapers, books, pamphlets, TV programs and camps, and I think every rheumatologist in all states is doing his best to spread this, and IRA has a special different cell for the awareness of these diseases. Through many Facebook live sessions, these awareness activities are going on various states since the COVID pandemic. Migration of patients to different places interrupts the treatment adherence, and therefore there should be at least names of rheumatologists, at least on the Facebook or whatever the media. If suppose a patient goes from Pune, he goes to Chandigarh, he must have a name of a rheumatologist, though we are doing it on our WhatsApp group. Medical ignorance in Indian patients and symptoms attributed to factors. I have eaten this, thus I developed rheumatoid. Stress, excess work and lifestyle causes arthritis or autoimmune disease. It needs an attention, and we'll have to change the patient mindset. Poor referrals due to lack of knowledge with primary attending doctors needs attention. To target the primary health care givers, I think we'll have to target the primary health giver doctors in villages, towns and districts to develop greater knowledge on the impact of delay in diagnosis, patients' life, morbidity. There is a need to increase the number of rheumatologists with better regional distribution. I don't know how we can do it, but we'll have to make an attempt. There should be greater involvement of government and improved policies and curriculum revision. Let's come to how we are done so far for the patient support group. I think that the patients are essential to grassroots advocacy. They should be the advocates for themselves. In India, we have got IRA patient cell. MAI is run by Dr. Arvind Chopra. I have formed, we Mumbai group have formed Arthritis Support Foundation, though we had taken guidance from MAI, but there was some objection for the MAI because we can't use India, at least from the Bombay office, for our patient support group. Stand for AS, Shashank is here, Akerkar, who has around 1,500 videos on the Facebook, and he has done a lot for the cause of ankylosing spondylitis. There is SLE patient support group from Calcutta, Scleroderma India group, Shogran India from Gujarat, Antardhvani from Gujarat for ankylosing spondylitis, and ACE support group from Pune. If he is Praveen Patil is here, he is running that program. So a lot has been done, at least all over India, for rheumatology care. What are my takeaways? Am I totally unhappy? Definitely not. The present moment in rheumatology for all of us is exciting. It concerns the prognosis of patients with inflammatory disease. We need to bring uniformity into diagnostics, access to a rheumatologist, a basic need, and a team approach in healthcare system wherever possible. Because most of us are like-minded, we like each other. We might prefer a person from ortho, a dermat, or a radiology. I think we must organize ourselves in this direction. Each step in this direction, from teaching institutions, I am appealing all the teachers in this hall, from medical institutions, corporate sectors like Josna Oak, who is already doing, Sunil Singh, who is already doing a good work in rheumatology, health policy makers and patients and caregivers will strengthen all the aspects of rheumatology care. I think with this positive message, I conclude, and I thank all of you for listening to me patiently. Sorry for some minutes of time that I took more. Thank you, everyone.
Thank you, Dr. Bichele ma'am, for unlimited wisdom on limited resource settings and sharing your valuable experiences. I request our chairperson, Dr. B.G. Dharmanand sir, to felicitate our speaker. I request Dr. Ganu ma'am to receive felicitation on behalf of Dr. V.R. Joshi sir.
The organizers were very keen to have Dr. V.R. Joshi's address here, and we are very, very happy that he had consented to give this. One of his most illustrious students, Dr. Lata Bichele, also contributed in this particular session, to be chaired by President of IRA, Dr. Dharmanand. What a good combination, Suvarna Kanchan Yog. I think this is a very extremely auspicious way to start the conference, and I am very sure that people will appreciate this particular session.
Now we will invite Dr. Arvind Chopra sir for our next discussion on clinical research in office practice. Another fatherly figure and renowned personality in field of rheumatology. He is a consultant rheumatologist in Bharati Vidyapit Medical College and Hospital. He is consultant in Arthritis Research and Care Foundation Pune, Hermes Doctor House Pune. He is Chief Investigator Officer in Arthritis Clinical Drug Trial and in WHO Corporate Trial Bhigwan Pune. He is at present the ACR Master, American College of Rheumatology.
Thank you very much. Okay, these are all nice beginnings. So thank you very much. I wish I was looking like that, but I no longer look like that. But anyway, I don't know. I think I need to remove that photograph from the internet. I don't know how it gets downloaded. So thank you very much. I think it's a lovely morning, and I've decided to speak extempo. Just few slides to... I asked Nachiket last night, what do you want me to say? Do you want me to frighten people, or do you want me to really encourage them? Because I'm aware that my office practice is not different from your office practice. And if I can sort of make a tongue-in-the-cheek remark, what my colleagues and myself can achieve and what we achieved, everyone can achieve. But that doesn't happen. That doesn't happen actually, unfortunately. There are many reasons for it. Research. I'm sure that none of you have come to this meeting to hear about research. I'm very sure about it. I would like to ask you, how many of you actually maintain a clinical database? Please put your hands up. Good. That's very encouraging. Now, I'm aware, so I think I'm trying to save time for the organizer also, so trying to give crisp messages. We all see so many patients. We are overwhelmed with time. We are just overwhelmed with time. I understand that. Overwhelmed with patients. But I think we somehow lose opportunities in our clinical practice to seek answers to many questions about which we have no answer, or we do not have an answer which is relevant to our population. I think that's very fundamental. We can do it. And I think to seek answers, of course, empirical experience, in my experience, and when you say in my experience from this stage, nobody questions you, but that's not true actually. I think my experience is fine from a clinical perspective, but my experience should be backed up with data. Many years ago when I used to look like that, what you saw, and I went for my very first, I think, American Rheumatology meeting, there was one particular slide which has always stuck in my head, which I've never forgotten. There was somebody making a great research presentation. I'm talking about 25, 30 years back. The first slide that he put, it was a clinical subject. I think it was fibromyalgia, and I think the title was "The Emperor Wears No Clothes," something like that. But the first slide was, "In God we trust, but the data must show it." Now that's very American. We are Indians, we are emotional. We don't believe in that. We believe in God. That's very fine. So we can do it. All of us can. We got to go beyond just recording patients' names, gender, things like that. And I think the other part is that I'm to talk about office practice. Now I'm trying desperately to think of my office practice, which was about maybe 30 years ago. 20 years back, I must share with you that it was no longer an office practice, it was a team practice. And we evolved into a center. We evolved into a huge team. I alone couldn't have done what I've done if many of you have very kindly read my papers and things like that. But in office practice, what made me do, you need a mentor actually. You cannot do research without a mentor. You need mentors. Because most of us are clinicians, and I'm talking as a physician scientist, if you may so accept my saying, yes, I think I am proud to be a physician scientist. And every clinician can become a physician scientist. There's a question mark in each one of you, at least on your faces, if not inside you. And that's important. When I was selected for MD, and I'm from AFMC Pune, and I went to and I was the student to the Professor HOD. It was a privilege of the student, it doesn't matter now, but anybody who tops and who has all the merits used to be the Professor's HOD student. And my professor made me suffer. My HOD, late General A.R. Subramaniam, retired as Director General, fantastic physician, made me suffer for weeks and would not choose the subject for my MD thesis. Everything was torn, Chopra, go away. This is a routine. This is a routine. One day, in army, you just got to follow the order. You can't question your HOD. I know you also have that kind of a cult in the medical colleges, but army is army. So I told him, I said, "Sir, what exactly do you want me to do?" He said, "Whatever you have shown me now is routine. Academic merit is routine. You got to do something which others don't do." And I think that was the beginning of my research. And he gave me this subject, arthritis. You will work on polyarthritis. If I could cry, I would have cried, actually. And my parents, when I spoke to them, they said, "Why not? We suffer from aches and pains. Nobody bloody knows what to do with us. There are no answers, just painkillers. You should do it. If your professor said do it, do it." And that was the beginning. I want to share with you, yes. I can never thank him enough, because I never looked back. Because when I started reading the subject, there were just questions and questions and questions, whys and whats. And when I went for my fellowship to Australia, I found another great mentor. So, Professor John Edmonds did my fellowship. He said, "Go back and work with the community." Two things he told me, actually. He said, "If you want to be an effective rheumatologist, you must understand your community and address their problems. Don't sit in your air-conditioned clinics and think that you will know what the community wants. You can do it. You have done so well." And second thing that he told me was that stop following the West, Arvind. You must have your own functional instruments. And that was the beginning of my passion for hack, which I've never stopped. I must be having more than lakhs and lakhs of hack recorded for patients systematically from day one. I use hack to track my epidemiology programs in Big One and other villages. I think we'll skip that slide. I just want to shock you with some statistics as to what an office practice can achieve. And I'm sure there's nothing compared to what can be achieved. So in my center, we maintain a database from 1996. There's another thing which I learned in Australia. If you want to research, you must have a database. Today, in a short time, I have an access to about over 78,000 patients, initial, and maybe a couple of lakhs follow-up. You ask me a question, give me some time, I'll give you the database answer as it is in my community and my patients. I can look at my clinic, I can look at my epidemiology. I have a wonderful lab person who has maintained a database on all the lab work. She has a serum repository of how many years, I don't know. You bring a new kit, we can do it. We did CCP on our patients of 1990s and early 2000 when the kit came in, because we had the serum. We could answer so many questions. We could confirm to us that what we looked at seronegative RA, which was doubted on, so, it took years, was actually rheumatoid arthritis. But some of them were CCP positive. So these things, I'm just throwing little crumbs at you. This is not the time to throw crumbs, because all of you have come to learn. My good friends in general medicine and my friends, colleagues in rheumatology, I think maybe some other day I had a very nice session on a little bit of research with one of my monthly meetings in Pune. And there I only showed the research of my PhD students. Now I must share with you, my PhD students have actually worked on thesis sitting in my office and then later on the center. There's a lady who did 500 RA gynec examinations to answer my question, are we missing the reproductive tract infections, young women, rheumatoid? Find out. And she got a PhD for that. Another young lady took about 400 blood samples of rheumatoid arthritis patients. She's in Mayo Clinic today, and she defined the pharmacogenomics of methotrexate and answered the question, does methotrexate last? I know what literature says. And finally she said, "Sir, most of patients don't have any methotrexate detectable in the serum beyond 36 hours. Now, we may know all that from the books, but do we have the data? Do we know what our patients, and the pharmacogenomics, predicting toxicity, which we found was not possible, it doesn't work at the moment. So things like that. Another student, actually, a physiotherapist, came for PhD, and I said, I've always wondered how much non-pharmacological treatment, I've always wondered how much can that contribute to the success? How much it can add on to therapeutic success? Wonderful chap, physiotherapist, worked for 3 years. worked on something like 300 patients, randomized. Finally, went into a assessor blind. One group only getting what we do, rheumatologist, clinical practice, giving them medicine, whatever you want to give, and give them general advice. The other group getting the same, but structured modules on diet, physiotherapy, yoga, lifestyle, structured modules, which we validated. And you know the outcome? It was a great learning for me. There was at least a 30% addition to the success achieved by just disease modifying, just by therapy. 30% is not a small thing. There were so many on everything, whether it's pain, swelling, hack, quality of life, WHO, so many things. Now, that may not happen in our practice, but it made me remember that as a clinician, as a rheumatologist, we need to talk about non-pharmacological treatment of inflammatory arthritis, which we don't do. Another PhD student of mine, she came and said, I want to work on potassium in rheumatoid arthritis. I said, potassium? Never heard of potassium in rheumatoid arthritis. But she was so keen, full of energy. Sir, there are just hardly few papers, but I think potassium is useful in RA. She was a research scientist. She is a research scientist in England at the moment. Made me read. Found some logic. I said, okay, I'll take you as a student. Remarkable PhD. Just 4 years back, she got the best clinical research excellence award from the European Society of Research Scientists. So a lot of work is there on the internet. You can read the role of potassium in rheumatoid arthritis. Of course, remember, potassium comes from vegetarian diet. So what have I done in practice? All my fellows know it. For the last couple of years, every patient with rheumatoid arthritis, Shakari Jeevan Hitkaraka hai. Because potassium comes from fruits and vegetables. That's how your practice changes. My practice has changed because of all these things which I've not done everything. My colleagues, my fellows, of course, keep running away from my research madness. I must share with you. They don't want to do so much research, but I think they're inspired. Many of them are inspired out here. So I can keep on talking, but I mostly want to finish it off, and maybe when in the afternoon, when I talk on infections, I'll give a little glimpse of what the database is all about. So I think we'll skip those 2-3 slides. In fact, I told Dr. Ganu I don't want to use slides and all. She's given me a subject where I think I can talk for hours and hours, and I can take for 5 minutes actually, depending on what you want to know. So friends, you need mentor, you need inclination, you need a will, you need dedication, you need to sacrifice a lot of your, I would say, family time also. But a wonderful wife who doesn't mind my madness is important. You need some family support. And you need destiny, you need providence, you need, I don't mind saying, you need God by your side. It's great to do research, but it's fantastic to get success. And success is not what you get promised on day one when you do your research. Remember that. You don't get promised. But when success comes, you get inspired. Deep within. I personally feel a good research person doesn't need others to praise him or her. Research is like addiction. You can be in your research frame of mind for hours and not look at your mobile phone. That's what research is all about. It's a passion. And it has and lastly, let me finish with you. Before you all go back home thinking that fellow only done research, what kind of job does he do? But no. I'm equally proud of being a physician, a clinician. I've never, bread butter to wahi se aayega na, patient dekhenge tabhi to kamayenge. Where does the money come from for research? That I will only share with those who are really keen to do research and not waste time. Believe me, there's lots of money for research, good research. And you should also have a willpower to donate from your own funds. Doctors have no dearth of money, let me put it like that. So, thoda sa paisa apna jo kamate ho, research mein bhi dalo. To start with. Because when you're young, this needs a team. Finally remember, I don't want to sound fancy. People have worked with me, you need a team. As a single rheumatologist starting your rheumatology practice, you need somebody at least by your side. You need to pay him or her. A paramedic, and some kind of person who will help you to start your database. And lastly, because some of you are looking at me with, what next, I can see on your face. You can't do clinical research if you do gypsy practice. You know what gypsy practice is? Hopping from one place to the other. It's okay. In the beginning you can do that. But if some of my young friends here want to do good research, you need to settle down at one place and very humbly tell all who refer patients to you, those of my friends, I've got great friends in medicine, orthopedics, many of you know that. I have no problems with working with anyone. If they want my opinion, then I'm afraid I will not come to your hospital. You'll have to send your patient to my hospital. Because I need to grab that data. It's simple. You use me for one-time consult, no problem, but I must have my data. In my clinic, any patient who refuses to fill the clinical record form or the hack is not seen by me. You may be anybody. Ask my fellows, they know my rules of the game. So that is what research is. I don't know whether you wanted to hear all this nonsense, but this is perhaps what I can tell you all. So thank you very much, I think, and we have 1.5 days, and please, I mean, I would be most delighted to talk to any one of you on one-to-one basis if you have to ask me something or set up something. And finally, it's great to be here. MRACON has got roots now. I think I'm thankful to all of you. I just I nursed a mission dream for very many years that, like Dr. Joshi said in the introduction, very kind of him. But MRACON is here to stay for good. I can see that, and I'm so happy to see this meeting and getting us out of the COVID and things like that. So I'll be around to answer any very critical questions on any aspect of research, whether it's clinical, basic, fundamental. Please go ahead. I see my young friends are here, and they can talk to me. Thank you very much for giving me this opportunity.
Thank you, Doctor. I request Dr. P.R. Joshi sir to felicitate our chairperson for the wonderful support. We will move on our next session, and topic of debate and discussion is Basics Clinical History, Flags and Pattern by Dr. Niharika Gill ma'am. We request our chairperson, Dr. Golwalkar sir, Dr. Rai Boge sir and Dr. Alirkar sir to please share our support.
Sir. I had already sent it. कोई बात नहीं. MRACON होएगा. किधर है हाथ आशा. स्टार्ट कर दो मेरा पूरा.
राजेश सर फ्री है ना? हाँ, संगीत रहेगा ना. यस सर.
It's not the first slide. Yeah, the first slide. Yeah. Good morning, everybody, and thank you so much, Dr. Mukund Ray and Solapur and API Latur. I would like to dedicate this talk to my mentor, Dr. V.R. Joshi. I can only stand here because of him. Yeah. See, even with the advancements of your Google and the artificial intelligence, I don't think so anyone can replace in this era a guru. So with that, I start my lecture. Basics in Rheumatology, Clinical History, Flags and Pattern. The topic is very basic, but it took years to really understand rheumatology. So it's 15 minutes talk. I'm going to give you a little bit of history, the background, the approach, the flares and patterns, and points to remember. Rheuma is a Greek word. It means a substance which flows, a humor which originates in the brain and causes various ailments. And what we understand is arthritis is to the joint and rheumatism is for the whole body, raising that arthritis is one manifestation of systemic process. Bernard Comrie coined the term rheumatologist, and in 1949, Hollander used the term rheumatology. So rheumatology is as old as the independence of India, 1947. This is something around 1949. So it's quite a recent advancements. Now, what is rheumatology? It's a medical specialty which is devoted to the study of rheumatic and musculoskeletal disorders, which includes all types of inflammatory arthritis, autoimmune disorders, fibromyalgia, soft tissue rheumatism, and even your soft injuries and osteoporosis. Now, coming to the history taking, I think this is the most important in rheumatology, is the most important skill needed in rheumatology. A good history, is like a story. It can be powerful therapeutic experience for the patient and provides the physician 80% of the diagnostic information. What I've realized in my 25 years of practice, you have to be a patient listener and you should connect to the patient. And this is like when they're telling you to the story, it's like a catharsis for them. It's like they're getting rid of their pain. So listening is very important, and in a busy practice with corporate hospitals or in medical colleges, if you have 200 patients, you can't really listen to them. So this is what we lack when we have too many patients to attend to, which is seen more in Western world where they see 10 to 12 patients in a day. So they can do all these things what I'm going to talk theoretically. At the end of the clinical history taking, every physician must ask the patient the mandatory last question, is there anything else that you want me to know? And I'm telling you the clue lies in that last line. I treat this thing as like playing with a puzzle in a box, trying to fit into the problems of the patient. So this is a classical photographs which I put, you'll see in your busy rheumatology practice. Now, all the hands, they look very similar when you look at in one line, but when you really go into each patient, you'll find there's a different diagnosis to each of the hands shown in these photographs. So I like this word, which is this sentence, this is very, very important. The patient's history and physical examination are the cake. Lab and the x-rays are the frosting. You have got to bake the cake before you reach for the frosting. So it's like how we make our ingredients in a cooking, the same thing is for the arthritis. So now coming to the approach to patient with musculoskeletal pain, is first thing you have to find out, is it an articular or is it periarticular? Is it a non-inflammatory or inflammatory? Or whether it is just a one joint involvement or more than 1 to 3 joints or more than 5. Now the bedside approach is the 3 key points: origin of the pain, the nature of the disease, and the pattern recognition. I'll be speaking more on the pattern recognition. Now coming to the pattern, there are various types. One is the mode of onset, the duration, the number of joints, the distribution, extra-articular features, or the sequence of involvement. So mode of onset is whether it's acute or insidious. It's more common with your viral arthritis, crystal arthritis, where the onset is very, very acute. Duration is whether it's acute or self-limited or chronic. If you really see the old books, they always say, wait for 4 weeks to 6 weeks before you label the patient arthritis, because the viral arthritis generally disappear within a period of 4 weeks. Then comes your number of joints, which I told it's 1 joint or more than 1 and less than 3. Polyarthritis is more than 5. So depending on that, in my next slide, I will give you the examples. Now the distribution, is it symmetrical? Is it asymmetrical, whether it's involving the upper limb or the lower limb? Or does the patient have extra-articular features like the fever, skin lesions, eye involvement, or the lung or the kidney involvement? Then the sequence of involvement, intermittent, migratory, and additive. I think so everybody after passing the MBBS, we all know migratory, intermittent, all related to your rheumatic fever and the viral arthritis. Now coming to the diagnosis of identifying the site of pain. Every pain is not arthritis. So either is it coming from the bursa, is it coming from the tendon, the enthesitis, or it's a bone pain, or a muscle pain, or the fibromyalgia and growing pain. For all these things, there's always a clue about the patient's presentation. Arthritis will be a joint swelling and tenderness, which is deep-rooted, and it involves during both passive and active movements, while bursitis is a point tenderness over the anatomical site, more pain on active than passive movements. Tendon will be a tender swelling of the tendon sheath, and the pain increases with the stretching of the tendon. Then you have the enthesitis. It is where the tendon gets inserted to the bone, and bone pains are deep-seated, while muscle pains are more of diffuse, not well localized, which we see more with polymyositis and dermatomyositis. And fibromyalgias. Fibromyalgias to me is pain everywhere. You touch any part of the body and they are in pain. And these are the most difficult patients to treat in rheumatology, and each one we play what we call as badminton. You send to the psychiatrist will send you back. And that's what happens with the fibromyalgia patients. And then you have a growing pain. Growing pain is the pain seen in the growing children at the age of 8 to 14 when they are, increasing in their heights. Then differentiating between an inflammatory and a non-inflammatory. The most example or the key word of inflammatory arthritis is the pain and the early morning stiffness lasting for more than 30 minutes. The most example is the patient says that they have a difficulty in forming a fist. And you have the lab reports which shows a raised ESR or a CRP. While a non-inflammatory arthritis, most examples are the osteoarthritis, hypothyroidism, and there's hardly early morning stiffness, and the lab reports are basically negative. Then coming to the differentials as per the number of joints involved is 1 joint. Most common is septic arthritis and tuberculous arthritis. In India, please do not be in a haste to write that atypical presentation of rheumatoid arthritis because 1 single joint. Always try to rule out TB and TB. Once you have ruled out TB, then you can think of a monoarticular onset of a polyarticular disease. And oligoarthritis is more gout, juvenile idiopathic arthritis, psoriatic arthritis, and spondyloarthritis. Polyarthritis, the most common is rheumatoid, psoriatic arthritis, lupus, your scleroderma, adult onset stills, and IBD. Now, I'm going to spend some little extra time on spondyloarthritis. Why? These are the patients who are lost to the orthopedic department in a medical college or in private practice, because by the time the patient comes to a rheumatologist, they've already lost almost 8 to 10 years. So sometimes we pick up a spondyloarthropathy at the age of 60s and 65. And that time they expect some miracle by the rheumatologist, and the moment you say, I can't help you, they're really upset about it. So now they are divided into 2 types, spondyloarthropathy. One is the axial form and one is the peripheral thing. So this you can basically take from the history taking, whether it is the SI joint is involved or the peripheral large joints are involved. So what is spondyloarthropathy? It describes a complex group of rheumatic disease, and it is characterized by articular inflammation, erosions, and a new bone formation. That's how we differentiate rheumatoid arthritis from spondyloarthropathy. We don't see any new bone formation in a rheumatoid arthritis. Now spondyloarthritis, again axial and peripheral. Now coming to the ankylosing spondylitis, the classical symptoms which they complain of is a pain in the back and which is radiating to the buttocks, and the pain is shifting. Sometimes it's right side, sometimes left side, and the pain is so bad that it spoils their sleep. And if you notice, the REM sleep is disturbed in the middle of the night, they get up with severe pain. And that is the catch. And the other things what they complain is that they have pain while coughing and sneezing because of the rib cage involvement. So this is the classical AS. And what is the other thing? Because the sleep is disturbed, they're always complaining of fatigue all the time. And with pain, fatigue comes the depression. So that is why these young angst patients do require a little bit of counseling too. And not to forget the extra-articular manifestations. Your uveitis is very common with angst, IBD in Crohn's disease and ulcerative colitis is also very common, psoriasis, aortic insufficiency, pulmonary lesions and cardiac dysfunction and prostatitis. These are very, very common extra-articular manifestations of angst. Now clinical features is the inflammation of the SI joint, which can be picked up on MRI very, very earlier. Then come the psoriatic arthritis. Psoriatic arthritis, majority of the time, they are lost to the dermatologist because they are so much involved in their skin and the nails that they forget to ask about the joint pains, and which they, and the patients also, especially the females, I'm telling you, with my experience, they're more bothered about the skin lesions than their joint pains. So this is a classical patients of psoriatic arthritis. They present with pain, morning stiffness, limitation of movements, and arthritis mutilants are seen at the very fag end of their life. And it involves majority of all the big joints and the small joints. The difference is that it is asymmetrical and mainly involve the large joints. Then this is the classical difference between a psoriatic arthritis and a rheumatoid arthritis. If you look very carefully, the rheumatoid arthritis is more bilateral, symmetrical, involving the metacarpal bones, while a psoriatic is more like a asymmetrical, and you'll have a complete swelling of the whole finger, which we call as a dactylitis. Then now, psoriatic arthritis is also associated with metabolic syndromes now. So they are really prone to a lot of coronary artery disease and risk of strokes, risk of MI, and even hyperuricemia. These are the typical skin symptoms preceding. Sometimes the skin lesions come early and the joint lesions come after 10 years. So that is the reason they are majority of the times they are with the dermatologist. These are classical different types of psoriatic lesions of the skin. I'm not going to talk more on details in rheumatoid arthritis because the next speaker is going to speak about rheumatoid, so it'll just become a repetition. So I'll just stop here. Now look at this. This patient had just come to me almost 3 months back. If you look at the hand, as if you are really very senior, you say, oh, this is like a rheumatoid arthritis. But this lady, I just asked her one single question ki, do you want to tell me anything else? So she said, yeah, I'm suffering from cancer and I'm on some new drug. It is known as checkpoint inhibitors. So when I checked, the most common side effects of a checkpoint inhibitor is a polyarthritis. Now you have to convince the patient that don't stop your drugs for malignancy. I'll give you a painkiller, and if the pain is so serious or disability is there, then I will request your oncologist if they can have a different protocol for you. But I think so the patient was understanding. She said, okay, I'll continue with painkillers. I'll continue with my drugs for the malignancy. So that is the clue is there, that anything else you want to tell me. And sometimes patients think, why should I tell her? This is meant for my oncology doctor, not for a rheumatologist. And that's how we sometimes miss the diagnosis. It stopped? Oh, okay. Now coming to this is the closest diagnosis to your polyarthritis is lupus. So I would like to tell you lupus on the outside and lupus from inside. So what happens, the lupus from outside is basically goes to the skin specialist again, because they are going for their rashes and the skin lesions. And what is the rheumatologist worried about? They're worried about the organ involvement. The organ involvement means the pleura, the kidney, the heart, the bone marrow, and the brain. So this is what every lupus patient, even if they're not complaining of any organ involvement, you should be asking them about these organs. Now coming to the next is the systemic sclerosis, that is scleroderma. This is also patients who present with a diffuse skin thickening, and what is the majority of them will have Raynaud's phenomena, and majority of them will have interstitial lung disease. With the advancements of treatment, the survival rate has really improved. So this is a scleroderma picture. Now what I'm doing, I'm basically giving you more of pictures, because I always remember, sir used to always tell us, if the eyes have seen, the brain remembers. If the brain doesn't see, the eyes have never seen, so you'll be just doing theory. So this is exactly what I'm doing. I'm giving a little more of pictures so that you can, remember. Now this is what we always forget in Sjogren's syndrome, to look into the mouth. And they think it's meant for the dentist. No, it's for us too, for the dryness of the eyes and the mouth, so that the patients do not develop too many cavities. Then come the eyes. Even for eyes, if they don't have the joint involvement, they all go to the ophthalmologist. And if the ophthalmologist is basically a retina or a uveitis specialist, they do send the patient early to you. If they are not a specialist in that field, like a routine ophthalmologist, then this gets delayed. So this is now again, these are vasculitic ulcers seen with rheumatoid arthritis too, and they are lost to the surgeons, because they go on debridement, they go on playing with antibiotics till someone says, let's take a rheumatologist opinion whether it's a vasculitic ulcers. This is a classical pictures of gout. Now gout we don't see like this, because now it's become a screening for everybody, a serum uric acid. So we never see such pictures anymore. So take home message, a bilateral and symmetrical involvement of small and large joints is a classical RA. Exclusively inflammatory DIP involvement of the fingers with nail changes, psoriatic arthritis. If there's a bony enlargement of the second and the third MCP joints with restriction of the movements, think of hematocrotic arthropathy. If the MTP is involved, is most common is gouty attack. Peripheral arthritis with axial involvement is your spondyloarthropathy, IBD. And Sappho syndrome is synovitis, acne, pustulosis, hyperostosis, and osteitis. And RS3PE syndrome is a remitting seronegative symmetric synovitis with pitting edema. And this is the closest diagnosis of complex regional pain syndrome. If somebody comes with this, please rule out this condition. And when you have a bilateral symmetrical swelling of the hands, fingers, think of SS, MCTDs, lupus, and rheumatoid arthritis. And conclusion, it's a multidisciplinary approach is warranted, need for early diagnosis, effective communication between patient and doctor. That means you have to give time to your patients. Patient education by all the awareness program with Pichle Madam has already mentioned. Awareness in healthcare providers, what we are doing for the API, Solapur and Latur, appropriate use of medications, and continued exercise program and physical activity. Please do not exclude your physiotherapist and occupational therapist from your therapeutic protocol, because they are really, really important for improving your range of movements, prevents contractures, preventing wasting of the muscles. And the red flags in is the unexplained weight loss, unexplained fever, malignancy, neurological signs and symptoms, subtle anesthesia, bladder bowel dysfunctions. These are more common with your spondyloarthritis who are having a cauda equina syndrome, or patients with malignancy presenting. Most common is the leukemias. They present like a classical polyarthritis. Now, I cannot finish my whole of rheumatology in 15 minutes. So I suggest, it's a beautiful book written by Dr. Rohini Handa. I'm not selling for him. Please take it that, I'm saying it's a good book for, for the awareness for the physicians. Because this book, it takes at least 15 days to read, and I have to assemble everything in my 15 minutes talk, which is not very easy. And thank you so much for your patient listening. I tried my level best to be very concise in my presentation, just trying to tell what things you have to pick up and what you should not do. Means not to forget malignancies and all that. Okay, thank you so much.
I ask our audience if there are any questions. And also a chairperson to add any experience on the topic.
Thank you very much, Madam, for the lovely talk. All that I would like to emphasize is something that Madam already said. We have to bake the cake first. Most of the rheumatology tests like rheumatoid factor are false positive as well as false negative. Many of them like HLA-B27 do not necessarily mean arthritis being present. So finally, the history and examination is where most of the times the definitive diagnosis is made. Investigations at the end of it just confirm your diagnosis. Thank you very much.
Thank you, Dr. Niharika Gill, ma'am, for your advanced update and discussion on basic clinical history, flags and pattern. I request our chairperson, Dr. Golwalkar sir and Dr. Akerkar sir to felicitate our speaker. I call upon stage Dr. Suhas Pujar sir to felicitate our chairperson. We will move on to our next session of MRACON, rheumatoid arthritis. Our first topic is investigating rheumatoid arthritis by Dr. Rahish Ravindran. He's a consultant rheumatologist working in Thane, worked as assistant professor in CMC Vellore. He's a member of Takayasu Study Group, NHS UK, and Arthritis Support Foundation, Mumbai. I request our chairperson, Dr. Prasad sir, head of the medicine, VM Medical College, Dr. Rajesh Patil sir, and Dr. Milind Aurangabad sir for the topic to share the session.
To everybody here. First of all, I would like to thank the organizers, especially Mukund sir, for inviting me and giving me this opportunity to interact with you all. Now, you just heard a great talk by Niharika madam regarding what you see. So I'm going to talk about what you can't see and what you don't do. So it's a very important topic because somebody else is telling you. So you have to know whether to believe her or him and decide your treatment, or you really need to think more about what you get. So investigating rheumatoid arthritis. So we'll briefly talk about rheumatoid factor, anti-CCP, we call it as ACPA, inflammatory biomarkers like ESR and CRP, other biomarkers which may not be clinically useful but academically definitely very interesting. What are the systemic investigations and how to assess the risk in a long-standing rheumatoid arthritis. So rheumatoid factor, the most commonly used tests, we will discuss about that first. Biology and utility of measurement. Rheumatoid factor are antibodies directed against the Fc portion of the immunoglobulin G. They are found in around 75 to 80% of patients of RA at some time during their course of the disease. High titer rheumatoid factor is a relatively specific for diagnosis of RA in a context of chronic polyarthritis. So anybody who has a chronic polyarthritis and the rheumatoid factor is high titer, then it's most likely RA, unlikely to be anything else. Rheumatoid factor remains to be a very important test in diagnosing rheumatoid arthritis in spite of the presence of anti-CCP, what we call as ACPA. A small portion of patients eventually diagnosed with RA may be positive for rheumatoid factor but not for ACPA, especially in the early stages of the presentation. So we sometimes see patients coming to us with only anti-CCP sent by the primary care physician and not the rheumatoid factor. So it is very important that sometimes the ACPA can be negative and rheumatoid factor can be positive and vice versa, where the rheumatoid factor is negative and the ACPA is positive. So we'll come to that discussion later on in the lecture. High titer rheumatoid factor appears to be a better predictor for a severe disease course, showing a stronger correlation with extra-articular manifestations such as interstitial lung disease and vasculitis than appears to be the case with ACPA. So high titer rheumatoid factor makes the patient more prone for extra-articular manifestations like ILD and vasculitis. The presence of rheumatoid factor also increases the likelihood of a clinically significant response to rituximab after failure of tumor necrosis factor. So sometimes where we are in a position where the patient is having a very bad disease, we've been giving patients aggressive medications, DMARDs, now TNF, then we don't know what next. So if the patient has high titer RF, the chances that the patient would respond to rituximab is higher. RF has only moderate specificity. It may be present in other conditions other than RA. The rheumatic conditions where patients disorders associated with positive RF include rheumatoid factor. Obviously, a major chunk is rheumatoid arthritis patient. Sjogren's syndrome again can have rheumatoid factor positivity. MCTD, mixed cryoglobulinic type 1 and type 2 and type 3, SLE, polymyositis and dermatomyositis. These are the other rheumatological conditions where you can have rheumatoid factor positive. What are the conditions which are not rheumatological but still the rheumatoid factor is positive? Is age, like more than 60 years, 5 to 25% of the patients can have rheumatoid factor positive. Infections like bacterial endocarditis, hepatitis B, C, tuberculosis, leprosy, other parasitic diseases. Pulmonary diseases like sarcoid, IPF, silicosis, asbestosis. Sometimes you get confused with these things. There may be an occupational exposure causing an ILD and your rheumatoid factor comes positive. You start treating the patient as probably rheumatoid with ILD. So all these things needs to be kept in mind before you start your therapy. Miscellaneous diseases like primary biliary cholangitis, malignancies, and after multiple immunizations, patients may have a rheumatoid factor positive. So these are non-rheumatological conditions where rheumatoid factor is positive. Healthy individuals, rheumatoid factor can be found in up to 4% of young and healthy individuals. So many times patients do come to us कि sir office में test किया, आता rheumatoid factor positive आला तर काय करायचं? तो आम्ही विचारणार की तुम्हाला joint complaints वगैरे आहेत का? Patients says की काही problem नाही आहे मला. So healthy individuals मध्ये सुद्धा rheumatoid factor positive येऊ शकतो. The reported incidence may be higher in older subjects without rheumatic diseases, ranging from 3 to 25%. So it's a big number, like 25% of elderlies can have rheumatoid factor positive, and elderlies do come to you with some joint complaints here and there. So you have to be really careful when you decide whether to treat the patient or not treat the patient. What are the clinical uses of rheumatoid factor testing? RF is not useful as a screening test. We just discussed right now that sometimes it may be falsely positive also. So although rheumatoid factor may be found in circulation prior to the development of RA, most asymptomatic persons with positive rheumatoid factor do not progress to RA. As a result, the measurement of rheumatoid factor is a poor screening test. So most of the labs who do RF as a screening test in their packages are not supposed to be doing that unless and until a physician or a rheumatologist asks for it. So then the patient becomes confused, what to do with that positive test. Predictive and diagnostic value, the published sensitivity of rheumatoid factor in rheumatoid arthritis ranges from 26 to 90%. Rheumatoid factor quantification, higher the amount, the greater the likelihood that the patient has a rheumatic disease. There are, however, few exceptions. We've already discussed that, chronic inflammatory disorders, patients can have rheumatoid factor positive like tuberculosis. Further, the use of higher cutoffs for diagnosis decreases the sensitivity of the test as it is simultaneously increases the specificity. So if you see, always look for higher titer, the specificity improves but the sensitivity goes down. So one study was trying to look at, how higher titer cutoffs can help. So RF titer of 1:40 or greater was 28% sensitive and 87% specific for RA as compared to 1:640 or greater, which increases the specificity that you might not miss a rheumatoid, but there is no false positive test, but the sensitivity comes down to around 8%. So you have to keep the titers not very high as a cutoff. Treatment for RA can lower the level of rheumatoid factor, but such fluctuations do not reliably reflect the disease activity. So there are many physicians who keep on repeating the rheumatoid factor to see how the disease progression happens. So that doesn't make any sense, saying that the rheumatoid factor comes down but the patient could have active disease, or the patient still has a very high rheumatoid factor but the patient clinically is in remission. So repeating rheumatoid factors may not be ideal. RF may have some prognostic value with regards to disease manifestation and activity as well as severity of joint erosions. So seropositive RA, that is rheumatoid factor associated with positive rheumatoid arthritis with positive RF, if often associated with a more aggressive joint disease and is more commonly complicated by extra-articular manifestations than seronegative RA. Rheumatoid nodules and vasculitis occur most exclusively in seropositive patients. These findings are associated with increased mortality. So high rheumatoid factor with rheumatoid nodules and vasculitis shows a worse prognosis. Radiographic progression may be more rapid among patients with a positive rheumatoid factor at initial evaluation. So there was a study which looked at around 135 women with early RA, found that the patients with persistently positive rheumatoid factor had more erosions, nodules, extra-articular disease, functional disability and disease activity than seronegative or intermittently seronegative individuals over a mean period of 6 years of follow-up. So if the patient continues to have that very high rheumatoid factor throughout the course of your treatment, that means the patient in the long run may have to go for higher advanced therapies or more aggressive therapies. So a persistently high rheumatoid factor in a patient indicates that you need to be really on your toes and make sure that you treat the patient adequately and aggressively enough. The presence of rheumatoid factor, particularly high levels, may antedate the clinical development of RA. So but we have just discussed that rheumatoid factor positivity need not go to a clinical disease, but a very high titer rheumatoid factor definitely predates the development of clinical RA. Role of repeat testing we have already discussed. Repeat testing of rheumatoid factor may be useful if the patient's diagnosis remains uncertain. Sometimes initially you do the rheumatoid factor, sometimes it is negative. So if you want to really, clinically it looks very much like RA, you can do the repeat testing after some time. However, there is no clear benefit of serial testing, particularly in a patient with established RA. Sometimes the patient does the RA test on their own and they come to us saying that ki sir abhi bhi zyada hi hai, अजून खूप हाय आहे पण मला त्रास काही नाही आहे, तुमच्या औषधांनी हा कमी का होत नाही. So you have to explain the patient that rheumatoid factor may remain high or low, but doesn't mean that your clinical prognosis is bad. You are doing well, your other parameters are good, your medication requirement is low, so don't keep on testing the rheumatoid factor. In Sjogren's, sometimes the disappearance of a previously positive rheumatoid factor may herald the onset of lymphoma. This comes on long-term follow-up patients with Sjogren's where rheumatoid factor can be positive. RF titer may fall with effective treatment of RA in patients who are originally RF positive. The fluctuations in the level of rheumatoid factor does not correlate with disease activity. RF should not be used routinely to monitor RA disease activity in clinical practice. So very, very important. So don't keep on repeating the rheumatoid factors. There is no one technique which is better than the other, but automated techniques are much better rather than manual techniques. So try to stick to nephelometry or immunoturbidometry and ELISA. It tends to be more reproducible than manual method. So that latest agglutination and all those things, people come with just rheumatoid factor positivity, better not to stick to that and try to go for automated methods. Rheumatoid factor is patient specimens sometimes interfere with the measurement of other plasma components, including the IgM antibodies to infectious agents. Sometimes the other antibodies can come falsely positive or falsely negative sometimes if the patient is having a rheumatoid factor positivity. IgM RFs can also cause false positive results in point of care tests for IgM antibodies for SARS-CoV-2, the agent of coronavirus disease 2019, or in assays of inflammatory cytokines. So sometimes a patient who has rheumatoid factor positivity can cause false positive COVID test. Now we will come to ACPA or anti-CCP test. The testing for ACPA is useful for diagnostic evaluation of patients for RA. The sensitivity of ACPA assays for RA is around 50 to 75%. But depending upon the assay and study population, while the specificity is very, very high, it's usually over 90%. So ACPA is more specific than sensitive. Measurement of ACPA is useful in differential diagnosis of early polyarthritis because of relatively high specificity for rheumatoid arthritis of these antibodies. So if the ACPA is positive, you are fairly confident that you're probably dealing with a rheumatoid arthritis. A decrease in ACPA titers can be seen in patients treated effectively, particularly if treated early with non-biological or biological DMARDs, but is less frequent and of a lesser magnitude than the decrease in rheumatoid factor. So rheumatoid factor can come down on treatment with aggressive treatment. ACPA does come down, but not as fast or as effectively as rheumatoid factor. But as I said, there is no point in repeating the tests. It is just for academic information that it can fluctuate. So sometimes the patient may say ki rheumatoid factor आता कमी आलाय कधी वाढतो पण मला तसा काही त्रास नाहीये. So tell the patient that it can keep on fluctuating. With treatment it can come down. It can sometimes become negative also. That doesn't mean that rheumatoid factor is or the rheumatoid arthritis is cured. Okay, so sometimes they come and say ना आता rheumatoid factor negative आलाय काय करायचं औषध continue करायचं का? So you better tell them that you should be continuing with the therapy. So it doesn't really correlate. So how do you do the test? Basically, ELISA assay for ACPA, which has increased sensitivity for the assay of ACPA. These anti-CCP tests have become the principal commercially available assay kits for detection of ACPA. Basically, the arginine residues are replaced by the citrulline in the mixture of CCP. The newer generation assays, including the second generation CCP, the CCP2, have improved sensitivity and specificity compared to the previous CCP assays. Sensitivity for ACPA was around 67% and the newer CCP2, and the specificity has increased up to 96%. So that's quite a good test to have while you are looking for rheumatoid arthritis. Positive anti-CCP in other diseases, although ACPA is very specific for rheumatoid factor, it can occur in other diseases, sometimes several autoimmune rheumatic diseases, tuberculosis and some chronic lung diseases. So CCP positive doesn't mean that the patient should have rheumatoid arthritis, but yes, most likely you are dealing with rheumatoid arthritis and less likely that you are dealing with something else, but you should know that anti-CCP also can be positive in other diseases. Anti-CCP can be positive in lupus and primary systemic sclerosis and usually associated with deforming or erosive arthritis. Some experts suggest that the patients should be reclassified as lupus with RA and primary systemic sclerosis RA overlap syndrome. So sometimes you get RA factor positive, CCP positive, systemic sclerosis, SEL70 positive with dominantly scleroderma features, but then you can with erosive disease. So you can put them as an SS-RA overlap syndrome where CCP is positive. Okay, so that's very important. ACPA can also be found in around 8 to 16% of patients with psoriatic arthritis. They are most frequently found in patients with erosive or polyarticular disease, but may be present in patients with severe psoriasis in the absence of arthritis. Obviously, we will not ask for ACPA if the patient doesn't have arthritis, but yes, it does say that, you know, an increased prevalence of anti-CCP antibodies has been noted in tuberculosis. The rate in different studies range from 32 to 39% to low as 7%. Anti-CCP is not positive in hepatitis C infection. CCP-RA prognosis, CCP positive patients with early RA are at increased risk of joint damage. ACPA testing may predict erosive disease more effectively than rheumatoid factor. So, ACPA, higher titer ACPA shows that it is a more erosive disease. ACPA, positive ACPA also appears to predict an increased risk for radiographic progression in patients with early oligo or polyarthritis who are RF negative. This is not commercially available. It's a very good thing to know that, you know, anti-MCV antibodies, we don't have the test right now available commercially, which has very similar features to ACPA. Sometimes in the long run, suppose we don't have an ACPA RF positive, but clinically it looks like rheumatoid, the anti-VMA antibodies may help in the long run with very, very similar characteristics to anti-CCP. So, in patients with undiagnosed early inflammatory arthritis of established RA, the diagnostic and prognostic value of adding an MCV testing to CCP and RF remains uncertain, but then obviously clinically it says that the behavior is very much similar to CCP. ANA is another test which can be positive in rheumatoid arthritis. Also, it can be positive in 45% of patients with rheumatoid arthritis. So, if the ANA is positive, that doesn't mean that it is not RA, it is something else, or you have to keep on testing or looking for something else. But ANA can also be positive in rheumatoid arthritis, as with other autoimmune diseases. So, the main clinical biologically useful markers in patients with RA that aid in disease activity and predicting functional and radiographic outcomes include ESR and CRP that we commonly do. In patients with RA, ESR and CRP tend to be elevated both together or sometimes one at a time. There were studies which found that the two tests were discordant. Sometimes the ESR was high, the CRP was low. Sometimes the CRP was high, the ESR was low. But then both of them together predict a more aggressive or more active disease. So, ESR tends to correlate with disease activity in RA as well as disease severity and may be useful for monitoring the therapeutic response. Despite shortcomings, elevated ESR definitely says that probably the radiographic progression or erosive disease can be there in the patient of RA. CRP, assessment of CRP, we regularly do CRP on follow-ups just to see, you know, how the disease activity is. Radiological damage assessed by erosion counts in RA is more likely when the CRP and ESR are high. So, CRP can be done in stored samples unlike the ESR. So, ESR CRP higher titers are strong indications for radiological progression than CRP alone. Other investigational and other biomarkers, basically there are a lot of potential biomarkers which are immunological or genetic factors other than rheumatoid factor and ACPA. Acute phase reactants like ESR and CRP and other macromolecules which are tissue specific, I will come to that as well. Immunological abnormalities and antibodies, a lot of antibodies are subject to study in RA in addition to rheumatoid factor and ACPA, but may not be very routinely used in clinical practice, but it may help in the long run. So, particular interests are anti-P68, anti-RA3, antibodies to alpha endolase, antibodies to ferritin. So, these are all tests which can be useful in the long run, investigational methods. Genetic factors that influence the development and severity of RA include HLA class 2, shared epitope, MMP, matrix metalloproteinases, interleukin 10 promoter genotype and sulfur oxidation status. So, these are all basically academic interests, not clinically commercially available. Other acute phase markers are IL-6, acute phase response. IL-6 targeted biologicals are used in treating rheumatoid arthritis. IL-6 levels have not been found to correlate with radiographic progression in RA despite their close relationship to and acute phase response in rheumatoid arthritis. So, measurement of IL-6 in blood or synovial fluid is not useful in routine clinical practice, although interest in research remains. There are a lot of tissue specific markers which can be useful. Synovium specific markers like 14-3 eta, serum hyaluronan, matrix MMPs, MP1 and 3, elevated serum levels of immunoglobulin soluble receptors, Cartilage-specific markers like COMP and thrombospondin protein family in early RA. Combination of cartilage synovial biomarkers like MMP3 and CTX2. Bone-specific markers are useful in predicting the aggressiveness of the disease in the long run. But as I said, it's not commercially available of academic interest. Vascular markers like VEGF concentrations are elevated in RA. Plasma proteins, IL-6, IL-2, TNF, CC motif, CCL23, TGF alpha, 14-3 eta. So a lot of things, investigational biomarkers are useful. Other citrullinated antibodies other than CCP and what we saw as VMA, like anti-SA, citrullinated synthetic type 1, type 2 collagen peptides. So these are the basic markers. So basic, you have to focus on rheumatoid factor, anti-CCP, ANA, ESR and CRP. These are the 5 important things which are clinically available. There are many other markers which are investigational and academic interest which may come in the long run. But you have to be very careful about comorbidities and advanced complications. So any patient you are investigating for RA, long-standing RA, make sure that you are looking at the lipids, the sugars, the thyroid, the liver functions for treatment, creatinine levels, UPUC ratio, chest X-ray, cervical spine X-ray. So all these are very important in prognosticating the additional risk factors a patient with rheumatoid arthritis can have and what are the long-term complications of rheumatoid arthritis. Amyloidosis is very important. Sometimes we miss in long-standing rheumatoid arthritis. A clinical diagnosis of amyloidosis should be suspected if proteinuria, renal insufficiency or intractable diarrhea is present in a patient of a long-standing rheumatoid arthritis. Attention should also be paid to long-lasting and high inflammatory disease who had a very aggressive disease for a very long time. Renal involvement is very well-known complication of amyloidosis with rheumatoid arthritis. It is usually manifested as proteinuria or nephrotic syndrome with a variable degree of renal impairment that may go with end-stage kidney disease. So what are the take-home messages? Testing rheumatoid factor and ACPA together improves the sensitivity and specificity. So don't do only ACPA or don't do only rheumatoid factor. Better to do both so that pick up rheumatoid early. Always ask for automated quantitative methods rather than manual methods. Rheumatoid factor, ANA can be positive in other conditions also. ACPA can also be present in other conditions, but ACPA seems to be more specific for rheumatoid. Repeating rheumatoid factor and ACPA has no specific prognostic value, so don't keep on repeating the test while on follow-up. High titer rheumatoid factor and ACPA are associated with more erosive disease. ESR and CRP may sometimes be discordant, however, high ESR and CRP may indicate a more erosive disease. Investigating for comorbidities, complications should be done diligently and referred appropriately to the concerned specialties. Thank you very much for your patient listening. So I tried to cut short because of time constraints. So, but 5 things: rheumatoid factor, anti-CCP, ANA, CRP, ESR, and look for comorbidities and investigate appropriately.
Thank you, sir. Thank you for a very informative basic lecture. A very kind and humble request to respected speakers that because of time constraints and packed schedule, we a very gentle and humble request that please stick to the scheduled time of the talk. And I'm sure there are many questions among the audiences. Most of us don't practice rheumatology. We have so many questions on rheumatoid arthritis. There will be an open session of around 45 minutes to 1 hour at the end of the day where you can directly ask the questions to the concerned faculties, or you can write down the questions and give it to us, which will be given to them for the answers at the end of the day at around 5:30 p.m. So thank you.
Thank you, Dr. Rahish Ravindran sir, for your topic on investigating RA. I request our chairperson to felicitate sir. Moving to our next topic, rheumatoid arthritis management, I request Dr. Samir Rajadaksha sir to come on stage and share a few thoughts on the important topic. Sir is a consultant rheumatologist at Global Hospital, Seven Hills Hospital, SL Raheja Hospital. He has been a part of more than 30 CME as speaker and delegate. He has more than 13 research papers published in national and international conferences.
Thank you. Hello everyone, and I thank the organizers for inviting me. Without wasting further time, what I'm going to speak today is the management of rheumatoid arthritis. The topic itself is very vast. This will be more like a brief overview of what we do in the management of rheumatoid arthritis. So in rheumatoid arthritis, irreversible joint damage occurs very early in the course of the disease, and that is in the first 6 to 12 months. And within first 2 years, almost 70% of the patient will have developed erosions on their x-rays, and that's why we need to treat them very, very early. We can broadly divide the goals of therapy into short-term and long-term. Short-term is obviously to control the underlying inflammatory disease, alleviate pain, and restore patients' quality of life. But the long-term goals are preventing joint destruction and preventing comorbidities. Now in the 21st century, we really have some ambitious goals. You should consider RA as a medical emergency. You treat now, not later. And using our newer strategies, we aim for tight control and remission. The medications, last 20 years, we have a lot of new molecules which have come over for the treatment of RA, and you could divide the eras into a non-biologic era where you had NSAIDs and conventional DMARDs. Then after 1998, the biologic era started with anti-TNF, IL-6 inhibitors, rituximab, and now after 2017, we have the small molecules era, tofacitinib and baricitinib, and there are many more JAK inhibitors in the pipeline. When you speak about pharmacological interventions, you can divide it into simple analgesic like paracetamol, NSAIDs, COX-2 inhibitors, DMARDs, and corticosteroids. Now DMARDs, that is disease-modifying anti-rheumatic drugs, are very effective, and eventually most of the patient will require them. Now there is a lot of worry about patient because of the side effects of the medications, but untreated disease carries far more side effects than the side effects of the DMARDs. In fact, you use them early, it will reduce the use of NSAIDs and the attendant nephro and gastrotoxicity. So in the long run, early intervention really proves cost effective because it will prevent further joint replacement in the later life. A very brief slide about steroids. Again, steroids, a lot of stigma is associated with them. So low dose steroid and high dose steroids are different. And the use of steroids in early as well as established RA is different. So if you use a low dose steroid in early RA, it has a disease modifying potential, and we have to use this judiciously. The basic use is as a bridge therapy because the DMARDs take around 3 months to act. And once the DMARDs start acting, we try to taper and omit the steroids. Whenever we see a patient with rheumatoid, all the patients are not the same, and you really have to differentiate which patients require aggressive therapy and which patients you can be a more milder with the treatment. So remember these poor prognostic markers. So any patient who has high disease activity as per the composite measure in spite of your conventional DMARD therapy, elevated ESR, CRP, high swollen joint counts, high titer rheumatoid factor anti-CCP, presence of early erosions, and failure of 2 or more DMARDs. So these are the patients who are going to fare badly, and you have to be extra cautious in treating these patients with more aggressive therapy which is available in your armamentarium. Just like diabetes, dyslipidemia, where you have like a glycosylated hemoglobin, you have LDL, you have cholesterol, and you have definite endpoints to prevent further complications of diabetes and ischemic heart disease. In rheumatoid arthritis also we have what is known as treat to target principle. And you have a patient with RA, you adapt the therapy every 3 monthly to aim for remission, which is more commonly seen in patients who have disease of recent onset. But if someone has an established disease, then you aim for a low disease activity. Now DMARDs, when I studied DMARDs 20 years back, there was only methotrexate, sulfasalazine, but now you can broadly divide them into synthetic and biological DMARDs. Again, in synthetic DMARDs, you have conventional synthetic DMARDs and you have targeted synthetic DMARDs. While in biological DMARDs, you have biological originated DMARDs and you have biological similar DMARDs. So these are the conventional DMARD which we commonly use. This table shows methotrexate, leflunomide, sulfasalazine, hydroxychloroquine. You can use them as a monotherapy or in combination therapy. And the different doses are mentioned there. They are oral molecules. Side effects commonly with methotrexate and leflunomide are GI, liver, cytopenias. Now we come to biologics, and this is a slide which shows all the cytokines which are implicated in the pathogenesis. You have B cells, you have T cells, interleukins, TNF, and all the biologics basically they block a single cytokine. These are the common biological DMARDs which we have. So, anti-TNFs, everyone is aware of that. We have 5 anti-TNF, out which only 4 are available in the country. We have etanercept, adalimumab, golimumab, and infliximab. IL-6 inhibitor is tocilizumab. Sarovar is not available. We have rituximab. Abatacept was available, but it's no level available in the market, and anakinra is not available. So basically, these are all, these are all like magic bullets. Basically, these are designer drugs which are made for the treatment of these conditions. They are good molecules, but you have to be very careful with the adverse effects because they are potent molecules. Infections, TB reactivation are commonly things which you need to see when you treat these patients. These are checklists which we always keep before we start any patient on biologics. So apart from the routine screening, specifically look for latent TB, particularly in the Asian community like India. And apart from that, you screen for viral hepatitis. For rituximab, you also check for occult hep B and immunoglobulins. Tocilizumab, fasting lipids. And more importantly, you need to screen for heart failure, ILD, cancer, demyelinating disease, active infections. And based on that, you need to decide which biologic is appropriate for a particular patient. After biologics, so after we found out about biologics, so biologics are basically extracellular. Just like biologics, we have the JAK-STAT pathway, and JAK-STAT pathway is a common denominator for multiple cytokines. It's an intracellular pathway, and dysregulation of this pathway has been implemented in many other autoimmune conditions, including RA. There are 4 JAK isoforms, JAK1, 2, 3, and TYK2. This is how the cytokines are, and some of the homeostatic cytokines also are involved in this. So JAKs basically pair to form either homo or heterodimers, and this is a brief slide to show that. So these are targeted synthetic DMARDs. They target the intracellular enzymes. Unlike a biologic which targets a single cytokine, these are multiple cytokine signaling inhibitors. Advantage is they are oral dose, rapid onset of action, and a shorter half-life. So if you see how things are, on the left you have a on and off switch, that is like a biologic where you just switch on the cytokine, switch off the cytokine. But the JAK inhibitors are more like a dimmer switch. So they don't switch off the cytokines completely, they just dim it. And the last slide is probably in the future when you will have multiple cytokine inhibitors. That's not for today. So two JAK inhibitors are available, we all know because of COVID, tofacitinib and baricitinib. Tofacitinib is a JAK1, JAK3 inhibitor. You can use at 5 mg BD, and now we have the extended release preparation also. Baricitinib is again with 2 mg, that is the FDA approved dose, and 4 mg it is the European association dose. So the indications for JAK inhibitors that you can be, this is a revised indication. As per the latest guideline which we had, that was the ACR guideline, you could use either a biologic or a JAK inhibitor after conventional DMARD failure. But because of the oral surveillance trial data, it is now to be taken only after you have failed an anti-TNF or non-anti-TNF molecule. So previously JAKs were considered a viable second line option with moderate to high disease activity, but based on the revised indication, you have to wait for at least anti-cytokine, anti-TNF failure. So all the JAK inhibitors come with a box warning. So just because they are oral molecules does not mean they have less side effects. The side effects are at par with the biologics, and this is something which we all should know and tell the patient also to be careful. So serious infections, malignancies, and more importantly cardiovascular risk. So you have to screen these patients who are to go on a JAK inhibitor for MACE, particularly for past history of thrombosis, OCP use, COX-2 inhibitor use, obesity, prior history of deep vein thrombosis, family history of any hypercoagulable state. These things are specifically to be asked when you use a JAK inhibitor. Herpes zoster among other infections are very common, particularly patients who are also using steroids, more seen in the Asian population. So this is a summary of, I mean, a lot of recommendations keep on coming. No? Yeah. So the latest one we have the ACR, and all the recommendations say one thing, that you have to use methotrexate, which is the anchor drug for rheumatoid arthritis. If you cannot use methotrexate, then you can use other conventional DMARDs like leflunomide, sulfasalazine. And if you cannot use that, then only you move on to the higher therapies, like it could be a biologic or it could be a JAK inhibitor. So this is the recommendation if you want to go through it. MTX monotherapy is strongly recommended. In a resource poor country like India, we often use combination DMARDs if the patient is not affording for a biologic. But then we move on to either ideally a biologic, and if no biologic, then a JAK inhibitor. So oral methotrexate is conditionally recommended over subcute form, but once the dose goes above 15 milligrams, subcute methotrexate is a better drug. Always give folic acid with that, because that decreases the side effects of methotrexate. So biologics are expensive molecules, I mean, particularly in India, after the patient has attained low disease activity, continuing the molecule for a longer period of time is not an easy thing. So we are looking at different de-escalation regimes. So you start with inducing remission with whichever molecule you have, then you maintain the remission, and then you can think about reducing the immunosuppression. So always the first thing to be stopped is a steroid and an NSAID. Then as per the recommendation, you can reduce the methotrexate dose, but this is very difficult in India, where you have to reduce the biological dose. So either you can space the biological or you can go down on the dose. So for example, if someone is on etanercept 50 milligram weekly, you can go into fortnightly. So for different biologics with their different dosing regimens, you can gradually taper it. So tapering a biologic is always better than stopping it suddenly, because there will be a recurrence of the disease if you stop it suddenly. And you can consider a drug holiday. Infection risk is with all the drugs. It is lowest with the conventional synthetic DMARDs, and then abatacept, which is not available, but anti-TNFs, then JAKs, then IL-6, and the risk is highest with high-dose glucocorticoids. So in managing the joint manifestations of rheumatoid arthritis, we seldom require more than 10 milligram of oral prednisolone. Higher doses are required only when you have extra-articular manifestations in the form of ILD or vasculitis. So using low dose for the shortest period of time is very important. But having said all that, let's look the actual Indian scenario is. Again, in India, there is significant delay in the rheumatologist referral, and this results in very high disease activity. So in this study, only 4% of the patients who reached a rheumatologist had a good disease control. A lot of patients still take alternative therapy, and that's why there is radiological damage. So again, if you can look at this slide, so majority of the patient, 76% of the patients reach a rheumatologist after 6 months of disease onset, and the dose also is always less. There's another paper, again non-use or a suboptimal use of methotrexate, and even the same thing. The main reason for active disease in our country is non-use or a suboptimal use. Rheumatologists are not everywhere, so in clinical practice, if possible, where the rheumatology doctors are less and physicians are managing this, you should use a good dose of methotrexate for better results. So this was the present, and we are talking about artificial intelligence, so this will be the future. Now as of today, to choose a molecule for a particular patient is not easy, because we don't have effective biomarkers. But in the future, with all machine learning and like this trial, clinical response to adalimumab and etanercept, based on machine learning, where they can accurately say which drug for which patient will be the future. So what is the success mantra in today's age? Early referral and diagnosis, timely treatment, management by the rheumatologist if possible, treat to target principle, individualized treatment, regular follow-up, treat the comorbidity, and you have to adapt to the realities of clinical practice. That's it. Thank you. Any questions?
Any
questions we'll take at the end, right? Okay, thank you.
Thank you, Dr. Samir Raj, for your wonderful insight. I request our chairperson to felicitate our speaker. As a consultant rheumatologist in Ruby Hall Clinic, Pune Super Specialty Hospital, Pune.
Good afternoon, everyone. Thank you for organizers and all audience for having your time. So I'll be just rushing through few updates and few insight into past about how early we should be treating rheumatoid arthritis. So we often miss opportunities because it's dressed in overall and it looks like work. As sir said, 75% of patients reach to optimal care after 6 months. Whether this window is correct or not, we'll see. So, yeah. So till 2010, these were the criteria which guided us for making diagnosis of rheumatoid arthritis. So if you see, these were criteria defined by ACR in 1987, and almost 3 decades we continued to use this criteria to make us diagnosis of rheumatoid arthritis. If you see, most of the clinical criteria should persist for at least 6 weeks, then only you can make diagnosis of rheumatoid arthritis. And at that time only rheumatoid factor was available for diagnosis of arthritis, and in imaging only X-rays were available. Despite all this, it has sensitivity and specificity not at par, but if you see specificity 33 to 77%. So again, you can doubt your diagnosis back then. But once you have diagnosed it and once you initiate DMARDs, it makes difference to patient. If you see, if you start initiate DMARD early, significant proportion of patient will achieve remission over the period of time, and they will achieve remission early. As compared to if you initiate DMARDs late, they will achieve, the less proportion of patient will achieve remission, and the amount of time they will spend in active disease will be higher. So it was already recognized that we need to initiate DMARDs early, and with this, all the possible evidence that time available, it was realized that the amount of window of opportunity is 2 years, as I said, and by the time of 2 years, we should get patient into remission. This was back then in 1992, but with the first decade of century, we had a lot of development, especially for rheumatoid arthritis, in both in terms of diagnosis and treatment. So first one was development of anti-CCP antibody assays, and that changed a lot of things. So they have got more than 95% sensitivity, and they could detect almost 1/3 cases of rheumatoid arthritis in which rheumatoid factor was negative. Not only this, they could also predict the prognosis. So if someone is having anti-CCP titers, they can have very aggressive disease and they can land up into extra-articular rheumatoid arthritis if not treated and get into remission in early. I still think anti-CCP is not ordered free. It's underutilized in primary care setting, considering the high cost. But I think if you consider delay in diagnosis and cost of delay of diagnosis, it will be justified to order anti-CCP. If you are suspecting any arthritis, there is clear evidence of arthritis and rheumatoid factor is negative, anti-CCP must be ordered. So with the help of this, there was increasing need to define rheumatoid arthritis again, and in 2010 they came up with new criteria. Here they included anti-CCP, and now you can, with the help of this criteria, you can even diagnose rheumatoid arthritis before 6 weeks. You don't need to wait for 6 weeks to make diagnosis of rheumatoid arthritis. And not only this, this help to diagnose rheumatoid arthritis, especially in cases of undifferentiated rheumatoid arthritis or so-called seronegative arthritis where you could not label the diagnosis. And this helped us to initiate DMARDs early. So this is graph which shows, this is mean sharp score, which is indicator of a damage in rheumatoid arthritis. So just making diagnosis early by 2010 criteria makes, over the period of time, there is less damage compared to the older criteria. Same set of patient, just diagnosing it early makes that much difference, almost 50% reduction in radiological damage over the period of time. Not only this, as previous speaker suggested, there were development of newer molecules, and also not this, but the combination DMARD use strategies. And this was a landmark trial published in 2004, tight control of rheumatoid arthritis. So with the new development of drugs and combination DMARD, low disease activity and remission seems to be possible for almost 80% of rheumatoid arthritis cases. And here they tried to strategize the care of rheumatoid arthritis with respect to target, and the target was to achieve remission on the escalation of, with the help of escalation of DMARD with more objective target, and with this almost 80% patient could achieve remission by the end of 6 to 9 months. So as this is a repeat, I think a previous speaker has already shown this. So now in 2010, we want our patient to achieve remission by the end of 6 months, or at least low disease activity. That's the main targets. From the diagnosis till 6 months or 3 to 6 months, they should go into remission. So in 1992, it was 2 years. In 2010, it is 3 to 6 months. Now, few more years have passed on. And what is the future? So, this is real life scenario. 2 months back, 24-year-old male came to my clinic. He's an IT professional. He's asymptomatic, and he did anti-CCP. And that was more than 500. He came in panic. What should I do? I asked him, why do you do this test? And he said, my sister is having rheumatoid arthritis. And now I could not see how she is going through, and I don't want to go through that phase. What you can do for me? We'll just find out. So, to start with, an ounce of prevention is worth a pound of cure. That's the thing he wanted to us. I don't want to have any joint pain. Treat me right now. So let's see before going to answer his question. So there have been few recent development in defining preclinical stages of rheumatoid arthritis, and so genetic susceptibility and environmental challenges and triggers can really leads to immunological alteration, especially at mucosal sites in terms of microbiome, that is periodontitis or gut microbiome changes, which leads to antibody formation. And an individual spends some time in this phase for before onset of clinical disease, and that's how our patient in question was. So now the antibodies is positive, what should I do? And what are my chances of getting rheumatoid arthritis in future? So let's find out. So EULAR, there have been lot of research, and EULAR came in 2009 with a certain set of clinical criteria to screen these individuals who are at risk for rheumatoid arthritis. So these are very simple questions you can ask anyone within few seconds. So anyone having joint pain of recent onset, last 1 year, symptom localized mainly to small joints, metacarpophalangeal joints, duration of morning stiffness more than 60 minutes, more severe symptoms in the morning, and if you squeeze the metacarpophalangeal joint and there is the squeeze test is positive, then that individual is more likely to have development of rheumatoid arthritis in near future. And presence of first degree relative with rheumatoid arthritis is an also independent factor. So if someone asks you next time, what are my chances of having rheumatoid arthritis, my sister or brother is having, you can ask this question, simple questions. So apart from the clinical parameters, there are certain lab parameters. As I said, the antibodies detection can be there even before clinical onset of disease. So this is data from US veteran data. So they have gone back and from nested cohort, and they have tested antibody positivity back in date from the clinical onset of disease. And as you can see, antibodies including anti-CCPs can detect it up to almost 10 years before onset of disease. So what are these predictive value? So if you have anti-CCP positivity in first degree relative, at 5 years, his chance of getting rheumatoid arthritis is 65%. So that answers our first question. Then there are certain other predictors which can help us to predict this clinical onset of rheumatoid arthritis. Imaging in the form of ultrasound and MRI. Specifically tenosynovitis, which sometimes we ignore, oh, it's tenosynovitis, fine, it's nothing. But you have to take a whole picture into consideration. If someone's family is having rheumatoid, there is early morning stiffness or not, if the squeeze test is positive. And MRI detected synovial inflammation. This can really predict onset of rheumatoid arthritis in near future. Then some modifiable factors like smoking, obesity, and mucosal dysbiosis, especially in the form of periodontitis, can trigger this event. Sorry. So there are certain protective factors also. Some studies have shown mixed result. Omega-3 fatty acid consumption has been shown, not so consistently, but some studies have shown to be reduced risk of rheumatoid arthritis. Moderate amount of alcohol consumption helps to prevent rheumatoid arthritis, though we cannot recommend it. And longer breastfeeding time and higher parity is also shown to be protective. So what's the use of all this? Why we are discussing this? Can we prevent rheumatoid arthritis? That's the question. So there have been a lot of efforts. There have been almost many trials ongoing, and this is the recent one published in last month. They have used methotrexate in patient at risk of having rheumatoid arthritis. Here they have used methotrexate for 12 months, then they have stopped it, and placebo arm they haven't given anything. It delayed onset of rheumatoid arthritis, but ultimately patient got it. So still a negative trial, but it delayed onset of rheumatoid arthritis for 1 year more. And the MRI detected inflammation, functional ability, morning stiffness and pain was much less in this patient. Another trial, they have used given from one end to another end, biologics directly, rituximab. And again, it concluded same. It delayed onset of rheumatoid arthritis by 1 year. And in some patient up to 4 years, the clinical onset of disease. There have been other trials including abatacept, GM-CSF inhibitor, hydroxychloroquine and infliximab. More or less they have shown same thing. It is delaying the onset of rheumatoid arthritis, though strictly it's not preventing the cure. And I think we will need few more research study to get this answer clear. So as someone said, we always overestimate changes which will occur in next 2 years and underestimate changes which will happen in next 10 years. So let's hope for the prevention. So to summarize, making early diagnosis is important. Use of anti-CCP and imaging to make early diagnosis, especially in doubtful cases, is very helpful. We should target remission or low disease activity 3 to 6 months, and let's hope for the prevention. Thank you.
Thank you, Dr. Zawar sir, for your prompt discussion on early rheumatoid arthritis diagnosis. I request our chairperson to felicitate our speaker. Which needs to be highlighted in our everyday practice. I request Dr. Praveen Patil sir working in Pune. He has worked in prestigious hospitals like University College London, Royal Free College, Whipps Cross and Southend University Hospital.
Sorry. Hi. Am I audible? Hi, everyone. I would like to thank the organizer for inviting me to give this talk. Thank you, all of you, for joining today here in Solapur. So I've been asked to talk about managing rheumatoid arthritis in special situation. I had given quite a big topic to cover in 20 minutes. There was pregnancy, there was hepatitis, there was TB, and quite a lot. So after discussing with the organizer, I have decided I will be talking mainly two important things: pregnancy and rheumatoid arthritis, and perioperative management, because a lot of physicians, they've been asked to give the medical fitness before the surgery. So I think these two things should do justice for daily practice. So let's talk about pregnancy and rheumatoid arthritis. So there are many questions. Does rheumatoid arthritis affect fertility or pregnancy outcome? So this is an important question if you have a young patient coming to your clinic and asking this. So when is the best time to plan pregnancy? what happens to RA disease activity during pregnancy? Should we test for anti-Rho and anti-La antibodies in patients with rheumatoid arthritis? What are the guidelines? Can male patients with rheumatoid arthritis continue methotrexate or other DMARDs? Does sulfasalazine cause infertility? Can we use NSAIDs during pregnancy? Which is the preferred biologic therapy during pregnancy? So these are the questions we'll try to answer in next few minutes. So rheumatoid arthritis and pregnancy. Most women with RA can have enjoyable and successful pregnancy. So we should be encouraging when they first time come to us and discuss about this. There is a lot of data supporting that a well-controlled RA has a good outcome and as good as the normal population. So the risk associated with RA is not significantly greater than the normal population if it is well controlled. So fertility again is not affected per se by RA if it is well controlled. So how to assess whether your patient is ready for pregnancy? So what is the best time? So planning ahead is the key. I tell my patient that I should be the second person to know if they are pregnant. So this is very important to emphasize right from day one, that it should be a planned pregnancy. Plan when disease is not active. The patient should be in remission for at least 6 months. Methotrexate and leflunomide should be stopped well in advance. We'll talk about the drugs in pregnancy, and folic acid should be there right from the planning stage. So we all worry about the harmful effects of RA drugs, but at the same time, we should be aware of the effects of uncontrolled RA on the fetus. So this is published just last month, a large data suggesting that preterm delivery and flares occurred more frequently on the discontinuation of biologics DMARDs at the positive pregnancy test. Many times, patients themselves, they stop the moment they see a positive pregnancy test. And so stopping the drug was associated with the preterm delivery and the flares. So what happens to RA disease activity during pregnancy? So this keeps changing data. Earlier we used to believe that most of them, they go into remission. But the recent data is suggesting that around 50% or so, they go into remission. So there is significant number of patients, they pose a challenge for us when we treating them for rheumatoid arthritis during pregnancy. Again, this is another paper published last month that the disease activity rather than the treatment is a risk factor for the preterm delivery and the small gestational age. So postpartum flare, so again all the treating physician should be aware that 6 weeks after the delivery is the time. So this is the time की gynecologist लोकांचे पेढे वगैरे खाऊन झालेत, सगळं झालंय, patient is at home and then they start flaring and then the patients, and it is very bad because I've seen patients going into depression and because they cannot hold their child due to arthritis, and so you should be aware of which drugs we can use during this time. So the treatment flares during pregnancy. So rheumatoid arthritis flares can be managed with low dose steroids, oral or intramuscular. There are DMARDs which we can use. NSAIDs. So all NSAIDs are contraindicated in the 3rd trimester. You should be aware of this. Do you know why? Why we can't use NSAID in the 3rd trimester? Okay, so we'll come to that. Oops. Okay, COX-2 inhibitors should be avoided throughout the pregnancy, and we should use the short-acting NSAIDs like say ibuprofen if we want to manage the pain during 1st and 2nd trimester. So next few slides will be based on this, so I won't be providing references for each point. So this is 2020 ACR guideline for management of patients with rheumatic diseases in the context of pregnancy. So they have provided the guideline for the ART as well. So say your patient is going for IVF or embryo transfer or various these fancy things. So the bottom line is very simple. You can continue with the pregnancy compatible medication. So throughout this ART process, continue with the DMARDs which are compatible with the pregnancy. Should we test for anti-Rho and anti-La antibodies? So we have rheumatologists and physicians. So I would like to ask, how many of you test for anti-Rho and antibody in a patient with rheumatoid arthritis planning pregnancy? Okay. Very few. Okay, very few. So till I read the guideline, I was not testing as well, so I must admit that. I will be testing from tomorrow. So yes, it is mandatory as per this ACR guidelines that, see, the logic behind is, if they have a very good paper where they looked at the congenital heart block data. And then when they looked at more than 50%, so they have this term autoimmune congenital heart block syndrome. So more than 50% were completely asymptomatic. They retrospectively looked at their antibodies and they were positive. So congenital heart block can be the only and the first presentation of the autoimmune disease. So that's why those who have a high risk of developing this should be tested for antibodies. So this is, I have copied this so to support my argument, that there they mention that SLE or SLE-like disorder, Sjogren's, scleroderma and RA, they all should be tested. Repeat testing is not advised for Roux and La. So if your antibodies are positive but no history of congenital heart block, serial fetal echocardiography is advised every 2 weeks from 16 to 26 weeks. If there is a prior history of congenital heart block, then they need weekly echo from 16 to 26 weeks. So if they have first degree heart block, then the idea is to try to give some medications that can prevent the development of complete heart block. So male patients with RA, now it is very well established that male patients can take the medications, all the DMARDs except cyclophosphamide, all of them they can take these medications, so it is not contraindicated. How about sulfasalazine? Does sulfasalazine cause infertility?
Yes.
Okay. So the word is subfertility. So this is the study. The problem with sulfasalazine is all the studies are really old, like they are from 1980s to 1990s. But there is enough evidence to suggest that sulfasalazine causes reversible oligospermia. So all these effects are reversible within 3 months of stopping sulfasalazine. So if you have male patients on RA on sulfasalazine, so this is to be aware of. So which of the following medications are safe during pregnancy? Which of the following medication is not safe during pregnancy? All are safe. Okay, that was a tricky question. So yes, all are safe. I don't know why they put colchicine there, but it is there in their table. But all these medications are safe during pregnancy, breastfeeding, preconception. So hydroxychloroquine, sulfasalazine, tacrolimus is something can be used for rheumatoid arthritis, particularly in this sort of situation where you are running out of options. So NSAIDs and pregnancy, we did discuss that we shouldn't use NSAIDs particularly in the third trimester. Remember the first one, preconception stage, they have mentioned discontinue if they are having difficulty in conceiving. So there is a problem with NSAIDs. It can cause it can cause a syndrome. I don't remember that. Basically, it interferes with the ovulation. So if you have a patient who is having difficulty in conceiving and they are on NSAIDs, particularly our Angspont patient, then you may want to discontinue that. And in the third trimester is the risk of premature closure of ductus arteriosus. So earlier I was asking you, why do you want to stop NSAIDs in the third trimester? So biologics and pregnancy. So which of the following biologics are safe during pregnancy? So this is not that tricky question earlier, all of it. So we have to decide individually. So certolizumab is the biologic for pregnancy. Unfortunately, it is not available in India. We'll talk more about that. But tocilizumab is something which works very fast and can be used wisely because it can be used to the point of conception, and then you don't continue that. So sometime you have a patient who have very high disease activity and they are planning to get pregnant in next few months time. I do use tocilizumab. Then there are other medications. Rituximab you shouldn't use unless there is a life-threatening situation. Most anti-TNF are safe during pregnancy till 2nd trimester. So you don't want to use them in the 3rd trimester. So which is the preferred anti-TNF during pregnancy? Adalimumab, okay. Anyone? Okay, correct, etanercept. So we'll talk about that. So the use of anti-TNF during pregnancy. So majority of the biologics, they contain this FC IgG1 construct, and this facilitate the transfer of these antibodies across the placenta during the 3rd trimester. That's why it results in the increased risk of neonatal infection. So placental transfer of certolizumab and etanercept is relatively low. So the transfer occurs in the 3rd trimester. That's why we can use it up to 2nd trimester. But in the 3rd trimester, if we are pushed against the wall, then etanercept is something you can use that is relatively safe. But certolizumab is definitely safe. Certolizumab is the pegylated antibody. It lacks the FC construct IgG1, and there are some reports showing that they have found traces of certolizumab in the neonatal blood, but that is believed due to the passive diffusion rather than the active placental transfer. So certolizumab is the first anti-TNF drug approved for the use both during pregnancy and breastfeeding. So steroids in pregnancy. So usually there is no issue for using steroids in pregnancy. We can use high doses steroids as well. This guideline have tried to answer that the stress dose glucocorticoid, they conditionally recommend if patient is going for surgical delivery, like say C-section. So you can decide about that. JAK inhibitors and pregnancy. So these are small molecules, they can pass easily, so we are not going to use them during the pregnancy. So they and we don't have much data, so they are contraindicated for all practical purposes for now. So DMARDs not compatible with pregnancy. We know about methotrexate, leflunomide, and the small molecules. So remember about leflunomide here to all our physician friends who would like to inform. I know there are a lot of orthopedic surgeons, they don't believe in guidelines or they don't discriminate pregnant, not pregnant, planning, not planning. But at least we can agree on this. Leflunomide can remain in the system for a very long period of time. This is the quote from the guideline that it can remain in the system for 24 months. Okay. So if you have a young female patient, you need to discuss with them about their plans for pregnancy. And we can't do serum leflunomide level in India. The other day I tried to find a lot. I asked at least 10 labs and not available unless someone knows where it is, where it can be done. So what they do is there, if patient had exposure to leflunomide, they give cholestyramine washout and then they check leflunomide levels. And if their level is still significantly high, they repeat the washout till the level is undetectable. So do not use methotrexate, stop well in advance. Leflunomide should be stopped at least 2 years in advance if patient is planning pregnancy. So lactation, which anti-TNF can be used during breastfeeding? So all anti-TNF are compatible with breastfeeding, and then these DMARDs can be used as well, hydroxychloroquine, sulfasalazine, and rituximab can be given as well during breastfeeding. Prednisolone, try to keep the dose less than 20 milligram, no problem. If patient is on more than 20 milligram prednisolone, then you need to delay the breastfeeding for 4 hours or the discard breast milk which is accumulated during this time. And again, methotrexate is not recommended. It may accumulate in the neonatal tissue. I know there are some arguments that it is given once a week and can be used, but this is what the guideline tells us. So perioperative management of RA. So this is designed by the rheumatologist, orthopedic surgeon, and ID specialist. The idea is to balance the risk between perioperative infection and the risk of disease flare. So which DMARD should be stopped? So the practice varies a lot about this. I have seen this. Depends on the mood on that day, which DMARD is stopped. So which is stopped? Which one do you stop? They don't discriminate, I told you. Correct. So all these DMARDs, methotrexate, sulfasalazine, hydroxychloroquine and leflunomide should be continued throughout surgery. So pre-op, during op, post-op, so continue. Okay. So no contraindication for continuing these drugs. They are long-acting anyway, so stopping just a week before I don't think makes much difference. How about biologics? How long do you hold the biologics and when do you start? Okay, so one dosing cycle interval basically. So say you are using adalimumab every 2 weeks. So wait for 2 weeks and get the surgery done in the 3rd week. So after stopping the biologic, wait for one dosing interval. So say you had given infliximab, then you have given only one dose of infliximab, then wait for the 4 weeks. Okay, and see if they have been having every 8 weekly infliximab, then you have to wait for 9 weeks. So in the next week you can get it done. So this is how it works for all the biologics. So similarly for tocilizumab, if they are having monthly, then wait for a month. How long will you withhold JAK inhibitor? Any guess for the JAK inhibitor? They are short acting, right? Very fast. So earlier the guidelines suggested 7 days. Okay, but this guideline got updated July 2022. So this is 4 days. Okay, so 3 days and you can do the surgery on the 4 days, 4th day basically. Okay, so they are fast acting, so that is another advantage that it can be stopped. About safety, when do you restart? So if they are on the conventional DMARDs, no question of restarting, you are going to continue that, right? So say their biologic was stopped or say JAK inhibitor was stopped, when will you restart? Okay, so the guidelines suggest that 14 days or when you see the signs of wound healing. Okay, so when the sutures are out, practically 2 weeks is something you would consider in your mind. So continue the daily dose of glucocorticoid. Say your patient is on low dose steroids, they conditionally recommend giving the supraphysiological dose, like the doubling of the dose to avoid the stress of the surgery. Remember, the prednisolone is one drug which is highly associated with post-op infection risk. Again, this is the paper suggesting that prednisolone more than 10 milligram is the biggest risk for post-op infection. So if you are a physician, you've been asked for medical fitness for the orthopedic surgery or any surgery for that matter, please look at whether patient has active RA and avoid the elective surgery if possible. Performing surgery during active disease can lead to increased risk of infection. Check ESR, CRP, that can give you some clues whether disease is active or not, and make sure patient is on prednisolone less than 10 milligram. If patient is more than 10 milligram of prednisolone, then wait till you manage to reduce the dose. Okay, I think I'm coming to the last slide. Okay, so take home message. So RA pregnancy, planning ahead is the key. Check anti-Ro, anti-La antibodies. Sulfasalazine can cause reversible oligospermia. Avoid any NSAIDs during the 3rd trimester. Placental transfer of certolizumab and etanercept is relatively low. If patient is lactating and more than 20 milligram of prednisolone, delay breastfeeding by 4 hours. Continue DMARDs, the conventional DMARDs during elective surgery. Biologics, plan surgery after the end of dose interval. JAK inhibitors, wait for 3 days and restart the medications which you were put on hold after 14 days or at the sign of wound healing. Thank you.
Thank you, Dr. Praveen Patil, sir, for important insights on treatment and management. I request our chairperson to felicite our speaker. Ravindra Kundeli sir to felicitate our chairperson. Next session to Dr. Anjali Shivpunjay ma'am.
Thank you, Dr. Asim. Now we move on to our prestigious presidential oration, which will be delivered by MRA President, Dr. Shubhda Kalke Madam. She is a physician and consultant rheumatologist in Mumbai. She has presented many papers and publications in the renowned national and international journals. She has a chapter on polymyalgia rheumatica in Oxford textbook of rheumatology, chapter on septic arthritis in Manual of Rheumatology. She has got special interest in spondyloarthropathy and myositis. I request Madam to please come on the dais. And to chair the session, may I call on stage Dr. Arvind Chopra sir and Dr. Rohini Samant Madam. I hand over to the chairpersons.
The most exciting thing in my career is just thinking. It's a community outreach.
Should I start?
What about your introduction?
No, introduction is already given. Thank you.
She's well known. Doesn't need any introduction. Yes, sure.
Good afternoon, friends and colleagues and chairpersons. It is an honor to deliver oration at such an august gathering of MRA. I am grateful and I am standing here because of my mentor, Dr. V.R. Joshi, and my colleagues, you all, and Dr. Kaushik Bhojani especially. I have chosen a common and yet uncommon topic. I hope it is thought-provoking. Differential diagnosis of gluteal pain can be very challenging. Pain may originate around and within bony ring of pelvis from lumbar spine to pubic symphysis. Bones, muscles, bursae, tendons, ligaments, fascia, nerves and all intra-abdominal organs are all nociceptive structures causing pain. History can be very non-specific. Pain originating from lumbar spine may be the commonest. You can say this is the crux of my presentation. Pain originating from lumbar spine is very commonly felt in the buttock. The nerve roots from L3 to S2 refer into the buttock. There are many causes of buttock pain apart from lumbar spine. We generally tend to presume radiating pain is due to sciatica, but it is not necessary. So muscles, myofascia and trigger points can all do that. The sciatic nerve has more risk of tethering outside the lumbar spine and deep gluteal muscle. Back pain and knee pain may be because of gluteal weakness and buttock pain. Just because patient has chronic pain doesn't mean there is a psychological issue. Whenever we are evaluating gluteal pain, it is considered as a part of hip evaluation. And anterior hip pain is usually due to hip joint problems. Lateral hip pain covers mostly greater trochanteric pain syndromes and mainly trochanteric bursitis and gluteal tendinopathy. And posterior hip pain can be because of sacroiliac joint, proximal hamstring tendinopathies, and deep gluteal syndromes and ischiofemoral syndromes. There is an unending list of the diagnosis of different types of gluteal pain. There are important causes and some red flags here. Most of them are easy to diagnose on MRI, so I am not going to consider them beyond these slides. So first is inflammatory arthropathy, and we have a big session after this on that. Hip pathologies, coccydynia, osteitis condensa, lumbar disc and facet joint, intra-abdominal pathologies, malignancies, infections and fracture. And you all are well versed to diagnose it. So we will be discussing the first few causes in this list. Gluteal amnesia and dead bird syndrome, degenerative and disc and facet joint, quadratus lumborum syndrome, myofascial pain syndromes. Sometimes there can be sciatica, but pain additionally can be outside sciatica as well, and it is common to have both of them. Deep gluteal syndromes and gluteal tendinopathies, sarcopenia. Wallet neuritis, as the name suggests, is a pressure of the fat wallet, or it is even called credit carditis, and causing gluteal numbness. I thought that was quite interesting terminology. Lotus neuropathy is a lotus position in yoga. If it is kept for a long time, you can get numbness and even foot drop. Post-injectional gluteal neuropathy is quite rare. I am going to present the commonest scenarios in our daily OPD, whether it is physician, rheumatologist or orthopedics. 80-year-old female presenting with low back pain on prolonged sitting, it's more of a stiffness, knee pain after walking on and off, heaviness and stiffness in the thighs, able to do household activities the whole day, walks for 2 kilometers a day, swims for 30 minutes 3 times a week. In 2004, there is history of facet joint injection and edema for edema on MRI, as there was no response to NSAIDs. In 2012, there was pain and inflammation in the knees with meniscal tear, and again she had bilateral knee injection as there was no response to NSAIDs. Has been doing regular exercises for knees and spine, clinically bilateral varus, no tenderness or swelling. Now additionally, she had bilateral gluteal weakness left more than right, and her tensor fascia lata was tight and tender bilaterally. These are her X-rays which show degenerative changes in the knees and spine. Her X-ray knees have not deteriorated since 2012. Points to note that she is doing almost normal activity for her age. We'll all pass off this problem as age related. She is regular with exercises, but her disability has definitely increased, and she improved with corrective physiotherapy. Next patient is a 70-year-old male, known diabetic, hypertensive and ischemic heart disease, history of sciatica 7 years back, recent knee joint pains for about 6 months, feeling tired, not wanting to walk, cannot get up from low chair. On examination, there is a patellofemoral grade. There is no swelling or tenderness. Single leg stand needs support. Unable to get up without support from chair. No gluteal pain. Seen ortho, advise knee replacement. In fact, I wanted to video the gross weakness. He improved with physio by the time I decided to present him here. You will agree that elderly patients with back and knee issues are very common. In both these cases, patients do have knee and back issue, but the gluteal weakness is gross, and that is the major culprit for their problem. Both are much better with corrective physiotherapy, and we mostly tend to label them as degenerative problems. So coming to gluteal weakness, gluteus medius plays a very important role in several functional activities as a primary hip abductor. It provides pelvic stabilization and controlling the hip adduction and internal rotation. Weakness can give rise to variety of disorders, and mind you, not only hip, back and ankle, knees, everywhere. Gluteal medius works with tensor fascia lata as a hip abductor. So when one is weak, the other tends to overuse. So in the first case, we have seen the tensor fascia lata was tight when the gluteus medius was weak. And this is called synergistic dominance, and compensatory movements occur. Weakness in the gluteal muscles can lead to irritation of the gluteal tendons, causing gluteal tendinopathy. Lateral instability and impaired lumbar spine lateral flexion or pelvic tilt can cause compensatory activation of quadratus lumborum, causing pain. Hip abduction or gluteal strengthening exercises may improve the physical function and abnormal movement patterns. Next patient is an 11-year-old boy with difficulty in walking and getting up since 6 months. Clinically, there was a proximal muscle weakness in lower limbs. This happened typically in the pandemic, and when he had to go to school after that, he just couldn't walk. Investigated for primary muscle disease, and all the workup was negative. Diagnosed as gluteal amnesia and treated with physio, recovered well. So now we are dealing with one diagnosis every time. Gluteal amnesia, if you look at the literature, it doesn't exist in PubMed or UBC online library. Google Scholar also shows very few studies and quotes from private fitness and rehab professional website. If you look at the studies, gluteal muscle strength seem to have minor relevance to normal functioning. When a patient presents with pain in hip, pelvis and low back, alterations in the posture, gait and strength may occur. But this is more likely as the person is in pain rather than causing pain. So from the studies, gluteal amnesia seems to be a misnomer. Nothing has proven that the brain has switched off or anything of that sort. Needs a lot of research. But what we do know that when patients sit for a long time, there is definitely gluteal function which is affected. Some people say that there is because the short hip flexors become short, and that's why the biomechanic changes. For whatever reason, it has become and it is becoming very important, as many patients are, as you know, are working from home for more than 12 hours on computer and so on. Next patient is a 55-year-old female. 1992 had low back pain with radiation, diagnosed as prolapsed disc at L4-5 and L5-S1 level. Mind you, that time there was no MRI in Mumbai. It was diagnosed on CT. Now we can't imagine. 1998, there was a history of L5 sensory loss with quadriceps weakness on the right side, recovered with local steroid injection and conservative treatment. But bilateral gluteal and leg pains persisted. Intermittently, there were acute episodes of low back pain treated with physio, diagnosed as sacral torsion, ligamental sprains, quadratus lumborum spasm, piriformis syndromes. There was history of neuropathic pain. In 2015, she underwent lumbar decompression surgery at L4-5 and L5-S1 level, despite no major compression or MRI. But at the time of surgery, there were lot of adhesions and lot of fibrosis was seen around the nerves during surgery. Recovered after significant rehabilitation, but bilateral gluteal pains and leg pains persisted on prolonged sitting and walking for 1 kilometer. But no relief in gluteal pains again. She continued getting intermittent back pain with QL spasm on exertion. In December 2019, gluteal pain worsened with radiating to lateral and front of the hip. There was locking of the hip, back pain, heaviness and in the legs after walking less than 3/4 of a kilometer. Repeat MRI showed a disc bulge with facet joint hypertrophy and edema and some indentation on L4-5 exiting nerve roots. There was partial relief on nerve root and facet joint injections. In March 2021, there was a severe back pain, shooting pain on just looking down to look at the keyboard of the computer. You will appreciate you can see the red line which shows the compression of the spinal canal. It was more than 50% at L3-4 disc level, and there was also significant bilateral facet hypertrophy with edema. There was grade 1 anterolisthesis and there was a severe lateral recess narrowing causing compression of L4 nerve root. The next image next to that, you can see how spinal canal recovered after surgery. But even then, after surgery, she could walk barely 50 steps, and that's why the next MRI was done. It showed recovery from the compression symptoms, but there were a lot of inflammatory changes in and around the spine and in the soft tissues. Improved gradually as the inflammation reduced, but there was increased stiffness in the back muscle, hip, gluteal, leg pains, weakness persisted. After a lot of rehabilitation, she improved, walks about 2 kilometers a day, swimming. Gluteal pains are better, but sitting and walking is limited. So now we are coming to all these causes. We have seen the disc causing the problem and the facets. I am going to present, because mechanical back pain is common and dustbin diagnosis for all of us. We don't want to see further, and we want to pass on the baton to somebody else. Why it is important is that up to 80% of patients will see physician at least once in the lifetime. It is the second most common cause of seeing a physician. The first episode resolves in 2 to 4 weeks. It is the third most common cause of disability after 45 years, and it increases 5% every 5 years. This is the extent of the problem. There is no major mortality or morbidity, but there are huge compensation costs in US. Up to 1/4 of these can become chronic low back pain. More than 25% will have recurrence at least once a year, and medical expenditure increases with MRI, epidural injections, chronic medications and surgery without significant improvement in patient outcome and disability rate. The complexity and the biomechanics of the spine make it difficult for a specific anatomic lesion with precise diagnosis only in about 20% of the patients. And if you see this percentage, you will see that first two is the major cause, which is lumbar sprain, strain and degenerative changes and facets. The specific causes for which we have treatment, like herniated disc, fractures, spinal canal stenosis, is barely 10 to 12%. Chronic back pain can have muscle deconditioning, improper posture, body mechanics and overuse injuries. All of you know that we use multiple therapies, allopathic, Ayurvedic and so on, with doubtful benefit in most of the studies in the literature. So we need to know the cause so that we can treat better. Coming to QL syndrome, as you can see, it is the deepest muscle in the lumbar region. It extends from pelvis to ribs. It contracts when you are sitting, walking, standing, and therefore it is susceptible to pain formation. Pain is usually caused by overuse, but can be sometimes caused by weakness and tension. If you see here, you will be surprised to see that actually the pain can be over the joint or even in the gluteal region. And we have already seen that gluteal weakness actually can cause pain in the quadratus lumborum. The crosses that you are seeing are trigger points, and that brings us to the next important topic, that is myofascial trigger points. It is an extremely common cause of pain. Discrete focal hyperirritable spots located in the taut band of muscle. Pain, stiffness, tension, physical limitation and loss of normal function can occur. On palpation, you will find a hypersensitive bundle or nodule in the muscle fiber which is harder. Palpation can cause local tenderness, or it can also cause referred pain with a local twitch response. Trigger points can be secondary to diseases like arthritis and spine, and that's why what happens is initially the problem may be arthritis and disc, and later on the trigger point can cause the major problem, and hence they are called great mimickers. They can be active or latent. Latent means the patient doesn't complain of pain. When you examine, you find the tender points. Various modalities such as spray, stretch technique, ultrasonography, manipulative therapy are used, and even the trigger point injection. This is just to show you the extent of referred pain with all these muscles with the trigger points. You can see the green causing is the infraspinatus, quadratus lumborum, latissimus, trapezius has major referring, and these can cause problem. In lower limbs, you can see how gluteus maximus, medius and minimus and even front thigh muscles can almost look like sciatic pains. Trigger points are formed because of repetitive injuries. That may be because of using mouse and computer, using electronic gadgets, home work environments. It can be sustained loading by heavy lifting. It may be that may be because of the patient. Babies are purses and briefcases. Habitually poor posture, poor chair or footwear. Muscle clenching and tensing due to emotional stress. Trauma. Surprisingly, even inactivity with prolonged bed rest can cause trigger points. Mechanical imbalances, joint disorders, sleep problems and vitamin deficiencies can all contribute. Coming to deep gluteal syndromes, when to suspect? Sciatica that is accompanied by pain in the buttock, when the pain is aggravated by sitting, or when the routine MRI has failed to find a cause for sciatica. Having said that, the commonest cause which is piriformis syndrome can most of the times happen in addition to sciatica. So this is the deep gluteal muscle. So if you imagine, if you are looking at a patient posteriorly, superficially it will be a gluteus maximus muscle. Anteriorly there will be bony structures like ischium, ilium, acetabulum, femur. Laterally it will be a greater trochanter, and medially it will be the sacrotuberous ligaments, as you can see in the figure. And the important structures, the most important being the piriformis muscle. You can see the triangular piriformis muscle there, and the other muscle which are superior and inferior gemellus, obturator internus, quadratus femoris, and there are variety of nerves in this area, the most important being sciatic nerve which has L4 to S3 roots, superior gluteal nerve, inferior gluteal nerve, pudendal nerves, cuneal nerves, superficial femoral cutaneous nerve, and each of this, there are various gluteal syndrome. So there can be piriformis syndrome, there can be different muscle involvement, there can be different nerve entrapment causing deep gluteal syndromes. The etiology mostly is a fibrous and fibrovascular bands. In piriformis syndrome, it may be hypertrophy of the muscle, dynamic sciatic nerve entrapment, anomalous cause of sciatic nerve, and the other muscles involvement as we have talked about. The clinical presentation is similar to low back pain and sciatica. There can be gluteal pain and weakness which may be unilateral and bilateral. Patient can't sit for more than 20 to 30 minutes, can't stride into terminal extension. There may be a limb neurological changes on testing. There may be severe pain in the night with disturbed sleep, and location of the pain may help. On examination, the deep palpation of the great sciatic notch can help. Investigations like EMG, MRI and MR neurography or even USG are helpful only when there is a gross obstruction or compression. But a lot of times there may be fibrous bands which are not seen on the MRI. So treatment is mostly conservative. It is stretching of the muscles, mobilization exercises, injection therapies with anesthetic, corticosteroid and botulism, acupuncture, and if you find a gross compression, then there is a surgical decompression. I am addressing piriformis syndrome because it is the most commonest and the prevalence is somewhere between 6 to 17%. Females common than males in 4th to 5th decades. There may be altered pelvic biomechanics, and piriformis syndrome may be primary when there is a muscle spasm or myofascial pain syndrome, or secondary due to congenital problems in piriformis muscle or sciatica, spinal stenosis, etc. There are a lot of clinical tests which has 70 to 80% specificity and sensitivity. The diagnosis is mostly clinical, but if there is a gross decompression, MRI and other tests as we have discussed can help. And again, the treatment is mostly conservative and rarely surgical. These are all the clinical tests and will not go into the details of the test. So we'll come to the last part of the discussion, which is sarcopenia. I'm just going to introduce you the concept and not discuss in too much detail. But I thought it is important for all of us to know. It is a progressive and generalized skeletal muscle disorder involving the accelerated loss of muscle mass and function that is associated with increased adverse outcome, including falls, functional decline, frailty, and mortality. Relevant symptoms are falls, weakness, slowness, and functional impairments. If you look at the SARC-F questionnaire, which is used for assessment of sarcopenia, the first, which is strength, is the grip strength, but the rest, assistance in walking, rise from the chair, climb stairs, and fall, all are related to lower limb involvement. There are variety of causes for sarcopenia. They can be nutritional, they can be inactivity related, lot of systemic diseases which are cardiorespiratory, bone, metabolic diseases can cause it, iatrogenic problems. Mind you, the important thing is to differentiate sarcopenia from malnutrition, cachexia, and frailty. It is not the same. The prevalence of sarcopenia increases with age. You can diagnose with clinical investigation like 400 meters walking, getting up from the chair, biomechanical testing, or by DEXA, CT scan, MRI, or USG. Treatment as of now is mainly exercises. Vitamin D has been tried. Allopurinol is tried with doubtful benefit. Anti-diabetic drug like metformin is used sometimes. There are trials going on bimagrumab and myostatin. Hopefully some more drugs will come in the future. Multifactorial etiology. So what I want to stress is whenever you are dealing with a back pain or knee pain, examine the gluteal status. I think we know, all of us know, it is a training that you should examine the joint below and above. But in this situation, it is really very important and we may be missing a lot of gluteal weaknesses. Back pain can refer to buttock and buttock problems can cause back pain. There can be extraspinal causes for what feels like sciatica. Gluteal weakness can come from sedentary lifestyle in young generation, and all of us are going to see more and more of that. If you notice, you will notice a lot of young people getting up with the support of the chair, and that is the first indication even when they are not complaining. In a lot of cases, diagnosis still can be clinical. MRI, EMG will help rule out red flags. Investigation negative does not mean no problem. If each of you help even one patient this way, my suffering and effort will be all worth it. Thank you very much.
Thank you, madam. That was really an informative lecture on some uncommon topic. I request the chairpersons to felicitate madam. च्या प्रदीर्घ अशा प्रतीक्षेनंतर पुन्हा एकदा याच छताखाली आपण इथे जमलेले आहोत. माणसाच्या इतिहासाच्या काही नोंदी बिफोर ख्राइस्ट, आफ्टर ख्राइस्ट किंवा इसवी सनापूर्व आणि इसवी सनानंतर अशी विभागणी केलेली आहे. पण मला वाटतं यापुढे ती कोविडच्या अगोदर आणि कोविडच्या नंतर अशी केली जाईल. कोविडच्या अगोदर सोलापुरामध्ये 3 स्टेट लेवलच्या परिषदा आयोजित केल्या होत्या. RSSDI, महाक्रिटिकॉन आणि मॅपिकॉन. तसं तर आम्ही म्हणजे मग एका पाठोपाठ एक लागोपाठ आलेल्या परिषदांमुळं आम्ही बऱ्यापैकी तरबेज झालेलो होतो. पण त्याच्यानंतर आला हा 3 वर्षांचा न भूतो न भविष्यती असा ऐतिहासिक खंड. त्याच्यामुळे सुरुवातीला आयोजनामध्ये थोडंसं आम्हाला चाचपडल्यासारखं झालं. पण MRA, API लातूर आणि API सोलापूर यांच्या संयुक्त सहकार्याने आजची ही परिषद आयोजित केलेली आहे. आणि पुन्हा एकदा याच छताखाली आपण न घाबरता, गर्दीला न घाबरता, एकमेकांच्या जवळ, एकमेकांच्या हातात हात घेऊन, मास्क न घालता पुन्हा एकदा आपण जमा झालेलो आहोत. कदाचित एका दुःखी आणि वाईट अशा स्वप्नाची अखेर होऊन एक नवीन, शहाणी, स्वच्छ आणि सुंदर अशी सकाळ जन्मलेली आहे. आणि निमित्त आहे आजचं MRACON. पर्सनली आय हॅव गॉट एन इमेन्स रिस्पेक्ट अँड इंटरेस्ट फॉर रुमॅटॉलॉजी. I don't think it's just a branch of medicine, but it itself, it's medicine, synonymous with medicine. Because no organ, no system and no cell can escape from rheumatology. So if you want to be excel or you want to be good in medicine, you have to be good in rheumatology. But unfortunately, it has not got the due credit, the due respect and due glamour in undergraduate curriculum, the postgraduate curriculum, and at least for first few years of our practice. So for that we need such many more and more frequent conferences. त्याची कदाचित आज सुरुवात झाली आहे असं म्हणायला हरकत नाही. या आजच्या या परिषदेचे उद्घाटन आपण धन्वंतरी वंदनेने करणार आहोत. सांगायला अतिशय आनंद वाटतो आणि अभिमान वाटतो की ही धन्वंतरी वंदना गाणार आहेत प्रसिद्ध रुमॅटॉलॉजिस्ट आणि संगीत अलंकार पुण्याचे डॉक्टर श्रीकांत वाघ. आणि त्यांना नृत्याच्या माध्यमातून साथ देणार आहे सोलापुरातील फिजिशियन डॉक्टर निशिकांत मस्के यांची कन्या आणि भावी डॉक्टर कुमारी गौरी मस्के. ती सध्या 3य वर्षाचं वैद्यकीय शिक्षण घेत आहे आणि सोबतच भरतनाट्यमचंही प्रशिक्षण ती घेत आहे. डॉक्टर वाघ आणि डॉक्टर गौरी या दोघांनाही मी विनंती करते की त्यांनी मंचावर यावं. सुरू करायचं. अतिशय वेगळा असा प्रयोग आपण करणार आहोत की ते लाईव्ह सिंगिंग आणि लाईव्ह डान्सिंग आपल्यासमोर सादर होत आहे. धन्यवाद. अतिशय सुंदर आणि अनोखं असं सादरीकरण आपल्यासमोर झालेलं आहे. अर्थात आपण अतिशय सज्जन सात्विक प्रवृत्तीचे संत प्रवृत्तीची माणसं आहेत. आपण देवाला अधूनमधून आठवतच असतो, कारण आपल्याला माहिती आहे जर देवाने आपली आठवण काढली तर ती फार पंचायत होईल. त्याच्यामुळे आपणच त्याची आठवण काढूया. धन्यवाद. यानंतर मी सर्व मान्यवरांना विनंती करते की त्यांनी मंचावर यावं. I request Dr. Dharman Singh, IRA President, please come on the President MRA, Dr. Shubhda Secretary MRA, Dr. Nachiket Kulkarni, Organizing Secretary, Dr. Mukund Rai, sir. Scientific Chairperson, Dr. Lata Bichle, Madam. Organizing President, Dr. Mohini Ganu, Madam. Vice President, Dr. Yojana Gokhale, Madam. API Solapur President, Dr. Satish Godse, sir. API Latur President, Dr. Ashok Ganu, sir. Secretary API Solapur, Dr. Pradeep Singhal. API Latur Secretary, Dr. Shyam Toshniwal. Okay, Dr. Shyam Toshniwal is not here today. So I request Dr. Patil sir from Latur to come on the dais. Dr. Rudrakshi sir, I request him. थँक यू ऑल. यानंतर मी व्यासपीठावरील सर्व मान्यवरांना विनंती करते की त्यांनी दीप प्रज्वलन करण्यासाठी पुढे यावं. हे बंद कर. समयी आणि तिचा प्रकाश हे मांगल्याचं आणि पावित्र्याचं प्रतीक आहे. सभोवतालचा काळोख कितीही जरी गर्द असला तरी हा प्रकाश, पणतीचा प्रकाश किंवा समयीचा प्रकाश मिळमिळता का असेना आपल्या परीने आसमंत उजळून टाकण्याचं काम करतो. निराशेची काजळी पुसून टाकतो आणि अंतःकरण पुन्हा एकदा विश्वासाच्या, श्रद्धेच्या आणि प्रेमाच्या तेजाने भरून टाकतो. ईश्वर म्हणा किंवा निसर्ग म्हणा, ती एक सर्वश्रेष्ठ शक्ती आहे आणि ती आपल्याला मान्य केल्या वाचून राहणार नाही. हे अखंड ब्रह्मांड, ही सृष्टी आणि सर्व जीवांचं पालन करणारी, त्यांचे संतुलन राखणारी ही सृष्टी. हे संतुलन जर आपल्या माणसाच्या वर्तनाने बिघडलं तर त्याचे काय परिणाम होऊ शकतात हे आपण सगळेजण पाहतच आहोत. या दीप प्रज्वलनाच्या निमित्ताने जीवो जीवस्य जीवनम याला अनुसरून आपण आपलं आचरण ठेवण्याचा प्रयत्न करूया. ही सृष्टी, इथले असंख्य जीव, ही झाडं, वृक्ष, वल्ली, नद्या, पर्वत आणि माणूस यांच्यामधील सलोखा आणि संतुलन टिकून राहिलंच पाहिजे. यातच आपलं आणि आपल्या पुढच्या पिढीचं सौख्य सामावलेलं आहे. कदाचित सर्वांच्याच ज्ञानाचा प्रकाश इतका मोठा आहे की समयीसुद्धा आता लाजू लागलेली आहे. धन्यवाद. सर्वांनी कृपया बसून घ्यावं. एखादी संकल्पना पहिल्यांदा मनात जन्म घेते, नंतर ती कागदावर उतरवली जाते. त्यानंतर तिचा प्रवास सुरू होतो, तो तिच्या मूर्त स्वरूपाकडं. या प्रवासामध्ये अनेकांचे हातभार लागतात, स्नेह मिळतो, प्रोत्साहन मिळतं, इम्प्रोव्हायझेशन होत जातं आणि शेवटी एक डेफिनेटिव्ह स्वरूप तिला मिळतं. डॉक्टर राय सरांच्या समोर हा अख्खा प्रवास सध्या तळत असणारे मला खात्री आहे. त्याच्यामुळं त्यांना मी विनंती करते की त्यांनी पुढं येऊन आपलं मनोगत व्यक्त करावं. डॉक्टर राय सर.
Thank you all. It's a pleasure journey to hold this conference in association with Maharashtra Rheumatology Association, API Solapur and API Latur. It was a tremendous journey since 2020, 21 and now in 22. But ultimately we could come together and have a physical conference and meet each other. And I see that everyone is enjoying this get together. And everyone is enjoying not only meeting with each other, but also the science. I welcome you all for this conference, and everyone should enjoy the whole 2 days. I won't go into the details of how it happened because of short of time, and I hand over the mic to the organizers.
Thank you, sir. बरंच काही बोलायचं असतं पण शब्द सुचत नसतात, अशी स्थिती होते बऱ्याचदा. नाव आय रिक्वेस्ट फॉर द फेलिसिटेशन ऑफ ऑल द डिग्निटरीज ऑन द डायस. मी विनंती करते डॉक्टर गोडसे सरांना की त्यांनी डॉक्टर धर्मानंद सरांचा सत्कार करावा. डॉक्टर गोडसे सर. Sir, to felicitate Dr. Nachiket Kulkarni. Mukund Rai sir to felicitate Lata Bichle madam. Dr. Ganu madam to please felicitate Dr. Yojana Gokhale madam. Few of our dignitaries are in the crowd also, so I request that they should be also felicitated. I request Dr. Golwalkar sir to felicitate the founder president Dr. Arvind Chopra sir. Dr. Zamre sir. Sir. Dr. Tanya will felicitate Dr. Baradia sir. will felicitate Dr. Bachuwar sir. To felicitate the senior physician Dr. Swami. Dr. Suhas Pujar sir to felicitate Dr. Suhas Kulkarni sir, who is the Dean of Ashwini Rural Medical College, Kumbhari. All the dignitaries to express their views, their thoughts. First, I would like to invite Dr. Dharmanand sir, IRA President, to share his views.
Good afternoon. My sincere thanks to Dr. Mukund, MRA, API, Solapur and Latur chapters. It's a pleasure to be amongst you all. It's an honor, and I could see the interest in rheumatology, which is a relatively young field but a complex field which varies from one side. It is very complex immunological disease, and as Subhada would have, so if you have listened to Subhada's talk, it borders to orthopedic surgeon and physiotherapy. So the spectrum is so wide, and that makes this specialty a difficult specialty to master. And many such meetings are required to familiarize non-rheumatologists in this complex area, and also enthuse few youngsters to take up rheumatology in future. And I wish this function grand success. Thank you very much.
Thank you, sir. I request now Shubha Kalke Madam, the MRA President.
Good afternoon, everyone. It was really nice to come to Solapur for Maharashtra Rheumatology Association conference. And I'm glad we are here and we are meeting you all. And I hope that rheumatology reaches all of you, creates interest in the students, physician, and grows in Maharashtra more and more. Thank you very much.
Now I request MRA Secretary Dr. Nachiket Kulkarni to come forward.
At outset, I thank all the organizers for their untiring efforts to see the day of today's conference, which as obviously is academically brilliant and ambience-wise enjoying. On behalf of the organizers, me being a part of them, I welcome you all to further participate actively in this academic venture. 2 years it has been that we have not been able to meet in person for social and these reasons, but I think with this great fanfare of conference that Solapur and Latur API teams have been able to put forward, the last 2 years we are easily going to be able to forget. Thank you. Welcome all.
Thank you, sir. फक्त ऐकणं आणि वाचणं म्हणजे ज्ञान नव्हे. एखाद्या विषयाची जमेल तितकी माहिती गोळा करणं, त्या माहितीचा झपाटल्यासारखा अभ्यास करणं आणि या सगळ्यावर आपलं स्वतःचं चिंतन आणि मनन करणं हे ज्ञान मिळवण्यासाठी करावं लागतं. आणि हे सारं सातत्याने आणि अनेक वर्ष केल्यानंतर त्या विषयाबद्दल आपल्या मनात जे निर्माण होतं ते खरं ज्ञान आहे. तर यासाठी मी विशेष करून विनंती करते आपल्या सायंटिफिक चेअरपर्सन डॉक्टर लता बिचले मॅडम, त्यांनी कृपया पुढे यावं.
Good afternoon, everyone. Dr.
Mukund Rai.
Dr. Dharmanand, Dr. Mukund Rai, and all the faculty members of MRA. I got a lot of pressure on me today because I find that I am getting unnecessary importance when so many good rheumatologists, young and the most senior ones are there in this hall. At the same time, I am very much pleased that I find a lot of very vibrant physicians from Solapur and Latur, and most of my, what should I say, my colleagues from Government Medical College, Aurangabad, just to name Dr. Patil, who is practicing in Latur. At the same time, I find that other physicians from this area, they seem to be very much interested in rheumatology. I think with the invocation of Dhanvantri, and along with the dance and the lamp that we just lighted today in this hall in the presence of this august gathering, will take up rheumatology to its height. I hope that our dreams will come true, and we as backbone in rheumatology, and I must say here that all the rheumatologists in India, they are very sober, they are very vocal, and I find the same trend amongst the lecturers or the students that we train in all medical colleges, in all medical institutes all over India. I think a time will come that physicians and rheumatologists and budding postgraduates who are there in this hall, they will opt for rheumatology, and we'll all will work together to take care of innumerable patients in rural and urban sectors. With this hope, I just thank all of you. Thank you very much.
Thank you, madam. वाढदिवसाच्या अनेक शुभेच्छा मॅडम. आणि केवळ कोइन्सिडन्स नाही आहे, तर आपल्या वाढदिवसाचा मुहूर्त साधूनच आपण ही MRACON आयोजित केलेली आहे. यानंतर मी विनंती करते डॉक्टर मोहिनी गानू मॅडमना. ही परिषद डॉक्टरांसाठी आयोजित केलेली आहे, तरी अनेकांचे विशेष सहकार्य आणि मार्गदर्शन लाभलेलं आहे. त्यांची आठवण करून देण्यासाठी, त्यांना धन्यवाद देण्यासाठी डॉक्टर मोहिनी गानू मॅडम येणार आहेत.
Good afternoon and greetings from organizers of MRACON, MRA, Latur and Solapur Physician Association. Organizing MRACON was a unique experience for all of us. COVID made us postpone this event by 2 years, but as soon as the COVID was over or restrictions were over, we geared up ourselves to organize this particular conference in this, and we welcome you all in this spinning mill city. Our visionary seniors, Dr. V.R. Joshi sir, Dr. Bichila madam and Dr. Chopra sir worked hard to form Maharashtra chapter of Rheumatology Association that brought all rheumatologists of the state under one roof. The association's next goal was to spread the rheumatology to periphery, and that's how this conference came into being. Considering this, current MRA office bearers, Dr. Shubhada Kalke madam, Dr. Nachiket Kulkarni, Dr. Praveen Patil, and their predecessors, they planned various programs to reach out to periphery and to primary caregivers at the periphery. The idea was well taken up by Latur and Solapur Physicians Association. Office bearers of both the teams, led by their presidents, Dr. Ashok Ganu and Dr. Satish Godse respectively, worked hard, and the team members cooperated and participated enthusiastically in the process. We tried to plan the scientific program meticulously under the able guidance of Dr. Bichila madam and assisted by Dr. Rudrakshi. Surely it will satisfy the knowledge-hungry medical fraternity from this area and Maharashtra. The highlights of the conference are guiding sessions by our father figures in rheumatology, like addressed by Dr. Joshi sir, Bichila madam and Chopra sir, and our IRA president, Dr. Dharmanand sir. Our ILA National Secretary, Dr. Aman Verma, could not, however, join the conference due to unavoidable reasons. Our local organizing team, led by, with lead roles by Dr. Satish Godse, Dr. Pradeep Singhal, and Dr. Rudrakshi, did hard job of managing economics. Dr. Mukund Rai shouldered the responsibility of the conference wholeheartedly. New MMC rules posed many problems and difficulties in front of us. But he could make it pass through all that. He was working almost 30 hours a day, and I'm sure he has lost few kgs in last few months. He was working actually with 3 phones in 2 years, that I know for sure. I must appreciate the efforts put in by Dr. Suraj Dhut and Latur API team for their background work, including the registration drive. We were constantly in touch with MRA office bearers whose timely suggestions made us strike the balance between the basics and advances in rheumatology. Souvenir committee led by Dr. Kamatkar toiled hard to make souvenir memorable, and Dr. Prachi Patil made a successful attempt to weave Solapur textile fabric on the cover page. State and local executive, travel and reception committees have done commendable jobs all these days. Hope your stay is made comfortable, with their efforts make your stay comfortable and you enjoy the academic sessions as well. I am thankful to all those whom I have named. If I have forgotten certain name, or those who have worked in the background, I am thankful to all those who made this process easy for us. Both Latur and Solapur are ancient cities with history dating back to Chalukya era, and blessed by Gram Daivat Siddheshwar and Shri Tulja Bhavani Mata. May both the deities bless us all and help us make this event successful. Thank you very much.
थँक्यू मॅडम. आता व्यासपीठावरील सर्व मान्यवरांना मी विनंती करते की त्यांनी आपल्या स्मरणिकेचं प्रकाशन करावं.
Good afternoon. Once again, thank you very much for this invitation, and greetings from Indian Rheumatology Association. And Dr. Mukund Ray wanted me to talk on soft tissue rheumatism. And Dr. Kavita, I think today asked me, your special interest is in fibromyalgia and soft tissue rheumatism. I mean, I do have a special interest, but why do I speak on this topic? Most of the conferences is nobody else wants this topic. That is the commonest reason. So I'm going to talk to you in the next 20-30 minutes on importance of soft tissue rheumatism and a little bit on myofascial pain syndrome. And Dr. Shubhada had fortunately covered many of the aspects of myofascial pain syndrome, so I will be brief on that lines. So what is soft tissue? So bone and joints are considered as hard tissues. So we are not going to discuss anything which is related to bone and joints. So soft tissue rheumatism includes painful states arising out of either a muscle enthesis or the ligament attachment points into the bones, ligaments, disc, menisci and tendons. So soft tissue rheumatism is common. All of us would have had it at some point of time, or at this moment some of you might have it. If I ask you how many of you have some back pain, neck pain, I think at least 25% would lift your hand. But knowledge base amongst the doctors who see soft tissue rheumatism is generally weak. Which are all the doctors who see soft tissue rheumatism? Orthopedic surgeons, rheumatologists, maybe neurologists, physiotherapists. The knowledge base is weak and this generally not taught well. And most of us are less confident doing a musculoskeletal examination compared to cardiovascular or respiratory or abdominal examination, because it is not taught systematically in medical schools and generally relegated to last few pages of a textbook. So these diseases are nobody's babies. So except for few interested physios and musculoskeletal specialists, most of us just pass through these chapters and focus on our darling diseases like rheumatoid arthritis, lupus, which are very attractive. When you deal with T cells, B cells, and targeted immunotherapy, it looks very, very attractive. So most people would drift towards that line, justifiably. I can't blame them because that is more attractive and more money is there. So if it is so common, why only some of us chose to be patients? That is again a perplexing question. If you ask the community, and Dr. Arvind Chopra has done good work on the community, 3, 4, 5% of the people at any point of time would say that they have aches and pains. Only few of them will go to the doctors. What makes them to become patients? The rest of them, they handle either the coping skills, the people who have a better coping skills manage. If I cannot stand without support, I just reflexly lift, keep one hand, one leg up and manage so that I don't suffer. So other guys probably continue to stand that and suffer. I don't know, there's a lot of complexity here. There is a school of thought to say that soft tissue rheumatism may represent intermittent or ongoing predicament of life. This is a very debatable topic because we cannot underestimate the importance of pain and the structural cause for pain. In sometimes it can be an acceptable mask for failure. So sometimes this happens in the subconscious level. The patient may not be aware of this connection. So we cannot blame the patient saying that, okay, you are having pain because you don't want to do, you are lazy. That's what their parents tell. When the kids become achy, you are lazy, you don't want, you are not interested in studies. So this kind of accusations happen to these patients, and because of that the patients can get a reactive depression. Rather than psychological disease causing the pain itself can lead to secondary affective symptoms. So when a patient comes to you with complaints of pain, first good thing we can do is to believe it. When they say it is paining, it is paining. Many a times when they come to us with, say, back pain, and you do a physical examination, gross, whatever examination we do, SLR, few tests we do, Faber test, patient has no symptoms, no signs, symptoms, and you do an X-ray, normal, MRI, normal. It can be, patient can still have pain. Sometimes we say everything is normal, you can't have pain, it must be psychological, it must be functional. So that is how we react to it, because we are, as a physicians, we are trained to take a history, do a physical examination, do few blood tests, some test comes positive and treat that disease. When everything comes negative, then we are at a loss. It is easy to treat a test positive patient than a test negative patient. Patient has a lot of aches and pains, all the tests are normal. It challenges our integrity, challenges our knowledge, and keeps us, actually humbles us and exposes our inadequacy. So accepting the illness is the first step towards building a good confidence amongst the patient and the doctor. And initial medical consults may have a role in medicalizing or demedicalizing symptoms. I will again take example of acute back pain. If you read any guidelines which says strict bed rest is contraindicated. But how many of you have seen the patient goes to the primary physician with acute back pain, they can't move, something like a sciatica or acute lumbago. Strict bed rest is advised. And also doctors find it difficult to explain in a native tongue what we have learnt in English. Say disc prolapse. At least in South Indian states, I don't know how Maharashtrian doctors will explain. A disc prolapse is explained to the patient as some nerves have twisted. That's how they tell. So they use this finger also. So whenever the patient has pain, Okay, they're taking bed rest, they want to get up to the bathroom. The first few steps, they have pain here. The patient's interpretation is nerve is twisting more. They stop. This can lead to fear avoidance behavior, and some patients don't listen to the doctors. They do well. They say strict bed rest, next day they will go to work. They will do well. Some people very obedient. The doctor said strict rest. And their husbands also sometimes, husbands or wives, they will tell, no, doctors, no, don't do anything. I will go and do everything. I will take the children out. So sometimes we call them as a partner in pain. So they can contribute because doctor has told. Doctor has told. See, they are strictly obeying. It can lead to a behavior which can lead to fear avoidance and catastrophization in the long run. Because every step they take, the more pain, they reinforces their philosophy that something is twisting more. So when patient and doctor talk to each other, they come from two different school of thoughts. So make sure that they understand what you want them to understand. In a way, they have to make sure that they have understood correctly in a way which you want them to understand. Otherwise, sometimes this kind of mishaps can occur. Because we see patients with chronic pain, 10 years pain. Because they say, my first doctor told you should take 1 month full bed rest. You should not even go to toilet. And bedpan. So this can be the trigger. So what we do in the first consult may have a long-term impact in a susceptible patients or a vulnerable patient, I will put it that way. So we doctors can be sometimes risk factors for chronic pain. And women, for many reasons, biological, psychological factors, so many reasons, they get more vulnerable to pain because women, one theory I read, I'm not sure whether it's true or not, if they have kids exposed to childhood adverse experiences, child abuse or whatever it is, if a girl is exposed, when they grow up, they get into chronic pain, depression. Men are exposed, they become violent and antisocial. So maybe something, the hormones and wiring might contribute to this. Of course, trauma, both physical and mental, can contribute to chronic pain. And nociceptive pain arising out of the tendon and ligaments are very localized. Somebody has a tennis elbow, they will point exactly where it is. Somebody says pain is everywhere, like this. This is unlikely to be tennis elbow. And entire limb pain does not occur, it's not due to nociceptive pain. The entire limb pain is generally has got a different interpretation. And also very severe chronic pain which makes somebody cry. Maybe only 2 or 3 explanations for that. Either it can be neuropathic, acutely neuropathic pain can be so painful that they can cry. It can be ischemic. So there can be an impending, some femoral artery occlusion, impending occlusion, they can present with severe intolerable pain, or sometimes it can be a conversion reaction. And when somebody comes to you with pain, always look for the expression of pain, whether it's a dull, achy type of pain, the pain on activity, how the throbbing type of pain. If they say they use a word burning, shock-like, junjanat, whatever, that may have a neuropathic component. So in this situation, you have to start thinking in the differential diagnosis whether they have some kind of a compressive neuropathy. Another tip is, when somebody comes to you with like very severe hand pain, they have hand pain, when you examine the hand, if the hand is not hurting, you might have experience as a physician, diabetic neuropathy patient, they'll come with a lot of pain. When you hold their hand, when they say initially pain, we continue to hold them, ask them whether what I'm doing is comforting or hurting. They say very soothing. So that means the pain is not coming from the structures. It's not a nociceptive pain arising out of the bone and joint here. It may have a neuropathic pain, or it may be a referred pain from a site above that. Pain coming from, say, forearm to the wrist. They may have wrist pain, but the wrist movement will be normal. The palpation of the wrist would be normal. Then start looking for areas above wrist. And red flags, somebody has already discussed in the morning. This is again a yellow flag. If you can identify these patients early, we can prevent them getting into a illness behavior, like multiple consults. They've seen all the doctors in Bombay. They depend on medical system rather than self. See, a lot of people have that self-coping skills. They do well. The people who lack that, they suffer a little bit more. Those who show fear avoidance, catastrophization behavior, start telling that, no sir, I'm 40 only, I'm like this, probably 60, I'll be bedridden. See, that is a thought process, a negative effect, sleep disturbance. When they come to us, we feel that they are heart-sink patients because they keep talking, they never go out of the room, and they take more time. All the patients outside the clinic, this patient comes in, there's going to be a big problem outside. The doctor has seen us in 10 minutes, this patient is taking 30 minutes. So it can be a heart-sink patient for us, but allotting some time and listening to these patients and identifying these can quickly lead to stopping further aggressive investigations, because more investigations you do, they get into that cycle. Sometimes we'll say, we'll agree to stop the investigations, we'll treat you, manage you, we'll do further test only if there is a new clue comes. Somewhere somebody has to put a full stop, otherwise they will go, every new doctor goes, your MRI is 6 months old, something might have happened now, so they'll get another MRI. So, ladies and gentlemen, I would suggest you to always think of regional pain. Somebody comes to you with knee pain, think of as knee regional pain. Then you will have a wider differential diagnosis. Because sometimes you do a physical examination, knee looks normal, X-ray normal, then we are stuck. Because in our mind, knee joint pain. So if you have a knee regional pain, there are so many structures around the joints. So one of them may be hurting. So regional pain can be periarticular, joints, neurogenic, or referred pain from structure above. I'll skip this, I have already discussed this. Some of the physical examination you can do, people who have very flexible joints, hypermobile joints, which you can include during your physical examination, are also prone for soft tissue rheumatism. People with hypermobile joints are more likely to be flat-footed, they will have a foot pain, they can have recurrent shoulder pains, recurrent knee subluxations, they complain of buckling when walking, anterior knee pain, a patellofemoral knee syndrome is very common. They are also prone for enthesitis, both tennis elbow, if they are into sports. They can also have back pain because their abdominal muscles are weak, ligaments are weak, they have a little increased lordosis. All these things can contribute to a mechanical back pain, flat foot. They can also have sometimes intermittent hydroarthrosis. Bland knee effusions can occur. They respond to intraarticular steroids. They are also prone for fibromyalgia, sprains, varicose veins, and in women sometimes uterine prolapse. All these things are a part of a hypermobile diathesis, which is similar to Ehlers-Danlos type 4, I think. Type 4, no? Type 4. Type 4 or 5. One of the Ehlers-Danlos is very similar to benign hypermobile joint syndrome. So when a patient comes to you with widespread aches and pains, I want you to consider 4 to 5 broad categories as differential diagnosis. First question would be, is it, as we are rheumatologists, we should always think of, is it a part of systemic inflammatory rheumatic syndrome? In a very early preclinical phase, many autoimmune rheumatic diseases can present with aches and pains, diffuse widespread aches and pains. But over time, within 6 months, 1 year, disease gets established. Somebody comes to me with 4 years of aches and pains. If they don't have clinical arthritis, I'm not going to think of rheumatoid arthritis or lupus. 6 months, 3 months, I would still consider whether it is a part of an autoimmune rheumatic disease. Second basket is it a rheumatic manifestation of an endocrine disease? Hypothyroid, somebody discussed in the morning, is a very common reason why people can have aches and pains. Another reason we found was undiagnosed or uncontrolled diabetes. Glucose toxicity itself can present with musculoskeletal symptoms. Even now, even with this enormous increase in the awareness of diabetes, everybody does tests for diabetes. Everybody goes to their own lab and gets the sugar tested every periodically. They come with a big booklet of tests from the labs. Even now, at least 1 or 2 patients a month I see with severe aches and pains with asthmatic symptoms and undetected diabetes. So I'm sure as a physician you would see more of this. And third basket is always think whether this patient has got a drug related aches and pains. If somebody started on a recent drug, I think she told me about checkpoint inhibition. So if somebody has been started on a drug, CA breast is very common amongst our patients. Most of the patients are put on, if their ER is positive, they are on anastrozole or some similar drugs. And many drugs can cause aches and pains. Many drugs which are used in chronic pain, like duloxetine, pregabalin, themselves can cause pain. So any new drugs, consider drug in the differential diagnosis of aches and pains. If patient says, I have aches and pains since last 3 months, 4 months back somebody started me on some Silacar, cilidipine. If you look at the literature, 1 or 2 arthralgia, myalgia will be there in the potential side effects. Change the BP tablet and see. If the patient responds, it is done. There is no need to do anything more. And the fourth basket is, of course, fibromyalgia and chronic pain syndromes. And the fifth basket is probably small fiber neuropathy. Particularly if the pains have a lot of burning quality, either length dependent or even bizarre. They have a lot of burning here. It can be a ganglionopathy or a small fiber neuropathy. The most important cause would be impaired glucose tolerance. So look for IGT, even HbA1c of 6 could be maybe stricter diet, getting into avoiding metabolic syndrome might reduce the symptoms, and drugs like pregabalin or gabapentin can be useful in them. Fibromyalgia is probably the most common musculoskeletal disease in women. Almost 3% of women can have it. It can mimic inflammatory arthritis because it occurs in the same gender, same age group. They also, if you ask any question, they will say yes. You have swelling of the joints, they will say yes, because they have subjective swelling. I am not telling anything in derogatory manner. They have subjective swelling. They say, they'll show that hands are swollen. You can't see it. They can see it. They can perceive it. It's similar to if you have ever gone to a dentist, if you have taken a local anesthesia jab into your jaws, after the dentist is finished his job, you also feel that the face is swollen, but look at the mirror, your face looks okay. So this is kind of a virtual reality type of subjective sensation of swelling, and they will have early morning stiffness more than 1 hour. Yes, they will say yes for it. If they happen to have ESR of 30 and false positive rheumatoid factor, which these people can be taken as rheumatoid arthritis and treated with potentially toxic drug to a patient who don't have rheumatoid arthritis. If somebody has rheumatoid arthritis, methotrexate is an angel drug. If somebody doesn't have rheumatoid arthritis, methotrexate can be a toxic drug. So it depends upon what context we use it. And look for affective components, sleep disturbances. A patient who has widespread aches and pains, fatigue, sleeping difficulties, tension headache, migraine, irritable bowel syndrome, irritable bladder, multiple sensitivity. Every drug they have taken, they are sensitive. Their patients know, I am allergic to all the tablets, doctor. So you cannot be, but these patients may be fibromyalgic, affective symptoms, patients who have had adverse childhood experiences. This is the category you should think of fibromyalgia. And we were all taught in the rheumatology school, rheumatology departments, as fibromyalgia as a disease of exclusion. That what we internalize is we have to do MRI, we have to do ANA, we have to do rheumatoid factor, we have to do spondyloarthritis, HLA-B27. We have to do everything to exclude. No, the exclusion happens in the clinical level. If somebody has symptoms complex like this, we need not do anything. We have thought about inflammatory rheumatic diseases as discussed. We have ruled out. Diagnosis of exclusion doesn't happen at investigation level, at the clinic level, history level, physical examination level. These are few examples I'll run through. Flat feet can result in foot pain, plantar fasciitis, medial ankle pain, particularly when they have hyperpronated foot. These kids are very commonly diagnosed as spondyloarthritis. Lower limb arthritis, they will have enthesitis, they will have, sometimes they will have a severe swelling in the medial aspect. They can be mistaken as spondyloarthritis. And footwear is an important cause, particularly young women who wear high heels are prone for foot pain, forefoot pain, hallux valgus, bunion, bunionate, etc. A lot of us have tight Achilles, which can contribute to plantar fasciitis. And tibialis posterior dysfunction is also a common cause for medial foot pain. And hallux valgus and rigidus is a common entity in women more than men. Another, and people who work in IT cities like Bangalore and Pune probably would see patients with work-related upper limb pain. It can be to any work. So it can be factory worker, loom worker who use their hands frequently. Some are specific syndromes like a tennis elbow. It's very typical, localized pain. Resisted wrist extension will be painful, localized pain. We can treat it like how traditionally treated physiotherapy, exercises, injections, etc. Similarly, medial epicondyle, carpal tunnel syndrome, intraoperative neuropathy, sometimes cramps. There's another group which is difficult to diagnose is diffuse upper limb pain syndromes. They will have kind of vague aches and pains which comes on while working. Something not as bad as a writer's cramp, but once they work computer for 10, 15, 20 minutes, they'll start aching. They have to keep doing it, keep massaging it. So they suffer a lot, but poorly defined. Some of them are related to posture. Some of them can be myofascial trigger points. And sometimes work satisfaction. See, a lot of people have these pains. Some of them will become patients. Those who become patients, there could be others. Maybe a job satisfaction, maybe some affective tendency for genetic tendency for affective symptoms. Somebody who is prone to develop depression, prone to develop anxiety, they develop these pains, they suffer more, they become patients more. They seek medical attention more. These are few examples of posture. We all abuse our neck. We use our mobile phone, sit in a wrong way, slouch on the couch watching Netflix and Amazon. And another new syndrome, interesting syndrome is tech neck syndrome or a text neck syndrome. You can use it this way. So it is people, you see in the road, lot of people who walk around like this. They are going in the morning walk, but with a mobile phone like this. Right? So people they spend entire life looking at their mobile phone like this. What happens is the shoulders get rounded, neck comes forward, and see the neck is a heavy head weight. People say no, head is really heavy. So it has to go through the neck. If this posture only, I don't know the exact kilogram weight, but some say 100 kg weight goes into this. The moment it comes forward, 300, 400 kg weight goes into this neck. So these muscles have to work really harder to keep the head. So they develop trigger points in the sternocleidomastoid, these areas, neck. So they become tight in the pectoralis and very weak on the rhomboids. So they ultimately they become like this. They can develop lot of musculoskeletal symptoms. So good posture advice, maybe a good physiotherapist, ergonomics can help. And how do we treat soft tissue rheumatism? Acute treatment is easy. Local heat, cold, rest, injections, rehabilitation, exercises, non-steroidal, and splinting. And when it becomes chronic, then education becomes important. The role of posture. It's always look for a correctable cause in chronic pain. Even they may have fibromyalgia. If they have severe osteoarthritis, sometimes a knee replacement or a knee injection into the joint can reduce their fibromyalgia symptoms as well. So we always look for a pain generator which can be addressed. Cognitive behavior therapies, acupuncture, injections, exercises. Here, pain relief is not the goal. In a chronic pain, functional improvement is the goal. Even with the best of best medications, we can only give 30, 40, 50% relief in 30 to 50% of the people. So even when you combine multiple drugs, so good substantial pain relief is not possible in many chronic pain conditions. Acute pain, yes. And learn about eccentric exercises. If you have a tennis elbow, eccentric exercise is the only exercise which are shown to benefit. I'm not going to expand on this now. Tell me, do you have still time? I have one more full talk there. I will quickly run through it. Okay, I'll take 5 minutes. Myofascial pain, which Subhada had beautifully addressed. It is not uncommon. It is not recognized and looked in the clinic because we are not trained to look for it. It can mimic arthritis, it can mimic migraine, it can mimic radiculopathy. And it is amenable to local therapy like simple massage and stretch or dry needling. So this trigger points are irritable spots in the muscle. Fascia is also an important structure in generating pain. Fascia is innervated. There is a lot of adhesions happen at fascia muscle level. It can contribute to a lot of aches and pains. Some of the bizarre radiation or what should I say, spreading of referral of the pain. We all think that the pain should go in the dermatome level, neurotome level, but sometimes patients say, when you touch here, doctor, it's hurting here. We think that these guys are mad, but it can go through fascia. It can go through fascia. And trigger points can cause local tenderness. It can cause tingling sensation. Some of the neuropathic symptoms can be due to trigger points. It can cause weakness. If they have a significant trigger point in my deltoid, I may have weakness in abduction. And the loss of range of movements also can occur because of the inhibition, reflex inhibition of the muscle because of the pain. So what happens if muscle injury happens? Increased acetylcholine leakage leads to sustained muscle contraction, leads to ischemia, and vasoactive mediators, increased acetylcholine secretion, which can increase the loop, and sensitization of the peripheral nociceptors, subsequently leads to sensitization of the nerves in the spinal cord level, and this loop is perpetuated. It occurs generally in a weaker muscle, and we all think that the radiation occurs from proximal to distal. If I have a trigger point here, I can have pain in the fingers. Sometimes it can happen other way around also. A trigger point in the calf muscle can be felt as a gluteal pain or as a hamstring pain or even as a back pain. This I will skip. Prevalence, whenever they have studied students, 32% of the students in an university, they had myofascial trigger points. And in a chronic pain clinic, 85% of them may be having myofascial pain. The trapezius, this area, neck, levator scapulae are the most common region to develop trigger points because of the reason which I have told you. Trigger points can be active. Active ones are the ones when you touch here, the patient reproduces all the pain. And latent ones are there, they are tender, they feel good when you massage it, but they don't cause spontaneous pain. But if you do any unusual activity, suddenly decided to move your house, lift a lot of weights, you can develop a active trigger point from a pre-existing latent trigger points. So this is a question which all the students ask. What's the difference between fibromyalgia and myofascial pain? The pain in myofascial pain is localized. Fibromyalgia is a diffuse. So fibromyalgia is a central sensitization syndrome, whereas myofascial pain can be a very localized pain syndrome. So it occurs in single muscle or a single region, and tenderness is very diffuse in fibromyalgia, and muscle spasm is common in myofascial and less likely in fibromyalgia. And you will have a tender region, but you don't find a tight or a nodule kind of a feel in fibromyalgia. And of course, fibromyalgia is more likely to be associated with fatigue, sleep disturbances, and multiple symptoms we discussed. And like subjective swelling sensations also more common. So in other words, myofascial pain syndrome presents as a regional pain syndrome. Fibromyalgia presents as a diffuse widespread ache and pains. Nice trigger point charts are available. This chart is available in Amazon. So it's 800 rupees or something like 8,000 rupees or something like that, the original ones. But nice distribution. You can at least when you have pain always refer to this. This is another lower limb chart. This is another important chart. I think the Chicago Center Myofascial Pain Relief. If you go to chicagotriggerpointcenter.com, you can download this picture. I'll explain the importance of this picture in the next one slide. I don't have a pointer, no? See, if somebody, we'll look at which area. We'll look at area number 2 here. If somebody comes to you with a temporal region pain, which are all the muscles which can refer pain to temporal region? That's what is the trapezius. The trigger points can be in the. See, somebody comes to you with the pain here. The patients can have trigger points in the trapezius, sternocleidomastoid, temporalis, splenius, suboccipital group. These are the muscles we should go and examine. Somebody has vortex pain, it can be sternocleidomastoid again, or splenius capitis. Like that, for everything, cheek pain, this many muscles can send pains into. One of the commonest site which I find is sternocleidomastoid. Somebody comes to you with a lot of ear pain, headache, just palpate here, they will jump. They never knew that there was a pain there. They will not allow you to even touch, but ask them to hold on. For half a minute if you hold on, they start getting pain everywhere. So we can easily see this in our clinic. So this is one pain in the butt. One of the reasons for pain in the butt can be trigger point. So whatever is there in plus is a trigger point. The red is the radiation region. So there can be a trigger point in this region. Patients can experience pain in this distribution. I've just given you few examples. There can be a trigger point in the forearm muscles. Patient can have pain in the wrist region. Patients can have knee pain and they can have pain in the quadriceps muscles, vastus medialis muscle. It can even mimic metatarsalgia and metacarpal pain if they have trigger points in some of the small lumbricals and small muscles of the hand. So how do we treat myofascial pain? One type of pain is ischemic compression and stretch. How do we ischemic compression? Give a digital compression to the trigger point identified. If you look for it, you can find a tight spot, very painful. They will not like you touching there. Hold the pressure for 10 seconds, and that pressure should elicit pain, not 10 out of 10, but 5 to 7 out of 10. 10 to 12 seconds, 20 seconds pressure, followed by stretch for 30 seconds. Repeat this cycle a few times. Intensity depends on the acuteness. Very acute pain, you will require generally some heat, local heat, some non-steroidal anti-inflammatory drugs. Once the pain comes down, we can start doing this. We can do the same massage and stretch. We can massage that area and stretch. If this is area, massage that and stretch the sternocleidomastoid in whatever way you can. There's another technique called spray and stretch, which people don't use it regularly. Dry needling is very popularly used. Dry needling is, you use an acupuncture needle, try to put it into the trigger points. Try to localize the trigger points, put a needle.
I have 2 more minutes maximum.
Yes, I'm done. It's the last slide. And we can inject this area. As a clinicians, we can take a syringe, have a local anesthesia and inject that. And if I can say an anecdote, what made me develop interest in this field is one of my own patients who used to come and see me for knee OAs. He came with severe neck pain. His was like a wry neck. He was crying with pain. So immediately I didn't even see. I just sent him to neurologist. Neurologist saw, neurosurgeon saw. They immediately asked for an MRI. They thought it was some kind of a radiculopathy. MRI was clean. They have to sedate him to do MRI. It was such a pain. MRI was clean. Then the neurologist went down to the radiologist to look for a brachial plexus. They thought it's brachial plexus. That was also normal. Next day morning when I went for round chest, courtesy call, I went in to say, hey, how you are? Sir, pain is, he was crying. Then I was just palpated. I palpated as very tender point, he was jumping in levator scapulae. Something in me made me to ask the nurse to load 5 ml of local anesthesia and give me, I just injected into that. And came back. I told him, let me see how it works. And after 30-40 minutes, his wife came and told, sir, he's all right, can we get discharged? So that was a dramatic, so something which really shook me. Okay, something we can do, something dramatic can be done for these patients. So ladies and gentlemen, this is a difficult area, hardly taught. We have to take self-interest, read a little bit, take the help of a physiotherapist. They are the ones, sometimes they know muscles well. We have forgotten our anatomy. Sometimes when it's splenius, I don't know where it is. I have to go and see the anatomy and say, oh, this is where it is. So learn about the current treatment strategies. There are a lot of new strategies are coming up. A lot of physiotherapists are learning this. They have got their own workshops on trigger points and various techniques to use this. And there is an interesting workshop. I recently happened to go there for a few minutes and come back. They were doing visceral manipulation. People who have got a cesarean section, who had surgeries, when they have a back pain, doing a good visceral manipulation seemed to improve their back pains and other musculoskeletal pain significantly. So it is all connected through fascia according to them. There is a World Fascia Congress, which I have attended once. So there is a World Fascia Society. So there is a lot of people who are doing work, but it is not getting integrated, it is not coming into our textbooks. And make sure that you and the patient speak the same language. I have given you an example of what could go wrong. Look actively for mechanical factors. These are the correctable factors. Somebody has a flat foot, probably can do something about it. Somebody has a tight Achilles, we can do something about it. And somebody has a very cesarean scar, and ask the lady to lift both the legs up. If she can't move it, and she has a back pain, scar mobilization and focus fully on abdominal strengthening exercise can make a huge difference to their back pain. Otherwise, routine physiotherapy will not help. And as I told you, they are amenable for simple treatments. And always look for the person behind the pain. Somebody coming to you with legs and pains may be crying out. He has a reason to come to us. He's not a nut case. He's not a gone case. He is coming to for a reason, but the reason may lie somewhere else. May not be in the area where he is complaining. And always look for a distress in these patients. If you are able to identify, we can do something about it. Not that we can eradicate the pain, we can deal with it in a much better way. And the pain sometimes is inevitable, suffering is optional, and we can sometimes suffering can be negotiable. Thank you very much for patience.
Thank you, sir.
Thank you very much, sir. It was really interesting, informative and practical talk. I request.
So we are running behind the time. In capacity of chair, we'll postpone the question answer session to the end of the day, sir.
And on immunization, we don't detect any abnormality. What is the cause of it?
It's difficult to say, sir. There's no single reason. When somebody says symmetrically exactly half, so we can't explain by like a neurological examination, or a neurological explanation is difficult to give. These are the patients I would think whether they have any other reason, any other affective symptoms. I'll look for them, look for it. If they don't fit into any neurological presentation, it's totally only one half, then you would think of a functional cause strongly above a musculoskeletal cause.
In constraint of time, I think we wrap up the session. Thank you, sir, for a great academic session.
I request the chairpersons to felicitate, sir. For the next session.
Presidential oration, inauguration ceremony and very informative keynote address by Dr. B.G. Dharmanand sir. We continue on our scientific program. Our next session is Symposium on Spondyloarthropathy. Our first topic is backache, is it inflammatory, by Dr. Nagnath Khadke sir, consultant rheumatology, member of Rheumatology Association Maharashtra. He has many paper and case publications in national and international journal.
At the outset, I would like to thank Team MRACON for giving me this wonderful opportunity to be here in front of you. I welcome you all to the second symposium, that is spondyloarthritis. And as it said, well begun is half done, so let's start on a...
I request our chairperson for this session.
Lack of time, I think. Everybody is running out of patience.
Yes. Dr. Zambre sir, Dr. Nilima Deshpande ma'am, and Dr. Yojna Gokhale ma'am. Sorry to interrupt, sir.
No, I'm sorry. So, I think much has been said about this low back pain issues. Dr. Karke madam, sir, Dharmanand sir has already talked about a lot of differentials which are possible in this scenario, that is back pain. And we all know that how common is it. In fact, it is the second most common medical element in the society behind common cold. If you want to know the numbers, the lifetime prevalence can be as high as 84%. The point prevalence can be up to almost 7.5%. So at any given point of time, almost 7.5 to 10% of the population will have low back pain, ongoing low back pain. The percentage of patients having chronic low back pain out of this will be around 10%. And the total workers' absenteeism, the most important cause is low back pain, which accounts for almost 75 to 85%. So just looking at the sheer numbers, you'll understand the burden of this disease in the community. There are so many nociceptive structures in the spine. There is a muscle, there is fascia, there is disc, there is bone, there are joints, there are nerves. So unless you can pinpoint, it's like you are fishing in a muddy water. So you have to find out what is the exact cause, what is the exact structure from where the pain is emanating. And I think that is the reason that almost less than 15% of times you can identify or you can have a specific pathoanatomic diagnosis in a case of low back pain. Red flags have been dealt with, I think, in a couple of prior lectures. Without looking at the red flags, nobody should go forward in a case of chronic low back pain. This can produce a lot of consequences for a patient if you miss them. And they need early intervention. I think most of the rheumatologists know what these figures stand for, 8 years and 9 years. I think this is the average delay in a diagnosis of inflammatory back pain or a spondyloarthritis or ankylosing spondylitis. 8 years is in gentlemen, 9 years is in ladies. And these figures hold true for Western world also, not only in India. In fact, one of the papers in 2018 by Dr. Devdhar claimed 14 years average delay in US population. I think as a rheumatologist, it's unacceptable to us. And what this can cause? Obviously, the delay results in permanent functional disability, sometimes structural damage. The people, the patients who are suffering chronically, they go into social withdrawal, find it difficult to establish a career, to start a family. Obviously, there is an increased healthcare cost. There are multiple visits to various doctors, an extensive use of over-the-counter medicines because they are not getting any relief from their pain. The spectrum is vast. The differential diagnoses are innumerable. As Dr. Karke madam, one of the slides she showed. So I'm going to stick to inflammatory back pain and how to differentiate it from a mechanical back pain. Otherwise, it will be a very difficult thing to look after within 15 minutes. So this is very basic actually. As a rheumatologist, we may not be so much interested in this, but our physician colleagues, our orthopedician colleagues, physiotherapists would like to know how to differentiate inflammatory back pain from a low back pain or a mechanical back pain. So early onset is one of the most important criteria. The gradual onset In most of the inflammatory back pain, you will have patients having early morning stiffness, which is quite significant, more than 30 minutes. The nocturnal pain will be there, but obviously the malignancy has to be looked into if there's a nocturnal pain along with the systemic symptoms. The pain will improve with the exercise, which is one of the most important factors or the criteria when you look for the inflammatory back pain. The radiating pain and the narrow deficits will be extremely rare in inflammatory back pain. There will be history, family history or previous episodes or sometimes GI infection in cases of inflammatory back pain. And when you examine the spinal mobility will be impaired in all of the axes when you are dealing with the inflammatory back pain. And on the other hand, if it's a mechanical back pain, the spinal mobility will be impaired in a selective axis. There are many criteria which are available for identifying inflammatory back pain. Most of the criteria have good sensitivity and specificity if you apply them correctly. However, one thing one should notice, improvement with exercise but not with rest is almost common in all the criteria. So this has to be one of the most important questions to be asked to a patient when you are suspecting an inflammatory back pain. How will the lab help us in this? So normally we do see a lot of patients coming to us after doing rheumatology profile, which contains almost everything. So if you are dealing with a patient of low back pain, what is the importance of C3, C4 and ANA? Unless you have some systemic features to go with it. So we do see a lot of patients having rheumatoid factor done, anti-CCP done, ANA done, anti-DSTNA done for just maybe some myofascial back pain. ESR, CRP obviously are important because they will denote the inflammation. HLA-P27 again is important, but should not be solely dependent into, as they say, you should not put all your eggs into one basket. But there are a lot of limitations. So fewer than 1 in 10 individuals possessing HLA-P27 will develop disease. Women will have an atypical presentation. Significant proportions do not have HLA-B27. And although the gene is autosomal codominant, it has a variable penetrance, so it may skip generations. Also, HLA-B27 negative ankylosing spondylitis is obviously there. So it has a later disease onset, it has a lower incidence of anterior uveitis, and significantly more frequently associated with psoriasis, ulcerative colitis, and Crohn's disease. So just do not emphasize on any one particular aspect when you are trying to find out whether the pain is inflammatory or not. This is the hot favorite topic for each and everyone. What about imaging when you are dealing with inflammatory back pain? Well, it's not needed in each and every case. In fact, if there is a radicular pain or if there is a red flag or if you are planning to have a surgical intervention, then only it's needed. Conventional radiography, unfortunately, is poorly sensitive and specific, do not hold much value in case of inflammatory back pain unless it is a chronic disease of years together, when you will find some inflammatory changes in the spine. The bone scan can help you, but it's not available everywhere. The most important imaging that is obviously ordered is MRI, which is quite sensitive, almost 90%, and quite specific also, almost 95%. However, the changes in the MRI depend upon the duration of the disease. So what you have early in the disease are the changes of osteitis, capsulitis, enthesitis, while as you progress, you may have fat lesions, you may have new bone formation, and lastly, you may have a complete ankylosis. So when you're looking at a chronic back pain of early chronic low back pain, maybe 6 months, 1 year, you have to think about these lesions. Now, if you start calling each and every altered signal on an MRI in an area of a spine or at the borders of the vertebra or in the SI joints as an inflammatory lesion, you are surely shooting yourself in the foot. There are some specific criteria which are important and which have to be applied before you can call a signal as it's related to an inflammation or maybe as an active sacroiliitis. So what you need is bone marrow edema, osteitis, or bone marrow contrast enhancement, which should be present in a typical anatomical area. So anywhere if you find a bright signal or a hyperintense signal in the spine or in the SI joint, you cannot call it, because as you know, the SI joint is a complex joint. It has a fibrous structure, it has a synovial structure. So this is something you can remember, that this is how it will look like, the MRI picture in an active sacroiliitis, where you will find a lot of hyperintensities along the sacroiliac joints in the subchondral area of the bone. Only synovitis, capsulitis, or enthesitis without bone marrow edema cannot be termed as active sacroiliitis. Also, as I showed, fat metaplasia, sclerosis, erosions, and ankylosis, which can happen over the course of the time without bone marrow edema, cannot be called as an active sacroiliitis, but they can be considered as a chronic lesion. If you apply this criteria diligently, the sensitivity and specificity is quite good, almost 80%. Many times we do get reports with the mention of modic changes in the spine. Now these modic changes are not only related to inflammation, they are due to edema, they can be due to fatty degeneration and bone sclerosis. So we need to understand what these modic changes are. They are different on T1, T2 images, so accordingly you can differentiate that whether you are looking at edema or a fatty degeneration or a bone sclerosis. Well, this is an important slide because not all the back pain patients or not even all the inflammatory back pain patients will necessarily progress to a radiographic spondyloarthritis or a ankylosing spondylitis. So if you remember the earlier figures that I showed you, 80%, 40%, 10%, when you actually come down to ankylosing spondylitis, this is a Kopka data, the prevalence is less than 0.4%. So something which is very non-specific and present in 80% of the population, you have to come down to 0.4%. And that is why I think we need to have our basics strong. I think next few slides are about approach and the spondyloarthritis features that you should look into, but I think they will be covered in the next topic of diagnosis of ankylosing spondylitis, so I think we can skip through it. Why I am skipping through it is because I want to come to this last couple of slides, which I consider are very important. Though we know that we are missing the inflammatory back pain in the society and we are having a delay of 10 years, 12 years, 14 years, though IBP is a key diagnostic criteria for diagnosing AS, very few non-specialist doctors are confident in correctly evaluating, diagnosing and managing inflammatory back pain, and this again is not a phenomena restricted to, I would say, our part of the world, but even in the Western world. I did a small survey when I got this topic just to know that actually what is the situation at the ground level. So I selected a questionnaire of only 6 questions and I did a survey among the GPs. Unfortunately, we are not the first interface between the patient and the medical fraternity. The first interface is always a GP, maybe BAMS, maybe homeopathy, maybe physician, general practitioner. So my first question was very simple: how commonly you see patients with RA? Most of them said yes, very commonly, extremely commonly. Second question was again, have you heard of inflammatory back pain? And I think it's nice to know as a rheumatologist that 100% affirmative answer I had. Almost all the GPs, the trainees, they said yes, we know, we have heard of inflammatory back pain. So I think happy we are. Come to the next question. Do you really understand the concept of inflammatory back pain? The percentage drops down to 50%. Yeah, last, yeah. Last 2 slides. Yeah. So only 50% they actually understand that what is the concept of inflammatory back pain. How do you diagnose inflammatory back pain? Most of them said X-ray, which is obviously not relevant as I showed. Examination, yes, very important. How do you deal with the patients of inflammatory back pain? Reference to orthopedics, almost 60%. Reference to rheumatologists, around 40%. So we need to do a lot of catching up. Choice of treatment of IBP, most of them said physiotherapy and muscle relaxants. Good to know that not a much emphasis is being put on rest. The last slide is same. This is a NHS survey, which again showed that there is a lack of confidence in history taking, assessment, investigating, treatment, and training. Yeah, it's over. So mechanical back pain, inflammatory back pain. Everywhere you score less in a Western setting also. Thank you so much. The last slide is just the summary.
Thank you, Dr. Nagnath Khadke, sir, for your knowledgeable insight on backache. I request our chairperson to felicitate our speaker. Now we will take a lunch break and we will start our next session sharp at 2:30 p.m. Next topic for discussion is spondyloarthropathy diagnosis and classification by Dr. Shashank Akerkar sir, rheumatologist in Mumbai, pioneer work in health related internet usage and a unique initiative Stand for AS on YouTube channel and Facebook page.
Good afternoon, everybody. Great to be here with all of you today. Today, let's have a look at, in fact, I'm changing seronegative spondyloarthropathy to arthritis since it is an inflammatory disorder. So let's have a look at how do we diagnose and how do we classify. Diagnosis is mainly for clinical purposes and classification is mainly for the clinical trials. So first of all, what all is included? What all conditions come under seronegative spondyloarthritis? Ankylosing spondylitis, reactive arthritis, psoriatic spondyloarthritis, inflammatory bowel disease related arthritis, and undifferentiated SPA. What are the common features that this entire group has? Inflammation of the sacroiliac joints and the vertebral joints, so sacroiliitis, spondylitis, association with HLA-B27, peripheral joint involvement, which is asymmetric, predominantly large joints, lower extremities, enthesitis, dactylitis, uveitis, enteric mucosal lesions and skin lesions. Inflammatory backache, how do these patients, most of these patients will present to us with backache. The first and the foremost step in diagnosing these patients would be to differentiate between mechanical backache and inflammatory backache. Dr. Nagnath has already done this in detail. The only point that I would like to feature in particular is pain at night. Age, generally young patients, duration more than 3 months, insidious onset, morning stiffness, improvement with exercise, and one of the most important is nocturnal pain. When it comes to nocturnal pain, there are 2 types of nocturnal pain that most of our patients will tell us about. One is इतकं दुखतं की झोपच लागत नाही आणि दुसरं झोप तर लागते पण 4-5 वाजता दुखल्यामुळे टर्न करताना जाग येते. So the first thing that is there, झोपच लागत नाही, is generally because of fibromyalgia and the other functional and other etiologies. But the specific thing, awakening in the second half of sleep, that is something very specific for inflammatory backache. Most of our patients don't understand when we ask these questions very easily. So these are some of the surrogate questions that we can get from them. तुमची झोप दुखल्यामुळे डिस्टर्ब होते का? रात्री एकदा झोप लागली कुशी बदलताना दुखतं का? सकाळी उठला आणि खाली काय पडलेला असेल उचलू शकाल का? दुसऱ्याला सांगायला गेल उचवायला? So this is what will give us the definitive answers. Most of our patients are not really good at telling us this history. And lastly, how do you get up in the morning? Most with ankylosing spondylitis, active inflammatory backache will give a history of इकडं पकडायला लागतं, तिकडं पकडायला लागतं, असं टर्न व्हायला लागतं. It takes 5 to 10 minutes just to get up and start walking. So this is what is inflammatory backache. I think skip this slide. The inflammatory backache need not always be in the gluteal area. It can also be low back. It can be thoracic, and at times it can be cervical as well with the same features. So, as I said, most of these patients will come with backache. Once we are sure that this patient has inflammatory backache, not just routine backache, the next step towards the diagnosis of spondyloarthritis would be looking for specific features of spondyloarthritis. What are these specific features? As you can see here, dactylitis. What is dactylitis? As you can see, these toes, it's not a single joint of the toe, but the entire toe that is inflamed. You can compare it with this. So somebody with inflammatory backache and dactylitis, the specificity for a diagnosis is 99%. One more patient, this is psoriatic nails, dactylitis. One more specific feature, enthesitis. What is enthesitis? Enthesitis is inflammation at the region wherever a ligament, muscle or tendon attaches itself to a bone. As you can see here, classic Achilles enthesitis, the Achilles attaching to the calcaneum, and there is inflammation here. Somebody with inflammatory backache with enthesitis, specificity for a diagnosis of SPA, 92.9%. So most of the time, something that we saw today in the morning itself, a good history taking, good examination, in most of the cases will give you a diagnosis straight away at the bedside itself. So this patient again, this is enthesitis, synovitis, and then there are psoriatic lesions, straight away giving a diagnosis of spondyloarthritis. There are other entheses in the body as well, not just Achilles, lateral epicondyle, and as you can see here, multiple entheses in the body. So whenever we see a patient who's complaining as local focal tenderness in multiple areas, let's not forget about enthesitis. Enthesitis need not always be very visible or obvious. You can have a look at this patient, inflammatory backache, complaining of knee pain every now and then. The knee definitely doesn't look swollen. If you ask the patient to locate his pain, this is where he locates, and you can clearly see inflammation here. There is a swelling here. There is a swelling here. What is this? This is the peroneus longus muscle enthesitis. So, somebody with inflammatory backache, complaining of focal, localized pain at multiple locations, definitely think of enthesitis. Heel pain again is one more enthesitis, plantar fascia enthesitis. And as we already saw, specificity, inflammatory backache plus heel pain, some obvious enthesitis straight away is 92.9. Psoriatic lesions, again, since psoriatic arthritis is one of the spondyloarthritis type, definitely let us not forget to look at psoriatic lesions when we see such a patient. Psoriasis is still a taboo. We may have to ask the patient to show areas where they are having skin lesions to reach a diagnosis. As you can see here, these are the other, quite obvious lesions. Some of the hidden areas, the scalp line, let's not forget to see here, and behind the ear, so that we don't miss out on these small psoriatic lesions. Psoriatic nail changes, frank changes, and onycholysis. So what are the other specific features apart from something that we already saw? uveitis, alternating buttock ache. It's not a single. Ask the patient, and I'm sure most of the patients will tell, initially it was right-sided, now it is left-sided, and it keeps shifting from one side to other. Positive family history of ankylosing spondylitis or SPA, history of inflammatory bowel disease, asymmetric arthritis, and raised ESR-CRP. These are the other features which will take us to a diagnosis of spondyloarthritis. So inflammatory backache with more than 3 of these features, the probability of diagnosis is 80 to 95%. 1 to 2 features, 35 to 70%. How about peripheral joint involvement with spondyloarthritis? It is predominantly lower limb joints, large joints, and asymmetric. So the pattern of joint involvement in these patients can be pure axial, wherein it's only the vertebral joints and the sacroiliac joints. And secondly, it could be a mix of the two, axial plus peripheral, or predominantly peripheral with a little bit of axial. So this is what the pattern of joint involvement would be in these patients. Once the history is done, you're more or less already through with the diagnosis. Examination wise, what all can give us a diagnosis, take us closer to a diagnosis? Examination, restriction of the lumbar spine movements in AP and lateral planes because of either significant inflammation with muscle spasm or because of secondary fusion calcification in that region. Second is restricted chest expansion. This happens because of involvement of the costovertebral joints. Again, either because of severe inflammation and also because of the joint fusion, the expansion gets restricted. Typical posture, thoracic kyphosis and hyperextension of the neck then. So if we have to look at the diagnostic algorithm, mind you, you must have seen HLA-B27, I have not even spoken about it till now. So once a patient enters, generally he would come with chronic low back pain. The moment you are through with inflammatory, this pain is inflammatory, the chance of this diagnosis increases to 14%. With specific features that we just saw, it increases to 30 to 70%. It's only after that that HLA-B27 and imaging actually comes into play. HLA-B27 alone does not mean a diagnosis of ankylosing spondylitis or SPA. In X-ray, we can see sclerosis, erosions, ankylosis of the SI joint and calcification in the lumbar or thoracic spine. CT SI joints, which can show erosions and sclerosis much better in doubtful cases. And one of the best things that has happened for diagnosis, MRI of the sacroiliac joints, something that Dr. Nagnath already touched upon, frank marrow edema, which can give us the earliest possible diagnosis of spondyloarthritis. Coming to the classification, this was the clinical bedside diagnosis. How about classification? These are the classification criteria. These are mainly for clinical trials and not necessarily for diagnosis clinically bedside. So these are the ASA's classification criteria. You can diagnose spondyloarthritis either with radiological help, which is sacroiliitis on imaging plus one of the features that we just saw, or even without radiology, HLA-B27, this is the clinical arm wherein HLA-B27 positivity plus two or more than two spondyloarthritis features. This was mainly for the axial spondyloarthritis. How about peripheral spondyloarthritis? We have classification criteria for the same as well. So if the patient has either arthritis or enthesitis or dactylitis and plus more than one of these features or plus more than two. So plus more than either the patient has psoriasis, IBD, preceding infection, HLA-B27, uveitis or sacroiliitis on imaging, and more than two, which would again include arthritis, enthesitis, dactylitis, inflammatory backache, positive family history. This would be classified as peripheral spondyloarthritis. So we have specific criteria for both the conditions. Something that Dr. Nagnath touched upon, but we should really know, you must have seen recent rheumatology prescriptions. Ankylosing spondylitis is the terminology that we hardly use. You must be wondering what is axial spondyloarthritis, what is NR axial spondyloarthritis. So this is exactly what it is. These conditions where it is predominantly axial is now termed as axial spondyloarthritis. Early stage, this is a continuum. This is not necessarily advanced stage of the same disease. These are various stages. First is the non-radiographic stage, so which is written as NR-AXPA in the diagnosis. What exactly is this? The patient has inflammatory backache, patient has features of spondyloarthritis, but the MRI does not show, the MRI shows sacroiliitis, but X-rays do not show any specific spondyloarthritis changes. So this stage is considered as non-radiographic stage, and as against this we have the advanced radiographic stage wherein the X-ray starts showing features suggestive of spondyloarthritis. What would the X-ray show? One is radiographic sacroiliitis in the form of sclerosis, erosions, irregularities or even ankylosis. And lastly, in the spine, one would have syndesmophytes. So this is non-radiographic stage and this is the radiographic stage. If you have a broader view of the same thing, spondyloarthritis, as we saw, can be diagnosed either clinically or by imaging. In imaging, if the X-ray does not show anything, X-ray is normal. Non-radiographic SPA, a few of these patients can progress to radiographic SPA over a period of time. Radiographic SPA can either be without osteoproliferation, which would mean changes only in the SI joints, no syndesmophytes, whereas there is also a stage of radiographic SPA with osteoproliferation, which would mean presence of syndesmophytes. So a few of these patients can over a period of time progress to this. What are the risk factors of progression? Male sex, positivity, HLA-B27 positivity, heavy work which involves lifting of weights, mechanically demanding jobs, and smoking. And a few of these patients can then even have osteoproliferation, radiographic SPA with osteoproliferation. And this radiographic SPA, this is called as ankylosing spondylitis, whereas this would only be termed as non-radiographic axial spondyloarthropathy. Thank you.
Thank you, Dr. Shashank Akerkar, sir, for your informative discussion. I request our chairperson to felicitate our speaker. Moving on the next topic of discussion, spondyloarthropathy, how to access activity, by Dr. Kavita Krishnan ma'am, Professor and Head, Department of Clinical Immunology and Rheumatology, Bharati Vidyapit University, Pune, PG teacher for rheumatology, and over 150 publications in various national and international journals.
Hello, good afternoon. Thank you for the kind introduction. I shall be talking about how to assess disease activity in spondyloarthropathy. So as physicians, we evaluate, we diagnose, we advise, we prescribe. Then what? We need to know whether our treatment is working. What should we monitor and how frequently? In diabetes mellitus, we have the HbA1c, we have the blood sugar. JNCC gives us the target blood pressure goals. In dyslipidemia, we monitor the LDL cholesterol. Let us see in spondyloarthropathies, what are the tools available and which are more useful. Next slide. Yeah. But in spondyloarthropathy, disease activity is the sum of many different aspects and a complexity that we cannot represent by a single variable. There is no simple gold standard for measuring disease activity in the individual patients. If you see the timeline in ankylosing spondylitis, as early as 2nd century, we knew about ankylosing spondylitis, but HLA-B27 were discovered only in 1973. In 1984, we had the modified New York criteria for ankylosing spondylitis. In early 1990s, the questionnaires for BASDAI, BASFI, BASMI, Stokes spinal scores were written in Bath, England. But in 2004, when the TNF alpha inhibitors arrived and they were approved, followed by IL-17 inhibitors, JAK inhibitors now recently, all these scores became more relevant. Such expensive drugs were used in these indications. So were they working or no? So outcome measures became more important than ever before. So we had ASAS in 2009, which revised the criteria for OAS, and ASDAS came up as a very useful tool to assess outcome measures. So the clinical tools can be patient-oriented, which are BASDAI, lab parameters included in ASDAS with ESR or the CRP, the measurement indices called the BASMI, quality of life indicators in BASQI, and a very important functional and quality of life index, that is BASFI. Furthermore, BASDAI and ASDAS along with enthesitis index, peripheral joint count and ESR-CRP are measures of disease activity. Structural damage can be measured by BASMI and Stokes spine scores, and physical function is better assessed by BASFI. So as many of you participated with the short survey with me on disease monitoring and ankylosing spondylitis, 74% were rheumatologists and others were physicians and 7.4% were orthopedicians. The maximum presenters were between 20 to 30 years of age and 92% patients presented with low backache among these consulting physicians and rheumatologists. So let us see what were some of our observations. The most importantly, most of us monitored the patients clinically, followed by inflammatory markers like ESR and CRP. Few of us only used X-ray and MRI for monitoring. The commonest used instrument was BASDAI because that is the easiest to do so, followed by by ASDA's ESR or CRP. You can see BASMI is not commonly used for monitoring because it's probably time consuming. However, lateral flexion, which is an important measure, is used by many consultants. So coming to a few words about each of these indices, BASDAI is the most traditional reported outcome, is completed in 2 minutes. The questionnaire was prepared in Bath, England. It has 6 components, as you can see. The first 4 are related to fatigue, tiredness, pain in the hip, neck or back, discomfort in the tender areas, overall pain in other joints. So these are out of 10. The last 2 relate to morning stiffness and the duration, and these 2 are divided by 2, and then average of 5 is taken. So the score is out of 10. A cutoff of 4 is frequently used to define the active disease or more. So if the score is more than 4 and persistently, we have to decide some change in management. It is reliable, sensitive to change after 3 weeks of physical therapy or the biologics if we are using. This cutoff level of 4, however, does not have a firm justification. Also, many times the BASDAI scores do not correlate well with symptoms and clinical measurements of disease activity, or even so are MRI scores. This score is fully patient-driven, so physician's opinion is not included in this assessment. So we had an improvisation called the ASDA score, the ankylosing spondylitis disease activity score. It's a new composite index and which includes either CRP or ESR along with back pain, duration of morning stiffness, patient global assessment, peripheral joint count. So these composite scores range from 1.3 to 3.5. If the score is less than 1.3, the patient has relatively inactive disease. You can call him less frequently to the clinic. If it is more than 3.5, that suggests very high disease activity. So definitely it warrants intervention in terms of higher biologics or other medications. So ASDAS highly correlates with BASDAI, CRP, or MRI inflammation scores, physician global assessment. It highly discriminates between the patients with different levels of disease, and it is better than BASDAI, more valid with enhanced discriminative capacity and sensitive to change. So if we have an ASDAS app, an ASDAS calculator can calculate the score. It is a score highly used in different trials and by many rheumatologists in the clinic when they're subjecting them to interventions with biologics. Coming to BAS5, this is a set of 10 questions. It determines the degree of functional limitation. If you see, the first 8 questions are related to everyday tasks like putting on socks, bending forward, getting out of the chair, etc. And the last 2 are related to one's ability to cope with daily activities, how demanding and how difficult it is for them. Each is on a scale of 0 to 10, and a summary is a mean of 10. It's again quick, takes about 2 to 3 minutes only, sensitive to change, correlates well with 3 weeks of therapy or medication. Again, the only limitation being it is a patient-reported index only. BASMA is by far a very objective index. It's a composite index of spinal mobility. We are all familiar with this anthropometry, triggers to wall, cervical rotation, modified shoulders, lumbar slide flexion, etc. 30% improvement in BASMA scores often is seen after 3 weeks of treatment. You have a 3-point scale, as you can see in these 0, moderate, severe, etc. You also have 11-point scale, so you have different calculators. Chest expansion is also an important index. The problem here is it takes time to do, so it's with a heavy patient OPD, it becomes difficult to measure every index in every patient. Coming further in this BASMI, what has been found is spinal disability and deformity at the time of presentation, the time the patient first comes to you, is an important deciding factor in disease progression as well as the response. If you see this study, in 51 patients were studied over 23 years and diagnosed with ankylosing spondylitis were analyzed. The ones who had only mild spinal deformity at the time of presentation, of these 74% did not develop any severe disease at follow-up. But out of those who had severe deformity at time of presentation, either they had severe disease or they came in late to the consultants, 81% developed severe deformity on follow-up. So impaired spinal mobility is common among individuals in ankylosing spondylitis after 10 years, but if there's early spinal mobility affection, they are the ones who have poor outcomes. This study also tells you similar observations, and they have derived that the 3 most important measurements out of the BASMI are lateral spinal flexion, occiput to wall distance, and chest expansion. So regularly these should be monitored in the follow-up patients. Coming to inflammatory markers, in our survey, 43.7% of the consultants felt that ESR and inflammatory markers helped them in 20 to 40% of the patients. What it means is that ESR CRP is elevated in 30 to 40% of patients in ankylosing spondylitis, but normal values do not exclude the presence of active disease. But the ones in whom they're elevated, they do help us in follow-up. CRP is more widely used and probably more reliable. ESR is more elevated when peripheral joints are involved or an associated inflammatory bowel disease. Elevated CRP also correlates better with radiographic changes. Cytokines and genes are used not commonly because they are more for research purposes. HLA-B27 should not be used for follow-up, though some people have answered yes in the survey. IL-6, IL-17, TNF-alpha, all have been studied in different research projects in ankylosing spondylitis. They may be useful in diagnosis, but do not predict the outcome of the severity of the disease. So the role in disease monitoring is not clear. What is the first line of imaging in suspected AS? So majority of the consultants used MRI or CT scan as the first line of imaging. In follow-up, some of them said MRI may be used, many of them said X-rays are used, CTs or advised were very few. X-ray of course is the gold standard as sacroiliitis is the first manifestation. Radiology of the spine is not included, but it can be the diagnostic criteria, but it can be used for monitoring. As we already know, conventional radiography is most easily available, it is cheap, and except for radiation exposure, it is pretty reliable. MRI is the best investigation, but acquisition time is prolonged. The scoring on MRI is time consuming, so very often radiologists do not have the time to give you the score. CT is rapid, is better for early bone formation, but it gives radiation, and its CT, SI joint, etc. is not easily available also. Coming to the scoring, so 24 sites are used for lumbar and cervical spine scoring, T12 to S1 and C2 to C7. Usually lateral views are used for scoring. As you can see in this slide, you have 0, normal right up to 3 where it is total bony bridges. So we had earlier on BASRI, that is Bath Ankylosing Radiology Index. Somehow this was not used much in different drug trials. Then you had Stokes AS spine score, and what is most sensitive found is modified Stokes AS spine score, MSA-SSS. So in this study they analyzed the patients post-infliximab therapy, and MRI was very useful in detecting and documenting reversible spinal inflammation, but X-rays were good enough for documenting spinal damage. The X-ray changes come up only after 2 years or more. So in follow-up, MRI is most sensitive more than CT or plain radiography because it can detect bone marrow edema, synovitis, capsulitis, etc. It is definitely a useful tool to detect and monitor disease progression, but cost is an issue. Many patients do not want to do an MRI again and again because it's cumbersome. And the studies for MRI are useful to prove the efficacy of biologics, but routinely MRI is not used in practice. It is more used in research and phase 3 or trials of medications. Is there a correlation? Sacroiliitis correlates well with BASDI, but other radiological features do not. So if I have to sum up the entire talk, using this ASA's OMRAC core domains, we have clinical, laboratory and radiological imaging tools to monitor the disease. At the center, we have assessment of physical function, global assessment, fatigue, pain, etc. You offer them SMART, that is symptom modifying anti-rheumatic therapy, physical therapy. We have to keep a good clinical records and we have to document the peripheral joint count, extra-articular manifestations, check the initial radiographs and maybe follow up acute phase reactants, and then overall decide which disease-correcting anti-rheumatic drugs you're going to offer the patients. To sum up, disease activity in axial spondylar arthropathy cannot be represented by a single variable. Combination of clinical and when required laboratory and imaging is optimum in predicting the course of illness and modifying treatment whenever required. Record keeping is a must when we monitor or assess disease activity. Initially, we should monitor frequently, 4 to 6 weeks, and after that to see the response. But once they are stable, you feel they are in remission, we can monitor even annually. And whenever you're doing, please use some score, whether it's radiological, whether it's meteorological, etc., some lab parameter, imaging when required, and keep looking for extra-articular manifestations. They can come later. Cardiovascular risk assessment is also important, at least once in 5 years. But first and most important question to every patient on every visit should be a simple one. How are you feeling today? Listening to the patient about the pain is most important. So many a times we cannot cure, but we should aim to heal and not just prescribe. As Hunter Patch Adams said in his serial, you treat a disease, you may win, you may lose. But if you treat a person, I guarantee you, we will win, no matter what is the outcome. Thank you.
Thank you, Dr. Kavita Krishna ma'am, for an innovative and wonderful talk. I request our chairperson to felicitate our speaker. I request Dr. Prasad sir to join the next session for the chairperson. Our next topic for discussion, ankylosing spondylitis management by Dr. Avinash Buche sir, consultant rheumatology, Dr. Hegdewar Hospital, Aurangabad, PG tutor in CMC Vellore and clinical fellow rheumatology, Royal Wolverhampton NHS UK.
Good afternoon, and thanks to the organizers for inviting me. In next few minutes, I'll try to finish this huge topic. So what is the agenda? I'm going to talk about non-pharmacologic treatment, pharmacologic treatment for active disease, what are the ACR recommendations, and then treatment for stable disease. It's not moving. So the goals of the treatment are to reduce symptoms, improve function, increase ability to work, reduce disability, and obviously decrease complications, minimize drug-related complications as well. Coming to most important part, the non-pharmacologic measures, which are I think equally important when you compare with the pharmacologic agents. So patient education is must, and it will help you to get cooperation of the patient. Physical therapy is important. It has got anti-inflammatory activity in AXPA, and the group physical therapy is better than home exercise program. There was a study in UK in 2020 which showed that the patient with AS who have sedentary behavior have worse exercise capacity and quality of life than those who have active lifestyle. Coming to pharmacologic treatment, the NSAIDs are the first drugs which we use. They improve spinal symptoms, peripheral arthritis, enthesitis, and uveitis. Around half of the patient, they improve partially or completely with NSAIDs. And ACR recommends that continuous NSAIDs are to be used over on-demand NSAIDs. But do they halt the radiologic progression? This issue is controversial. There was a trial done with celecoxib, which showed SAS20 response in 57% patients, and the rates of spinal fusion were reduced on radiograph after the end of 2 years, but the similar results were not reproduced with diclofenac. So this is a controversial thing for NSAIDs. Coming to conventional DMARDs, they are used in patients with peripheral arthritis. They are not useful for axial disease, and sulfasalazine is preferred over methotrexate. But leflunomide, apremilast, thalidomide and pamidronate are not recommended to be used in ankylosing spondylitis. So in adults with active AS and despite treatment with NSAIDs, the TNF inhibitors are recommended when your ASDA score is more than or equal to 2.1 or BASDA is more than equal to 4. This slide shows the response of various biologic DMARDs in the clinical trials, and more or less every DMARD has shown the response around 40 to 50%. It is somewhat better with infliximab in anti-TNF group, and the new entrant tofacitinib is also showing SS40 response in 40% of patients. So these are the TNF inhibitors which are approved for use in ankylosing spondylitis, out of which certolizumab is not available in India, as previous speakers have told. And majority of people, they use etanercept adalimumab because it is easier to administer subcutaneous injections than the IV drugs. So this anti-TNF agents, they show response in around 60 to 75% of patients, and around a quarter of patients, they are non-responded. There is no response when you initiate the anti-TNF, and these are called primary non-responders. If you initiate the anti-TNF and you get some response, but after a while the patient stops responding, such patients are called secondary non-responders, and the rate is around 13 to 68%. The intolerance or adverse reactions to anti-TNF are seen in 13 to 57% of patients, but fortunately the rate of reported rate of drug retention after the end of a year is around 77% in these patients. So what are the predictors of response to TNF agents in patients with AS? Obviously, when you start the anti-TNF early, you get a better response. So patients with short disease duration responds better. Patients who are younger, they respond better. Patients who have high baseline disease activity, they respond better. And obviously, patients who have low physical function score, they respond better than patients with advanced disease. The other factors are male sex, absence of enthesitis, and presence of HLA-B27. The poor response factors are obesity, which is becoming common in our society now. Low education level and poor mental health are other factors. So this question arises every now and then, whether these anti-TNF agents, they retard structural progression or not. So in North American and Swiss cohort, they showed that half of the patient, they showed reduction in radiographic progression, and similar results were shown in Dutch study, but the duration of the treatment was around 6 to 8 years as compared to 4 years during the observation period. And the meta-analysis which was done in 2020 showed that the favorable effects of long-term treatment are seen after 4 years and not before that. And there was no beneficial effect shown in this meta-analysis for NSAIDs and secukinumab as far as the radiographic progression is concerned at the end of 2 years. So if you continue anti-TNF drugs for longer period, there is chance that you have reduce the structural progression in such patients. What are the major adverse effects of anti-TNF? The main thing is increased risk of reactivation of latent TB and opportunistic infections. This risk is high with monoclonal antibody therapies such as adalimumab and intermediate with etanercept. And there is also increased risk of other serious infections, liver failure if patients have hepatitis B. There are some reported cases of inflammatory ocular diseases, renal vasculitis and autoimmune hepatitis. The other main concern is development of lupus-like syndrome in such patients and aggravation of psoriasis. So these things are to be managed, and in these cases anti-TNF needs to be stopped. Coming to the next drug which is available for the treatment of AS is anti-IL-17 secukinumab. It was approved for radiographic expa in 2016 and non-radiographic expa in 2020. The dose is 150 milligrams subcute injection after a loading dose, followed by every 4 weeks. But in US they can use the drug without a loading dose. And based on clinical response, the dose can be increased to 300 milligrams for patients with radiographic expa. This was the trial which established the role of secukinumab in the treatment of ankylosing spondylitis. So you can see if the patient is anti-TNF naive, the SAS20 response is around 68% at the end of week 16, and which is maintained at the end of 5 years. The response is less if the patient has inadequate response to anti-TNF, but still it is around 50% at the end of week 16, and it is continued to 52% at the end of week 260. Similarly, the same kind of picture is seen as far as SAS40 response is concerned. The main adverse effects which are feared for secukinumab are increased candidal infections and reactivation of hidden inflammatory bowel disease, but the trial shows that the rates are not very significant. Still, this recent paper published in 2020 give a recommendation before starting anti-IL therapies. You should search for IBD family history, search for GI symptoms, and give information about reactivation of inflammatory bowel disease to patients. Check for the fecal calprotectin levels. If they are normal, you can safely start the anti-IL-17 drugs. But if they are elevated, a gastroenterology consult is recommended. And if there is no IBD, you can still go ahead and start with secukinumab. But if there is active IBD, you should not give secukinumab in such patients. This is the new entry which has changed the scenario and changed the management of AS. And this was the phase 3 trial which established tofacitinib as a drug. And tofacitinib is now recommended and approved for the treatment of AS in December 2021. So the efficacy results showed that SAS20 was significantly greater in tofacitinib group as compared to placebo, same with the SAS40 response. And the functional improvement was also better as compared to placebo in patients who have used tofacitinib. So the recommended dose of tofacitinib is 5 milligrams twice a day, but the patient who have hemoglobin less than 8 should not initiate tofacitinib, or with patients who have absolute neutrophil count less than 500. Patients with moderate or severe renal impairment, the dose should be 5 milligrams once a day. Same is the case with moderate hepatic impairment. So these conditions are to be kept in mind before initiating ankylosing spondylitis. Tofacitinib. Coming to guidelines, major points are anti-TNF agents are preferred drug after NSAID's failure. Anti-IL-17 should be used as third line treatment after failure of anti-TNF. JAK inhibitor is fourth line in the fourth line therapy. Major thing is treat to target strategy is still not recommended in AS patients because it increases the chances of adverse events. And tapering of biologic DMARDs is not recommended by ACR, but probably in India nobody follows this. And the MRI sparingly should be used when there is no response to standard therapy, only then you should use the MRI. That is what ACR says for the follow-up imaging. So for a stable disease, continue with NSAIDs and physical therapy, and you should determine whether the patient has any deformities, and if the spine deformities are there, ACR recommends to avoid spinal manipulation or osteotomy. If there is advanced hip disease, total hip arthroplasty is the recommendation. If the patient has stable disease and he is taking methotrexate along with anti-TNF, the recommendation is to stop methotrexate or stop NSAIDs. And obviously they have not recommended to reduce the doses of anti-TNF. So what should we do when multiple therapy fail? Reconsider your diagnosis, whether you are dealing with AS or any other disease. Do these investigations, find out whether the disease is still active or not. What you are treating, you should ponder over that, whether you are treating inflammation or you are treating structural damage. Check for the patient compliance. Are there any other issues which are complicating or which are aggravating the pain? Is there a fibromyalgia, depression or sleep disturbances? And importantly, are the treatment expectations realistic? So you should talk with your patients. So concluding, NSAIDs are useful in AS patients. Anti-TNF drugs are recommended when 2 NSAIDs fail. Secukinumab is recommended in TNF non-responsive cases. Tofacitinib is the recent addition. Non-pharmacologic therapy is equally important for better functional outcome. Guidelines do not recommend biologic dose tapering or stopping in stable disease, and surgical interventions are needed in severely damaged joints. Thank you.
Thank you, Dr. Buche sir, for explaining in detail about management. I request our chairperson to felicitate our speaker. Our last topic of session, special situations, psoriasis, IBD by Dr. Vaijayanti Lagu Joshi, consultant rheumatologist, CRD Pune, Dinanath Mangeshkar Hospital Pune, Sahyadri Hospital Pune.
Good afternoon all. It's a pleasure to be here. Thank you organizers for this great opportunity. And I'll be a last speaker of this session, but I'm at that advantage because all of you guys are made wiser and wiser about this spondyloarthritis in detail by our eminent previous speakers. So my job is easy. I'll focus only on spondyloarthritis in special situations. Pregnancy has been forgotten, which has been really dealt with in detail, especially medication part by Praveen today morning. But I'll be highlighting few other points, especially in context of spondyloarthritis and inflammatory bowel disease and psoriasis with spondyloarthritis. So we all know this now. It's a heterogeneous group. It is seronegative. There are no biomarkers. It's multifactorial. There is gene environment interact. And it is a spectrum of the diseases which run from dominant axial to dominant peripheral spondyloarthritis. So here we have already gone through this ankylosing spondylitis in detail. A few other topics are not touched upon, but I will be focusing on spondyloarthritis in psoriatic arthritis and the part of inflammatory bowel disease. So basically the common features of all this spectrum is there is familial clustering, there is a strong association with HLA-B27, there is an axial joint involvement, it is an asymmetrical peripheral joint involvement pattern, and with the involvement of enthesitis, some extra-articular signs with dominant involvement of skin, gut and eye, and these are all immune-mediated inflammatory disorders. Coming to pregnancy, which is a very peculiar physiological condition that has got many potential interactions with rheumatic diseases. For a normal pregnancy, a normal individual also has a social, emotional, physical challenges, and then you can imagine a case of spondyloarthritis with pregnancy. There are many maternal immune system adaptations which are occurring for a fetal survival, and that's how they are interacting with our inflammatory immunological disorders as well. So there is suppressed cell-mediated immunity responses, there is decreased lymphocytic function, there is rise in complement levels as well as immunoglobulin rise, there is a dominant Th2 cytokine profile, that's why few diseases flare up and few diseases don't flare up during pregnancy. And there are physiological changes occurring in various organ systems all throughout the body. So few of them like 30 to 50% rise in the intravascular volume, that can lead to puffiness of fingers, puffiness of pedal edema, which is there commonly seen in third trimester, which can be mistaken for arthritis flare at times. There is a raised glomerular filtration rate that can cause increased protein excretion through the urine. That can also masquerade some of the protein excretion investigations during SLE. Then there is a ligamentous laxity because of the hormonal milieu, which can cause increased arthralgias during pregnancy. The change of posture, obviously more of lordosis can cause precipitation of more of back pain, and that too with already having inflammatory back pain can further add to their problems. Lab parameters which we use for monitoring the disease activity can also at times be mistaken because of this physiological changes. There is a hemodilution occurring which can cause a relative anemia. 8% of normal pregnancies can have thrombocytopenia. The leukocytosis can also be a feature of normal pregnancy. There is a raised ESR, so that particular parameter we can't really use to monitor the disease activity during pregnancy because of the elevated ESR right from baseline. So what are the effects of pregnancy on axial spondyloarthritis? When we go through the literature, there is no consistent pattern seen of this spondyloarthritis activity across the duration of the pregnancy. So whatever literature available, they say 1/3 of them remain stable, 1/3 do flare up during the pregnancy, and 1/3 they are improved, they are in remission. The highest disease activity and the worst self-reported pain is generally during the second trimester of the pregnancy. And the risk factors for this kind of flare during the pregnancy are mainly the higher disease activity right at the time of conception, or discontinuation of medication at the time of pregnancy. Once the pregnancy is detected, many are afraid of medications. So there have been few systemic reviews and meta-analysis which are available to find out about this pregnancy in axial spondyloarthritis and outcomes of pregnancy. What is the effect of pregnancy on outcomes? And here again, there is no causal relationship as such between the axial spondyloarthritis and the infertility. But miscarriage rates have been found to be around 15% in pregnancies with axial spondyloarthritis. Caesarean section rates are higher, both elective as well as emergency. There has been increased prevalence of some pregnancy-related complications like preeclampsia, intrauterine growth retardation, small for gestation, and preterm deliveries. There are few technical issues during planning of these cesarean sections or any surgical interventions because of the difficult airways due to the limited neck mobility caused by ankylosis of cervical spine. There is difficult epidural catheter placement and spinal anesthesia again because of the narrow intervertebral spaces and structural changes caused by this spondyloarthritis. And at times the normal labor becomes difficult because of the involvement of the hip joints. So basically one needs to assess the position of hip as well as the neck while assessing the rest of the pregnancy parameters. So medication, I'm not going to go into details because Praveen had already really given a very nice talk on, exclusive talk on this. And these are the medications which are safe during pregnancy, which generally sulfasalazine and anti-TNF inhibitors. These are the two which we use for spondyloarthritis patients. So generally during the first trimester and the second trimester, and the third trimester, as well as during the lactation, sulfasalazine is the safest drug. Then low-dose steroids can continue. Anti-TNF inhibitors, as he had already given us an idea, in third trimester we do stop. Non-steroidal anti-inflammatory agents we can use after the conception or if required during the first or second trimester, but not beyond 30 weeks of pregnancy. But total contraindicated drugs, methotrexate, leflunomide, jackinibs, and non-TNF biologics. So what are the general principles for successful pregnancy outcomes? The effective and safe contraception, which is really critical for patients with severe disease activity and need to counsel them regarding teratogenic medications. Careful planning and timing of pregnancy is important to be discussed with all married patients, and planning to be done especially during minimal or no disease activity. Pre-pregnancy assessment for the disease activity as well as medication safety is important, and ultimately it all needs a team approach, a good approach by a rheumatologist, the gynecologist, and patient and her family as well. Now coming to the other extra articular manifestations, especially in the gut and the skin. So are there any real links between this? But yes, people are searching for those links, and there have been ties that bind the skin, gut, and the spondyloarthritis. So the epithelial joint axis is being established. The IBD and psoriasis, they have strong links with spondyloarthritis at all levels, clinical levels, the genetic levels, the immunological levels. They have a shared risk factors. Type 3 immunity, especially the interleukin 17 and 23 dysregulation, are important and playing a central role in this inflammation. Along with that, a new concept of this microbial dysbiosis is also noted in each of them. So these are the few figures showing some genetic risk factors which are shared and which are some exclusive to that particular entity of the disease. Then there have been postulates, there have been causal hypotheses, there have been comorbid hypotheses, where these epithelial inflammations are leading or landing up with inflammation at different sites, but still more information is awaited and research is on. Coming to inflammatory bowel disease and seronegative spondyloarthritis, 10 to 15% of inflammatory bowel are complicated by SSA. And almost 2/3 of seronegative spondyloarthritis do have either a clinical or subclinical intestinal inflammation which simulates IBD. The spinal involvement is around 10 to 20%, peripheral joint is around 5 to 15%. Peripheral joint involvement more commonly seen with Crohn's and more with large bowel involvement. And as we said, the SSA can have intestinal inflammation, either an acute one or a chronic inflammation. The axial involvement in inflammatory bowel disease can be just isolated sacroiliitis, which can go unnoticed or symptomatic at times, and generally is associated with non-progressive disease. But at times it can be an axial spondylitis, frankly, with strong association with HLA-B27. It can precede the onset of IBD. The course is independent of IBD, and it can be associated along with that with uveitis. And peripheral joint involvement, again 2 patterns have been described, the type 1 pattern and 2. Type 1, less than 5 joints, they are commonly involved is knee. The acute onset, they are generally self-limiting, and the activity generally coincides with IBD activity, and they have an association with HLA-B27, B35. Well, type 2 is more than 5 joints involved. This is mainly like symmetrical metacarpophalangeal involvement. Then they are chronic course, they are persistent activators. The activity is independent of IBD activity. So you cannot predict the arthritis and correlate the arthritis with the IBD activity as such, and a strong association with uveitis with HLA-B44 association. But generally IBD arthritis are non-destructible and non-erosive. Then what are the differences in phenotypes of classic AS and AS with inflammatory bowel disease? So there has been some findings and observations. The onset of classic AS, as we have seen, is young males generally, onset 3rd decade, with severe axial disease and strong HLA-B27 positivity with more severe radiological changes. I'll come to the radiological pictures a little later. And ankylosing spondylitis with inflammatory bowel disease, the onset can be at any age, equal sex distribution. They are less severe axial disease, less HLA-B27 positivity, and milder radiological changes. So medical treatment, again Avinash has covered it well. So non-steroidal anti-inflammatory agents, little deviation, mild arthralgia, axial disease, very helpful to control the symptomatology, but caution needed in inflammatory bowel disease condition, where COX-2 inhibitors would be preferred as an NSAID to control the mild activity. Disease modifying agent, sulfasalazine, yes, definitely has a good efficacy in controlling the arthritis and has proven role in ulcerative colitis. Methotrexate also has been shown a utility in Crohn's as well as efficacy for arthritis. Coming to these anti-TNF agents, he has already described in detail. Infliximab is an important one because it shows a good response, especially in moderate to severe Crohn's and ulcerative colitis. It controls the axial disease activity, the peripheral disease activity, as well as the bowel activity. And it is also playing an important role as a steroid sparing agent for colitis and fistula closure and mucosal healing. So definitely scores high over other anti-TNF agents. Etanercept doesn't show much role in colitis. When associated colitis, it is not the drug of choice. Interleukin 17 has been shown a very important role, especially in psoriatic arthritis. So secukinumab, ustekinumab, that is another agent, and JAK inhibitors, which are the newer agents showing. Psoriasis and arthritis, we see different patterns of psoriatic arthritis, something like rheumatoid arthritis-like presentation, asymmetrical oligoarthritis, then there is an axial spondyloarthropathy and arthritis mutilans-like thing with classical nail and skin changes. So dominant spinal manifestations are uncommon in psoriasis, but still seen in 40 to 70% when we take radiographs. Clinical presentation differs from that of axial spondyloarthropathy because patients do showing, they are older at the time of presentation. They show less of the inflammatory back pain, less of the limitation of the movement, and equal sex distribution. 30% of the spondylitis may not have sacroiliitis, and they are HLA-B27 negative. Unilateral or asymmetry is supposed to be a hallmark for psoriasis. Syndesmophytes, I'll show them. Cervical involvement is more common with psoriatic spondyloarthritis, and even atlantoaxial subluxation, which we've seen with rheumatoid, can be a complication of psoriatic as well. There are two phenotypes also being now considered by more and more research into psoriatic spondyloarthritis. So this is in a ZIS, the cervical involvement is more common, more frequent fusion of facet joints in cervical spine in psoriatic phenotype. In thoracic and lumbar, non-marginal, chunky, large syndesmophytes, but less symmetrical. Syndesmophytes may occur in absence of sacroiliitis as well. These are a few of the X-rays. Right ones are classical ankylosing spondylitis with symmetrical, ongoing, continuous kind of syndesmophytes. Yeah, 2 minutes. Yeah. And these are Romanus lesions and Anderson lesions, which they always comment on MRI, which are actually the marrow edema lesions. Asymmetry and symmetry that has been highlighted. So this is in nutshell the differences between classical axial spondyloarthritis and axial psoriatic spondyloarthritis. And ultimately, I want to just highlight on the treatment part, the NSAIDs, TNF inhibitors, interleukin-17 inhibitors are all effective for the treatment of axial spondyloarthritis, classical one. And this TNF inhibitor and interleukin-17 has been extrapolated data for psoriatic spondyloarthritis, but there have been some positive data on use of interleukin-12 and 23 inhibitors. So more and more data is coming on that. So this efficacy of NSAIDs and TNF is assumed based on axial spondyloarthritis data. So that is how the presentation in psoriatic spondyloarthritis. That's how. Thank you for the organizers for the time given.
Thank you, Dr. Vajayanti Lagu Joshi ma'am, for special information and discussion. I request chairperson to felicitate our speaker. With this, we end the symposium on spondyloarthropathy. I request Dr. Swami sir, Dr. Rajendra Agarwal sir to felicitate our chairperson. I request Dr. Pooja sir to felicitate our chairperson. I request Dr. Kamatkar sir to felicitate our chairperson.
Hello. Good afternoon, everyone. I would like to thank Dr. Asim Saifan for his anchoring since morning. We will now start with the next session. Our next topic is on adult onset Still's disease. For this, I would like to call on the stage renowned rheumatologist, Dr. Rohini Samant from Mumbai. She has more than 20 years of experience in the field of rheumatology. She is currently a senior consultant in Hinduja Hospital. Along with it, I would also like to call Dr. Ajit Nalavde, Dr. Dilip Apte, Dr. Yogesh Somani as chairperson for this session.
Very good afternoon to all of you, and I'd like to thank the organizers, Dr. Bichale, Dr. Rai, for giving me this opportunity, and also for giving me some extra work, which made me, do a bit of more of reading. So anyway, for today's topic is adult onset Still's disease. Now, we are all physicians here, and I would like to ask the non-rheumatology physicians, I mean, how many of you have come across Still's disease in your practice? Anyone? Yeah, so there is a fair number of people who've seen Still's disease. It's a rare disease, so we start with a case, and this was a 20-year-old. This was in the early years of my practice at Hinduja. She was admitted in 2003 for evaluation of PUO. She had sore throat at onset and arthralgia, and she had a typical evanescent rash with the fever. So historically, she fit in fever, rash, arthralgia, sore throat. Investigations revealed anemia, leukocytosis, platelets were raised, and there were increased transaminases. The other tests for other infections, X-ray chest, echo, etc., cultures were all negative. So a clinical diagnosis of Still's was made, and she was put, a high ferritin also came, the test result came, and that was high. which supported the diagnosis. So she was put on oral steroids, methotrexate, hydroxychloroquine, and she improved with this. So this was a very typical presentation of a Still's disease. Now what followed was something different. So she was from Nanded, and she called up at that time, and she said that she was not tolerating methotrexate. And I advised her to start cilazopirin, which she took for 9 days, and subsequently she landed up in Hinduja hospital with a terrible complication. Okay? So what happened was she developed high-grade fever, an extensive erythematous rash all over the body, mouth ulcers, angular stomatitis, odynophagia. She had an episode of bad melena, which dropped her hemoglobin to about 5 gram%. And her platelets had dropped to 55,000. Her WBC count was still high at 30,000. Her SGOT-PT were markedly raised. Her PT, APTT were both raised. And she was actually bleeding from the mouth. Her serum ammonia was raised. So she was in early hepatic insufficiency. A clinical diagnosis of macrophage activation syndrome was made, and she was initiated on oral cyclosporin, about 150, and then increased later to 200 milligram per day. And the subsequent reports confirmed the diagnosis with a very high serum ferritin and increased triglycerides. So this was one of the rarer complications of Still's disease, what we understand as macrophage activation syndrome, which was relatively early at that point in time. But thankfully, she made a very dramatic recovery, and she had a monophasic course, and therefore she is completely off treatment now. So now coming to this disease, which is rare but very important for physicians to recognize, and 7th September, which is close to our conference date, happens to be Still's Disease Awareness Day, and Still's has been represented by a dragon, okay, which is a sign of sort of danger. And it was first described in pediatric age group by George Still in 1896. However, adult onset Still's disease was described much later, only in 1971 by Bywaters, and it's quite rare, as you can see. It's only 0.1 to 0.4 cases per 1 lakh people. And the peak age of seeing Still's is between 15 to 25, and the second peak is 36 to 46 years of age. So generally young adults, okay? Now this is a disease which absolutely sits on the fence between autoimmunity and autoinflammatory disease. So you have a lot of native immune cells, the neutrophils and the macrophages which are involved, and also the adaptive immune system, that is the T cells, the NK cells which are involved. The T cells obviously releasing the Th17 cytokine, which has been implicated more recently in the pathogenesis of Still's. But neutrophils play a very important role. So these are in a nutshell the clinical features. We went through that in this patient: fever, sore throat, hepatomegaly, splenomegaly, myalgia, rash, arthralgia, and serositis. These are the most common features. A little bit more of the fever, because as physicians, how is this fever? The patient typically is quite well, except for the fever. When the fever comes, there is a feeling of sickness. But otherwise, the patient tends to be quite well. And it's a daily recurring fever with temperature coming absolutely down to normal in majority of patients. But in few patients, it does not completely drop. It can obviously present as a PO. And usually it occurs a little late in the day, that is an evening rise of temperature. How is this rash? Now the rash usually accompanies the fever. It's a macular rash, salmon colored, classically in fair skinned people, not so much in our population. It's evanescent, it disappears after the fever, and sometimes it's pruritic, but usually non-pruritic, and usually seen on the trunk and extremities. Sometimes you can see Koebner phenomena, and the histopathology is non-specific. There's nothing very classical of Still's. The arthralgia and arthritis is an important feature. Now, initially there is only arthralgia or maybe some swelling of the joints which affect the knees, the wrists, ankles, elbows. But as the disease progresses, and those who do not have a monophasic phase of the disease, they tend to have a chronic polyarticular arthritis which can be destructive and can be associated with ankylosis of the wrist and ankylosis of the ankle. So these are some typical features of the musculoskeletal system. What are the other striking lab abnormalities? So other clinical and lab abnormalities, we already mentioned the sore throat, the hepatomegaly, some elevation of transaminases, lymphadenopathy and splenomegaly. And therefore, when a patient comes like this, you really need to exclude a lot of infections and sometimes malignancies. As I said, serositis, so pericarditis, pleural effusions, transient pulmonary infiltrates. And the lab features we've already spoken about: leukocytosis, thrombocytosis, raised ESR, CRP, and hepatic transaminases. One important thing is that you should, if you have a patient with arthritis, you do a rheumatoid factor, isn't it? And in 95% of patients with Still's, this is going to be negative. So if you have a positive rheumatoid factor, you have to rethink this diagnosis, okay? And ferritin has been considered as a very important marker of active disease. However, as you all know, it's a very non-specific marker, okay? So it has to be looked at in the light of the clinical context. And generally more than 5 times of normal is taken as an important elevation, and it's a sensitive test, but the specificity is very low. And just to take you quickly through these Yamaguchi diagnostic criteria, these are predominantly clinical criteria, as you can see. And the 4 major criteria are fever, which if you go back to our patient, she had fever, arthralgia, and a rash, and leukocytosis, okay? So you need at least 2 of these major criteria to be fulfilled. Of the minor, sore throat, which also our patient had, lymphadenopathy, hepatomegaly, splenomegaly, and abnormal liver function. However, the most important thing about Yamaguchi criteria is you absolutely need to exclude infections, other autoimmune diseases, and malignancy before you can call this patient as a Still's disease, okay? And this is another criteria which also is very similar, so I won't go into that. The disease patterns can be monophasic. Like our first case, this girl was very sick, but within 3 months she had completely remitted, and after that she's been on just telephonic social contact with me. She's completely well, got married, has had children after that. So that which lasts for less than a year is a monophasic illness. Intermittent pattern is when there are intermittent flares, and usually this is, these episodes last from weeks up to 1 or 2 years. And a chronic pattern which we do see and is a difficult pattern to treat is this severe chronic polyarticular arthritis, which can be erosive and damaging. So this, when it occurs, it does lead to damage in these young patients. Now this is our data, courtesy our fellow, Girija, and of course we had a paper earlier with Dr. Sunil Singh, who had published half of these patients, and then we added on these and about 25 patients. And here the mean age was 32 years, majority were male, and there was a delay, diagnostic delay in the diagnosing. It was about 9 to 10 months. And as you can see, fever was seen in all patients, and rash in about about 3/4, and articular symptoms were there in almost all patients, and sore throat and weight loss also in a significant number. So again, nothing much different. There was thrombocytosis, leukocytosis, elevated ESR, ferritin, hepatic enzymes, and the arthritic patients had a chronic polycyclic pattern which was refractory to conventional DMARDs in about 4 patients. So how did we treat our patients? All of them received NSAIDs initially. Steroids, methotrexate, chloroquine were added so as to get the patients off the NSAIDs, and in some patients where methotrexate did not work, or sometimes cyclosporin was introduced as an initial treatment because we found good responses, it led to dramatic recovery in some patients. And one patient responded only to tocilizumab. Another received abatacept because the only reason being it was available free at that time and it was used for resistant disease, but she did not benefit. One patient, as I mentioned, had macrophage activation. And 2 patients, these are to be noted, one patient had stills after COVID, this is a very recent patient, and one patient was an elderly one who was being treated as stills and then went on to develop a cholangiocarcinoma. So these are the few different manifestations. And differential, I can't read this slide, but suffice to say that we need to exclude infections, malignancies, other autoimmune disease, drug reactions before we can call this stills. And now coming to the treatment. So, as I mentioned, the initial fever often responds very well to the steroids and NSAIDs and then steroids. For the joints, one needs to add methotrexate and then further, if there is no response to methotrexate, we do use cyclosporin, but these are Western charts, and therefore what they recommend is that if you have articular refractory disease, you can use anti-TNF alpha agents or anti-IL-6 agents. For systemic disease, anakinra has been recommended, but we don't have it. But tocilizumab is very, very effective for systemic disease. So I thought my presentation should be a little brief so that if we have some time, we can use it for questions. So the take-home message is that for physicians, normally stills is very common, more common in the juvenile population. So you need to keep a little higher index of suspicion to think about it in the adult patients. And often sometimes, we associate diseases, ferritin high hona chahiye, but then we are not happy if the ferritin is 1000, okay? So, but the ferritin may not necessarily be high. Remember, it's not even in one of the criteria, but it's a supporting criteria. Sometimes the patient doesn't have arthritis, has predominantly systemic features. So you have fever, serositis, and increased transaminases. It can be a bit confusing, okay? But if there is some leukocytosis, and if all the autoimmune tests are negative, think of stills, okay? We need to exclude absolutely infections and malignancy. The arthritis is often a problem. I have faced with several of these patients, at least a fifth of these patients, and usually the outcome is very good. However, the patients that we lost was someone who came primarily with a macrophage activation syndrome, one of the patients that we lost, and the second one that we lost was due to the malignancy. So if we preempt macrophage activation syndrome, this disease, I think the outcome has a 2% mortality is what the textbooks say for Still's disease. So thank you very much, and if we have time, I'd be happy to answer.
Due to time constraints, we can take only 1 or 2 questions.
So this dragon can be beaten is what I wanted to say. Sorry? Yes, of course. PET scan now has become so easily available, and it's a very important, useful test when you're suspecting malignancy. Particularly when you have an older patient and you're not sure, you need to exclude malignancy or even any other infection. So I think PET scan would be useful to rule out malignancies or infections, not to rule in stills. It doesn't help in stills. So I'm happy to be in this city of yours, which is, I understand, going to be a smart city. And we've already got these lovely gifts and some other things that we are hoping to buy soon. Thank you.
Thank you, ma'am. Introducing the case report as well as the case series from your experience helped to understand this difficult and rare disease. I request the chairpersons to felicitate Dr. Samant, ma'am. Dr. Venu sir and Dr. Prashant Dhon sir, I request you to be on stage to felicitate chairpersons. Coming to our next session, infections and rheumatology. Our next topic of chikungunya, I would like to call on dais our own API Latur member, Dr. Mohini Ganu from Latur. She has multiple years of experience in the field of rheumatology and she is one of the organizing chairman of this conference. For the panel, I would like to call Dr. Lata Bichle ma'am, Dr. Shubhadha Lohia ma'am, Dr. Suhas Karkamkar sir.
Good afternoon, everyone. Should I thank the organizers? Yes, I must, because they have given me opportunity to present my data in front of my teachers and colleagues who have helped me immensely while exploring chikungunya. In today's lecture, I will be touching upon epidemiology and will be focusing more on post-chikungunya chronic arthritis. That is my topic of interest. The definitions that I am going to use are acute chick is one with onset less than 15 days, prolonged chick defined as 16 to 3 months onset or duration, and chronic chick will be henceforth called as PCCA with more than 3 months duration. So when we had patients of febrile polyarthritis in our OPD, we had many queries in mind. Is this chick? We had no way to confirm that time in 2006. How long is it going to last? We had no answer to this question. Does it cause chronic arthritis? It was not described earlier. And is it fatal? We were seeing fatalities, but were not described. So till that, we had an opportunity to study more than 2,500 patients. We have recorded and preserved data in all, and most of these patients are under regular follow-up. What we found, that time was the patients presented with febrile polyarthritis plus minus rash with multi-system involvement, almost all systems involved, and 12 to 13% patients developed chronic disease, and we saw few fatalities as well. Our data on systemic manifestations and long-term manifestations was presented in JAPI. Chopra sir also conducted a study during that period at his Big One Center. It was a 2-year prospective community study, and their observation showed high attack rate and patients presented with febrile onset of musculoskeletal illness. Females outnumbered males, and most of these patients were seropositive for chikungunya. A peculiar finding was 4 to 8% of healthy adults were positive for IgM, IgG chick, and that indicates subclinical transmission of disease. Though most of the patients recovered, 16% of patients had musculoskeletal pain and 4.1% developed chronic arthritis. The treatment of chikungunya remains symptomatic with rest, hydration and analgesics, and CDC warns against use of corticosteroids in viremic phase of the disease. Chikungunya has become endemic and multiple outbreaks are erupting since then. What we found was the major outbreaks in 2010 and 19. The difference was these were smaller outbreaks as compared to 2006, predominantly arthritogenic presentation without other system involvement. This is the rash of chikungunya, maculopapular rash, conjunctival congestion, then this is synovitis and edema feet. This is extensive exfoliation of the skin, perioral pigmentation, here pigmentation and nodules over hand. This is my staff who acquired chikungunya last month. He has developed extensive pigmentation on nose, on face and hands. Again exfoliation. This is another patient with rash over pinna of the ear with swelling. When patients started coming back after 3 months of treatment, we were curious whether we can, we knew that the chronic disease is occurring, and we were curious whether we can predict chronicity in these patients. So we took up another study, this is yet unpublished, and what we found as elderly persons, females, those with a higher number of larger joint involvement, soft tissue rheumatism, peripheral neuropathy and high SR, these are the patients who are likely to go for chronicity. So again, further questions in mind, how long is it going to last? What are the clinical features and long-term prognosis of these patients, and how to treat, and are disease modifying drugs effective and safe in these patients? The clinical profile of chronic chikungunya arthritis, most common is RA-like symmetric polyarthritis. Few patients present with soft tissue rheumatism, fibromyalgic picture, rarely peripheral spondyloarthropathy-like or undifferentiated arthritis-like presentation. So we took up study on chronic chikungunya patients with the aim to study clinical and laboratory features of PCC and effects of disease modifying drugs, and this was published in 2011. We included all confirmed cases of chikungunya without pre-existing arthropathy and having chronic arthritis, total 16 patients with follow-up of 2 years. What we found that multiple family members were affected in most, 93%. It was chronic, in all it was chronic inflammatory polyarthritis that was symmetric in nature, involvement of large and small joints of hands and feet, and DIP joint involvement in 12.5% of them. Soft tissue pain, which is lancinating pain, fatigability, tenosynovitis, bursitis, effusions. One patient had flexion deformity of hand here, and bilateral edema of hands and feet resembling RS3PE. It was present in this patient. This is unilateral edema with bilateral synovitis. We could do biopsy in only one patient. We showed hyperplastic congested synovium with dense infiltrates with lymphocytes, plasma cells, polymorphs, sublymphoid follicular aggregates, congested blood vessels and proliferating fibroblast. However, we could not isolate viral RNA in these patients. CBC was unremarkable except thrombocytosis that was seen in 2 patients. Markers of inflammation, however, were raised in all these patients. Serology showed most of them to be seronegative for rheumatoid factors. CCP antibodies were positive in 56.7%, and both the antibodies were positive in 1 patient only. ANA and ANCA was negative and all, biochemistry was unremarkable, X-ray showed erosive disease, and synovial tissue did not reveal RNA isolation. So these are the erosions on X-ray, condylar erosions. Then this patient had marrow edema and Becker cyst and suprapatellar pouch effusion. The disease activity score showed, DAS28 showed moderate to severe disease in all, and all of them had received hydroxychloroquine and NSAIDs in prolonged phase of the disease. So we added sulfasalazine in standard doses along with low dose steroids. Good response was seen in only 12.5% patients. Most other patients had moderate to poor response. After 3 months of sulfasalazine therapy, we added methotrexate pulse doses, and the response was good in most of the patients. Very few patients had poor response. There were no major side effects. So disease modifying drugs we found to be effective and safe for the management of post-chikungunya chronic arthritis. Other observers also studied these drugs during that same period. A study by Dr. Pandey showed effectivity of methotrexate and hydroxychloroquine in 49% patients. Study by Dr. Ravindran, he compared hydroxychloroquine corticosteroid low dose along with with second group with hydroxychloroquine, corticosteroid, methotrexate and sulfasalazine, and found the second improvement in second group in disease activity, disability and pain score. International studies by Javel again reveals clinical improvement in 75% of these patients, and a Latin American study also quotes improvement after methotrexate and sulfasalazine therapy. Those who fail methotrexate or disease-modifying drug therapy, Bocquillard and Combe, they used TNF inhibitors, etanercept 4 and adalimumab in 2 patients, and all patients responded well. So this is a chart showing same the disease-modifying drugs. Other patients also researchers have also used ribavirin and colchicine. Colchicine is especially effective when there is only arthralgias and no active arthritis. Certain French guidelines are laid by, in certain countries, they have studied and laid the guidelines. So French guidelines, they advise use of disease modifying drugs according to the clinical stage of the chronic inflammatory rheumatism in these patients. Brazilian guidelines recommend methotrexate and hydroxychloroquine along with low dose corticosteroids in these patients, and use of biological agents like TNF inhibitors whenever indicated. However, unfortunately, there are no Indian guidelines available. So after seeing the clinical pattern of symmetric arthritis response to disease-modifying drugs, we were curious whether we are treating the same disease. Is it the same disease, PCC and RA? So what we found, our observation showed that affection of multiple family members, initial febrile polyarthritis, acute or explosive onset disease, DIP joint involvement, soft tissue pain and edema of hands and feet was a feature of post-chikungunya chronic arthritis that was lacking in RA, and extra-articular features and R factor and CCP positivity are the features of rheumatoid arthritis. So coming to the pathogenesis, like any viral infection, during early phase of the disease, it is the innate response by innate cells, monocyte disease and NK cells, and innate cytokines. Interferon alpha provide first line defense. IL-6, it is an endogenous pyrogen responsible for pyrexia, and IL-7 and 15 responsible for joint inflammation. In early convalescence, it is the innate and T cell response with tendency to tilt towards Th2, which is anti-inflammatory one. NK cells assist in viral clearance. NKT cells through secretion of interferon alpha, TNF alpha and interferon gamma have a disease promoting role, and neutralizing antibodies assist in viral clearance. IgG antibodies day 5 onwards and IgM in day 5 onwards and IgG3 later on. Recovery phase is the crucial phase in the course of the disease. Patients have secretion of various growth factors during this phase, and when the patients have secretion or a more hepatocyte growth factor along with eotaxin, It has a Th2 type of response with less monocyte macrophage activation and muscle regeneration. And these are the patients they go for recovery. When there is NK-NKT cell dysfunction along with increased GM-CSF secretion, these patients have a monocyte macrophage activation, Th1 profile, and they land up in chronic disease. So we were also curious to know what is happening in our patients. So further studies were done in collaboration with NIV Pune under ICMR, and all clinical data was provided from my center. So we studied the phenotype and functions of NK and NKT cells in PCCA and RA, and this was published in Human Immunology in 2017. What we found was percentage of NK and NKT cells was decreased in both the disorders. Perforin expression of NK cells, that is decreased in RA and PCCA, whereas TNF alpha and interferon gamma NKT cells, that is increased in both the disorders. Perforin expression of NK cell, however, is increased in RA and decreased in PCCA. So perforin NK cell expression and TNF alpha interferon gamma NKT, these are the markers of both the inflammatory arthritis, whereas perforin NKT expression is a differential marker. Same thing again, and TNF inhibitors, since there is increased secretion of TNF alpha, TNF inhibitors could be a treatment strategy for treatment of PCCA. Then we studied the NK-NKT cell functionality and differential inhibiting and activating NK cell receptor levels in these patients in different stages of chikungunya. And what we found that NK cells were dysfunctional, NKT cells have a pathogenic role, and there is upregulation of inhibitory receptors and downregulation of activating receptors. And it is the deregulation of NK cell receptors expression that is responsible for defective cellular response in PCCA. We all know T regulatory cells modulate the antiviral response or modulate the response in viral infections. So we studied the role of T regulatory cells in different stages of chikungunya, that is acute, chronic, and compared it with rheumatoid arthritis and controls. What we found was there is Treg and T effector cells increased in RA and decreased in PCCA. However, their ratio is reversed. It is decreased in RA and increased in PCCA. And IL-10 secretion, which is decreased in all stage, it increases during recovery phase. So it is the balance between Treg and T effector cells that modulates the magnitude of effector response. IL-10 and Treg cells are associated with recovery, indicating their protective role in PCCA, and Treg and T effector ratio, which is high in PCCA and low in RA, indicates different mechanisms of Treg mediated pathology in RA and PCCA. Coming to the genetic factors, we know genetic factors do affect the course or outcome of viral infections. So we studied IL-1RN, which is an inhibitor of IL-1, the levels of IL-1RN in acute and chronic stages of chikungunya, and the association of IL-1RN genetic polymorphism with chronicity. So what we found, this study was published in Medical Virology in 2019. What we found was IL-1RN11 genotype, this has high risk of chronicity, and IL-1RN2 genotype, it has a protective effect. And also IL-1RN levels affect the pathogenesis of chikungunya. Thus, in nutshell, acute chikungunya can cause multi-system involvement. PCCA mimics rheumatoid arthritis with few clinical differences. DMARDs are effective and safe in PCCA. It is altered NK receptor expression and dysfunctional NK, NKT and Treg cells that are possibly involved in pathogenesis of PCCA. TNF alpha interferon gamma are probable mediators of chronicity, and altered Treg effector ratio in PCCA and RA indicate different mechanism of Treg mediated pathology in PCCA and RA, and genetic factors do influence the outcome of chikungunya infection. So though RA and PCCA, they clinically look similar, the pathogenesis is different. Thank you very much. This was the slide taken, this was the photograph taken by me in Sri Lanka. I always like to equate it with the chikungunya disease, there are bright spots of information that are available, but there are many gloomy areas which we need to explore, and the path ahead is not smooth. Thank you very much.
Thank you, ma'am. Viral infection like chikungunya, which we see so often during our day-to-day practice, was very well pictorially presented. I request Dr. Lata Bichle ma'am to felicitate Dr. Mrs. Mohini Ganu ma'am.
Before I felicitate her, I must say here that Ganu couple and their son, they work like an institute. It is one of the best research papers under the guidance of Dr. Chopra, and many times she has consulted me as to how to go ahead with the further research. I also thank the NIV of Pune for collaborating for this work from a rural sector. I have gone and seen her OPDs of chikungunya, and I was surprised how they can cope up with such workload with the proformas in place and more than 5 to 6 publications from a rural area. So I congratulate that family who work like an institute. It's an example how a doctor can start research from her office, as was highlighted by Dr. Chopra. Personally, I would like to give them a standing ovation. Thank you very much.
Thank you very much, madam, for your kind words, but it is yours and Dr. Chopra's blessing that made us go to this level. Thank you.
I request Lata Bichle ma'am to felicitate Dr. Ganu ma'am. Coming to our next topic, post-COVID autoimmune syndromes, I would like to call upon the dais Dr. Amit Dravid to take the stage. He is infectious disease specialist who hails from Pune with a special interest in HIV.
Thank you. Thank you, IMA Solapur. Thank you, IMA Latur. Thank you, MRACON. Thank you, Rai sir. Thank you, Rudrakshi sir. It's so good to be back in Solapur, whom I consider my second home. And it's so nice to speak in front of all my teachers. I was taught by 3 rheumatologists, but I became an ID consultant. I'm going to talk about post-COVID autoimmune syndromes. In the morning, Shiv Puja madam told that today the world is divided into before COVID and after COVID. We have talked a lot about before COVID. We will now come to know what happens after COVID. So here we go. So viruses and autoimmunity is not new. There are multiple viruses which have contributed to autoimmunity. It started with Epstein-Barr virus, which was linked with multiple sclerosis. Then came CMV, then came HIV and HTLV1. HIV was associated with multiple autoimmune syndromes, and so establishment of viruses with autoimmune diseases is not new. We need a genetically predisposed individual, we need a hyperstimulated immune system, and then it causes an autoimmune disease. If it is left unchecked, it leads to lymphoma. So the sequence is very clear, and SARS-CoV-2, or the virus which causes COVID-19, has the ability to induce hyperstimulation of the immune system, and also has the ability to synthesize a lot of autoantibodies. That's why it is a trigger to multiple autoimmune diseases. So we all know that we have all seen the cytokine storm in SARS-CoV-2, or the cytokine release syndrome, where pro-inflammatory cytokines, namely IL-6, IL-1, IL-10, IL-17, TNF-alpha, are released in humongous numbers, especially in the second week of the illness, once the viremic phase is over. And then that leads to hyperferritinemia, that leads to ARDS, that leads to HLH, patient becomes breathless, lands up on the ventilator, and that's when all the critical care consultants and the ID consultants come into the fore. So hyperstimulation of the immune system is not new. It is seen in the second week of the illness. The first week is the viremic phase. The second is the host inflammatory phase, and that's where the immunity really goes haywire, causes hyperinflammation, and that is where the immune system of the body really wakes up, and that's where we use all our steroids, our tocilizumab, all our immunosuppressive agents are used over here. So this is the phase which actually wakes up the immunity, and this is the phase which wakes up the autoimmunity as well. So hyperstimulation is fine, but there are certain other factors which also is linked to autoimmunity in SARS-CoV-2, and the main thing is homology of primary sequences between the humans and SARS-CoV-2. So there are certain heptapeptides which are common among the virus and the human body. You might not be able to see, but there are almost 17 proteins which are more or less similar between the virus and the human body. So once the immunity wakes up, when the hyperinflammation occurs, the body doesn't know what is the virus, what is the human body, and it starts producing a lot of autoantibodies. And the third factor which is responsible for autoimmunity is something called as neutrophil extracellular traps, or NETosis. It is also becoming a big concept now, and we are in a study with NIV Pune about studying NETosis in post-COVID patients. What is NETosis? These are neutrophil extracellular traps. That means once the body's immunity wakes up, all the neutrophils flood into the lungs and they degranulate and they put out something which is called as net. The net is there to trap the virus, kill the virus. But once the virus is trapped, the virus is killed, what happens is the protein remains, the chromatin remains, and that protein or chromatin becomes a trigger for autoimmunity, and that is what autoimmunity gets triggered in COVID-19. So these three, hyperinflammation, NETosis, and molecular mimicry, are the three main factors because of which COVID-19 has become a big trigger of autoantibodies and a big trigger of autoimmune diseases. What are the autoantibodies which are seen in COVID-19 patients? The most common antibodies which are seen are the APLA group, antiphospholipid antibodies, which cause the antiphospholipid syndrome. So anticardiolipin, lupus anticoagulant, beta-2 glycoprotein, these are the antibodies commonly seen, and there are studies published now that 47% of severely ill COVID-19 patients had anti-ACL or anti-APL during their illness for COVID-19. Higher concentrations of lupus anticoagulant were seen in patients who were severe COVID-19 and developed thrombosis, or severe COVID-19 and developed pulmonary embolism. So APLA antibodies are the ones which are the highest, and the antibodies against phosphatidylserine and prothrombin are also very commonly seen in patients with severe COVID-19. These are just autoantibodies. These are not causing any syndrome that time. They are just awakened because of hyperstimulation of the immune system. What other antibodies are seen? 10.2% of the people with life-threatening COVID-19 also had anti-interferon antibodies. And remember, the interferons are the ones which cool down the immune system. Don't let it become hyperstimulated. Don't let it go into hyperinflammation. So if there are anti-interferon antibodies developing, automatically the check on the immune system goes, the patient goes into cytokine storm. Then they looked at whether ANA, ANCA, these antibodies are developed during cytokine storm, and they found that in severely ill patients, almost 25% of the people had a positive ANA, 6.9% people had positive ANCA. Without any syndrome, there was no joint pain, there was no SLE developing, but autoantibodies were definitely developing. Also, the titer of the ANA was linked to the titer of the CRP. So higher the CRP during cytokine storm, higher was the ANA titer, and the ANA titer went up to even 1:640. So scientists believe that the cytokine storm today is causing autoantibodies, but it might develop an autoimmune disease later. So the COVID-19 is finished, cases have come down, but it's quite likely that the autoantibodies which are produced because of triggering of the immune system today, if a second trigger comes, say 3-4 years down the line, more and more autoimmune diseases might be seen in patients, and rheumatologists will be the ones to pick up. So autoantibodies are detected. What are the autoimmune diseases which are described? The most common is GBS, Guillain-Barré syndrome, most commonly seen when the patient is admitted for COVID-19 and develops quadriparesis. Then we have also reported Miller-Fisher syndrome, polyneuritis cranialis, autoimmune thyroiditis, Graves' disease, all have been reported. In children, a self-limited vasculitis, which is Kawasaki's disease, that has been seen. Also ITP, Also, heparin-associated thrombocytopenia, which is associated with anti-platelet factor 4 antibodies, that has been described. Autoimmune hemolytic anemia has been described. SLE has been described. Viral arthritis has been described. Myasthenia gravis has been described. So all these autoimmune diseases have been described, and I am sure in years to come, more and more autoimmune diseases will be described as years to come, because autoantibodies are already created. So these are the autoimmune diseases which have been listed and which have been described, but I am sure in years to come we will have a bigger basket of autoimmune diseases which will be associated with COVID-19. So there are diseases and there are autoantibodies which are there because of COVID-19 in our body. Then what about olfactory manifestations? Everyone knows during the Delta pandemic, almost 70% of the patients developed just one symptom, which was either anosmia or parosmia. And now it is very clear that even this is because of an autoimmune phenomenon. Initially people thought that it is because of neuronal death in the olfactory bulbs, but no, more and more studies have shown that it's inflammation around the olfactory bulbs secondary to IL-1 or IL-6 which is causing the anosmia or parosmia. We published our paper on neurologic issues during severe COVID-19 in India, and we found that acute disseminated encephalomyelitis, acute transverse myelitis and GBS were the 3 neuroautoimmune syndromes described in our patients with severe COVID-19. Autoimmune COVID-19 is incomplete without talking about post-COVID-19 vaccine-induced autoimmune syndrome, and this is another big issue in the world nowadays, that people are taking vaccine, COVID vaccine, and remember India has 200 crore vaccinations being given in the last 1 year, and patients developing autoimmune syndromes. Most commonly it is molecular mimicry, but some believe that the adjuvants which are there in the vaccine, the aluminum salts, the oil in water emulsions, these are the ones which are causing the post-COVID-19 vaccine autoimmune syndromes. The most common is the vaccine-induced thrombotic thrombocytopenic purpura, which was diagnosed initially and it was known as VITT, vaccine-induced immune thrombotic thrombocytopenia. 200 cases were published recently in NEJM out of a total of 6 lakh people being given the vaccine. This is more associated with the vaccine we use, that is the adenovirus-based vaccine or the Covishield vaccine which India is given, and it is also seen with other adenovirus vaccines like the Sputnik vaccine or the Johnson & Johnson vaccine. So it is typically related to the adenoviral vector which is being used, and this is very commonly seen vaccine-induced immune thrombocytopenia and thrombosis. It is related to the anti-platelet 4 antibodies which are triggered because of the vaccine, and the patients normally are young females less than 50 years of age, and they come within 5 to 30 days of taking the vaccine with cerebral venous sinus thrombosis or DVT or pulmonary embolism or even myocardial infarction or peripheral vascular disease. So this is an immune phenomenon, this is an autoimmune illness, and most commonly it is cerebral venous sinus thrombosis which comes most commonly in 50% of patients. It was cerebral venous sinus thrombosis, and if you have a platelet count less than 30,000 and if you have intracerebral hemorrhage, then your risk of dying is almost 70%. So the disease is rare, 1 in 1 lakh people get it, but if you get it and if your platelet count drops to less than 30,000 and you develop cerebral venous sinus thrombosis, then your risk of mortality could be as high as 73%. So a rare complication, but a devastating complication if it develops, and it has to be kept in mind. But that does not mean that the vaccines are bad. The risk-benefit ratio of the vaccine is definitely in favor of the benefit, it's not towards the risk. This is a rare complication, and majority of the patients are treated with steroids or with IVIG, but if the patient has very low platelet count, people have even tried plasma exchange and patients have got better. Other post-vaccine autoimmune syndromes like, as I said, central venous nervous system demyelinating diseases, myositis, myasthenia, limbic encephalitis, autoimmune liver disease, ITP, IgA nephropathy, rheumatoid arthritis, Graves' disease, all have been explained. So it is associated with the whole host of vaccine syndromes. Also disease flares have been shown. That means patients who had rheumatologic diseases at baseline and they got vaccines, almost 10% of them had a flare of their disease, although they were on stable anti-inflammatory therapy. So if you have a patient who has SLE, rheumatoid arthritis, he is on treatment and you give COVID vaccine, then the flare can also be there and the patients have to be told about that. Similarly, leukocytoclastic vasculitis of the limb secondary to coronavac vaccine in China has been explained, and even glomerulonephritis secondary to vaccine has been described. And this is the picture. A patient in China was given the coronavac vaccine and post-vaccine developed leukocytoclastic vasculitis, which was biopsy proven and had to be treated with steroids. So this does occur, autoimmune syndromes do occur post-vaccines as well. Lastly, long COVID. Everybody knows that around 30 to 40% of patients who have severe COVID come with symptoms like fatigue, tiredness, dyspnea, emotional disturbances, anxiety, palpitations, joint pains, pins and needle sensation. And overall now, we are now come to the point where even long COVID has an autoimmune pathology related to it. The autonomic nervous system gets compromised. There are antibodies developed to the autonomic nervous system, because of which long COVID occurs, and now research is now directed towards immunomodulatory therapy for long COVID-19. And finally, our research on cytokine storm, which is, I feel, again an immunologic disease, and we have the largest series of patients with cytokine storm who were treated with another anti-inflammatory drug, which is tocilizumab, and we found that 74% of the patients did survive and 26% did not survive the cytokine storm. And now more and more anti-inflammatory drugs like even infliximab and etanercept are being tried for cytokine storm. So very clearly the cytokine storm of COVID-19 is also an autoimmune immunologic phenomenon akin to lung rejection, and anti-inflammatory agents are used there as well. So in conclusion, in similar manner to other viruses like EBV, CMV, SARS-CoV-2 also has an attribute to contribute to autoimmunity. There have been 15 separate types of autoantibodies and 10 distinct autoimmune diseases which have been described post-COVID-19. The most probable mechanism, as I said, a genetically predisposed individual, hyperstimulation of the immune system, molecular mimicry, and extracellular, excessive neutrophil extracellular traps. Despite the increasing number of reports regarding autoimmune syndromes secondary to vaccination, the incidence is still low, 1:1 lakh, and the benefit outweighs the risk. However, VITT is a rare but devastating complication of adenovirus-based vaccine, increasingly seen in women who are less than 50 years of age, and that's why Germany and other Europe had banned the adenovirus vaccine because of high risk of VITT. Autoimmunity also now seems to be one of the causative factors for long COVID, and immunomodulatory agents have a role to play in SARS-CoV-2 mediated cytokine storm to bring down the mortality. Thank you.
Thank you, sir, for enlightening us with one of the common issues we are facing during the current post-COVID era. I request Dr. Shubhda Lohia ma'am to felicitate Dr. Dravid sir. Coming to the next topic, mimics, infection and rheumatic diseases. I am glad to call on the stage Dr. Arvind Chopra sir, a very renowned rheumatologist and a dynamic orator who has more than 30 years of experience along with multiple awards in the field of rheumatology.
Good afternoon, everybody. Thank you very much for giving me this second inning in the day. Can I have the next slide, please? So, my job has been made much easier by my two very excellent preceding speakers. It's so nice to see that there is indeed research in the office setup, both in the urban and in the rural areas. I mean, these are very iconic, and I think they tell us that the future is bright. We certainly need to investigate our common problems in the Indian situation. Okay, I'll do that, right. Am I, the next slide, am I able to do it from, okay, yes. So, friends, So there's a lot which I'm not going to talk about, because as you have just heard that chikungunya is a great mimic, and COVID-19 seems to also be a great mimic, but I'll possibly give you my comments on that. So this is a case from my MD days, maybe 35 or 40 years back. I'm sure you read it. Any guesses? Get prejudiced by the source of this case. This is a time when I got inspired in rheumatology. Actually, my earlier days which I referred in the morning, that so many questions. This was possibly our very first experience in the department as well. We knew about syphilis. Those days syphilis was a great mimic. In fact, anything that you couldn't understand, you looked at syphilis. And this is not surprising if it comes from the armed forces background. That's why I said look at the source, then you could guess what the problem could be. But I'm sure that you're aware that we have not got rid of syphilis. A few years back, almost in epidemic proportion, syphilis was described from China in a New England Journal of Medicine. So, and then, yes, I didn't put that, otherwise the cat would have been out of the bag. So after I left these services and I came to the civil street, in very early part of my work in Pune, we held lots of camps, and I remember our very senior late Dr. Pispati was the one who actually initiated many of us into this camps, which was, they have their problem. Camps have got a lot of prejudices, biases, but they do tell us about community problems to some extent. And again, it was very surprising that that in this very large series of analysis, if I remember, infections were a great mimic. And to my surprise, even at that stage, I think we picked up at least one patient of syphilitic arthriostitis. Those are the mimics that we used to talk of those days, not to forget tuberculosis and Hansen disease. Also, it's important to remember from the previous experience, these camps were held in an orthopedic setup. But to remember that I don't see this now. Maybe some of you have seen in your medical colleges or, where there's a large number of people coming from the lower socioeconomic status who have been injected in the joints. But I want you to remember that iatrogenic problems, an injection which introduces infection of the joint, iatrogenic pyogenic arthritis, can certainly mimic an inflammatory monoarthritis, and so we need to remember some of the things. This morning I was not in I was much fresher in the morning, but I didn't show this slide. So let me tell you what a data can actually do. So I'm going to use this particular topic to highlight the requirement of creating, this is still not big data, but some of you know what big data is. This is the world belongs to big data. If you can create big data, then you can join the mainstream research, and medicine has to join that. And big data will only come when you collaborate, when you network. This may sound impressive that at this point of time I have something like 17,793 patients initial visit in my database in my center, and maybe about 2.5 lakhs if I include all the follow-ups. This doesn't happen overnight. You have to begin at a very early stage. And like I said, you should have the entire setup, etc., you got to set up. But this is what's required, at least in clinical research. When I got the invitation from you all to talk on infections, so I told my friend Anuradha, who's my microbiologist, I said, let's look at our data. We haven't really looked at infections in a bigger picture. This is, mind you, this is community referrals from all over Maharashtra. And interestingly, these are important, infections are important, but they're not more than 5 to 6% of the entire referral database in this particular setting. So let's now spend the next few minutes only on infections, and they are very important, but in a rheumatology setting in my center, the burden is about maybe 5% of the entire load, as you can see in this. Important problems are tuberculosis, Hansen's. As you can see, the rheumatic fever has become less. I have deliberately divided this entire data into the 10 years from 2000 and then again 2010 to 2020. But overall, you find the proportions are same. Viruses has sort of, galloped like anything. And I think chikungunya has increased our problems. There's no doubt about it. And I don't have any more answers than what Mohini provided to you through our research. It's a very exciting area. And then we have seen patients with hepatitis, mimics, viral fever, upper respiratory. I think maybe 3 patients with retroviruses, presenting as inflammatory polyarthritis. And COVID. I've left COVID blank. Purposely, I stopped at 2020 because I still think the jury is out. And I'll talk about what I think is about COVID and rheumatic diseases. So though we got lots of data in COVID, but that can wait another time. Yes, I am very fascinated by the chikungunya virus. As, in my opinion, no virus till date has had the propensity to mimic different types of rheumatic syndromes as much as chikungunya has done. And not only arthritis, but extra-articular manifestations. I don't know explanations. Just like Mohini, some of us keep on searching, researching, and we look at a lot of things to find out. Fortunately, we have got excellent animal models in chikungunya actually, which come very closely to mimic the human response. So chikungunya is a great mimic, but there were some, this is I don't want to go through this, just to impress you all with the numbers and the colors that we continue to see a lot of chikungunya. And someday maybe Mohini and myself can spend the whole day talking to you about chikungunya. Should not be surprised. Infections and autoimmunity are so much, there's a nexus. Again, this is a wonderful book. It's available now free of cost on the net. Please go through this book if some of you wish. It's Autoimmunity from Bench to Bedside, most written by Schoenfeld, who is one of the finest, the greatest clinical rheumatologists that I've ever heard. And he and his people from Israel and from Latin America. Great book. Very well written. In fact, they make a statement. Everything in clinical medicine is autoimmunity unless proved otherwise, quote unquote. That's what he writes. And I think to some extent that's true actually, because we're so difficult to define where the infection stops. Autoimmunity should stop there. But if the infection does not stop the autoimmune process for some reason that my previous friend talked about, that's what autoimmunity is all about. So let's forget about the details. To tell you that everything that you have in clinical medicine, in my earlier days, syphilis was a great mimic. If you ask me today, there's so many great mimics. It's not only chikungunya. You've got to think of so many diseases, especially in rheumatology. This is a slide, I think it's from Sjogren syndrome. Yes, this is one of the very beautiful things from that book on Sjogren. Everything that you see in Sjogren can be part of an infection in different situations. So there are a lot of mimics, but then I think I never realized, one of my most quoted actually papers in the literature today is this pictorial kind of one-page paper which was published in Indian Journal of Rheumatology, which I was editor. 2011, there was an issue on infections. And I think all our young friends must read it. Fellows must read this particular issue. A lot of people from India contributed, including, I think, Rohini has written a paper there as well. Infections and Rheumatic Disorders. Journal of Indian Rheumatology Association, 2011, supplement. Rage of the bugs. This is what the bugs can do. Now here I'm showing you a paper, a patient of mine who has been followed by me for several years, from Aurangabad, this lady is, and all of a sudden she gets right hip pain. Somebody rings up from Aurangabad and they say, well, I said, right hip arthritis is not very common in rheumatoid arthritis unless you think of an avian. But she said, this whole flare-up is only in the hip region. Because as you can, I've written, she was in good control for several years. And lo and behold, very soon she showed a typical severe lephnomide multisystemic toxicity with pancytopenia. Few days later, right thigh was a bulge which increased. Few days later, I was getting this notes from Aurangabad, ulcer just above the right knee, burst, pus. A liter of pus, surgical debridement, on and off, repeated antibiotics, etc., etc. See what happened to the hip? Completely. This is what the bugs can do. Surprisingly, despite so many attempts, we could not isolate any microbe, repeated cultures, etc. And later on, even the cerebral histopathology was done. Tuberculosis was very much on our minds. It was excluded. But this is the kind of thing that we see in an era where we use so many antibiotics. But the good part is, the best part I would say of this case was, which was learning for me, then after such good orthopedic surgery, she went through a hip replacement and she came walking to my clinic after 9 months. This is possible. But that doesn't mean that the bugs are our friends. Bacteria, microbes can never be our friends. We don't see much of gonococcal arthritis. I've just skipped some of these things. There are a lot of those pictures of pyogenic arthritis. We have a lot of bugs even today which are important, and many of you have had experience, I'm sure, in your clinical experience. I have not seen more than 1 or 2 cases of brucella arthritis. I think I was in Belgaum those days, 3 days. 3 years I was there, and I saw an odd case of rickettsia. But some of the things we all have seen, and they all can mimic. And again, septic arthritis. Now remember, my subject was infections and rheumatic diseases mimics. Mimic can be on either side. Infections mimicking a rheumatic disease. In a rheumatic disease, you think of a flare which is not a flare but an infective situation, or both together. A classical example of a gout in a knee joint looks as much as pyogenic as much as in a gout or a pseudo-gout. So it's a two-way kind of a game. It's both sides when you look at the whole thing. And I purposely brought this wonderful paper way back. I think New England Journal of Medicine did not publish anything after that on polyarthritis fever. But look at the list. The list is still relevant. So many years later, this is still the list with us. But add chikungunya to it and add COVID to it. Those two damn things were not there all these years actually. But all of them are with us today also. And okay, so in interest of time, we'll just, time moves very fast. I'm so happy that my friend has covered adult disease. Extremely important, both as clinicians and rheumatologists. Number of times you encounter a fever of unknown origin and sometimes the diagnosis is so delayed. So I think fever of PUO or FUO as you call it these days, and Still's disease, you should remember it. Second example of the rage of the bugs. One was a pyogenic, and this situation is tuberculosis. And this was right under my eyes. It took me about almost 3 weeks to realize that this is not just a rheumatoid. Swelling in the region of on the shoulder, I thought of pseudo-gout, various crystals, but no, it was not very inflammatory. It just came down on the arm. And this was absolutely proven to be tuberculosis. Sensitive did very well. And I think we'll, yes, I personally really like this publication from Aman Sharma and group. This is one of the world's very good publication, accepted all over, that they defined in a more systematic or a more scientific manner what Ponson's disease is about. Remember Ponson's? That also is a great mimic. And from my own group, I think we have had if I can say, both bad luck and good luck, that we have had a fairly good experience of Hansen arthritis published mimics. I think we were amongst the first groups in the world to describe acute polyarthritis after Hansen. Only maybe 5 or 6 such cases were described. And this was work done by one of my colleagues in my center. And she's a physiologist in DY Patil, in Bharatiya Vidyapith today with Kavita. She's doing physiology. She gave up rheumatology for whatever reason. I don't see much of this. Now, I must not go without adding some chikungunya to what Moini has said. In 2006, this was the kind of experience that we had in CRD Pune. All of a sudden, first of all, 20-25 years after MBBS MD, we began to read what chikungunya is. Many of us didn't even know how to spell chikungunya. Even today, you look at the medical papers, the way chikungunya is spelled. And it was fascinating that we were seeing patients with different phenotypes and thinking of that. This got published, and it's in that paper that I wrote that I think this needs to explore as to why chikungunya can do so much what it does. And then we did an ICMS study, which I think Moini also spoke, long study. We looked at many things in that, and all kind of mimics. Okay, let's forget. Yes, this was a very fascinating experience. For years, I told myself, Chikungunya cannot produce erosive arthritis. And I'm saying that because of what I was saying, experimental evidence, mostly seronegative. Unlike Mohini, I haven't found even CCP antibodies in the patients who were convincingly chikungunya. Let's put it like that. Very few get it. This lady made me change my entire picture. She's from Nagpur. Suddenly turned up, bilateral THR. Then I had to send her for bilateral TKR. Now she's got total destructive arthritis in shoulders. I cannot find any other explanation. I've worked her extensively. Even the biopsy was sent to all the leading centers in the world. We could not isolate the chikungunya virus, which Mohini spoke about. And I think as of now, despite everything, I think we still do not know whether post-chikungunya arthritis is an autoimmune phenomenon or a persistence of a viral genome fragment. Some other day we can talk about it. And little work that I carried, because Anuradha told me you must take this along. Sorry, I'll just finish in maybe the picture of chikungunya, when you see during acute phase, subacute phase, and you look at all the cytokines repertoire, is just like rheumatoid arthritis. But then subsequent, the course is different. We know that. So let's skip this. We know this, just to make sure that we remember that so many upper respiratory tract infections can mimic polyarthralgias, polyarthritis, short-lasting. And yes, finally finishing with COVID-19. If I was to give a comment on post-COVID-19 inflammatory arthritis, I believe that there's not much of it so far. In my also, we have got now about 4,000 plus patients worked out. I have not seen much of that. The convincingly published literature on, I'm not talking about autoimmune disorders. I think we had a wonderful talk on autoimmune disorders, and many things happen. In any epidemic, it happens. As of today, let me say that in my personal opinion, COVID-19 is not the way chikungunya virus behaves. And we'll see that. I just want to quickly add to your information, and I think, pardon me, again, it will need a lot of time sometime. After 12 years in the village Bhavi near Solapur, where I did my ICMR chikungunya work, we did a resurvey. It's just getting ready for publication. And I did this resurvey trying to answer the question, will chikungunya increase the incidence of autoimmune rheumatic disorders, especially inflammatory arthritis, in time? That was the question. That was a research question which I set for my group in 2006. We have just done that. My one simple answer is no. There is a slight increase in inflammatory arthritis, but surprisingly, my friend Anuradha, who is my microbiologist, she is showing so much more autoantibodies in this population after these years. I'm surprised. Asymptomatic, rheumatoid factors, some ANA, which we are working on. I think it's good enough just to leave some kind of a dessert with you all, those of you who love chikungunya research like Mohini and myself, but we'll talk about some other day. So I think we have to watch. I heard that question which my previous speaker asked, very relevant question. Years later, will rheumatologists get richer? We all will be driving Mercedes because there'll be so much of post-COVID rheumatic syndromes. Sir, I mean, wherever you are sitting, I don't think so. And maybe you'll outlive me to see that, but I don't think so. Because viruses has been with us for a long time, and these things happen, many of them. But it takes time to really know the proof. Please focus on the fact, my rheumatology colleagues who are sitting amongst us, we need to review our entire understanding of what reactive arthritis is. Many of the things that we see are reactive arthritis. So many new bugs are there. Many of the things that I've said are possibly reactive arthritis, but chikungunya arthritis does not fall totally in reactive arthritis. So we'll have to wait. Yes, thank you for giving me such a lovely subject to speak upon. And bugs envy, don't put that music on, it's so frightening, isn't it? Just hold on. It really shakes up the whole hall. Isn't it? I was wondering, I was sitting there. Oh, बहुत ही भूचाल जैसा म्यूजिक है वो यार. कहाँ गया हमारे ऑर्गेनाइजिंग सेक्रेटरी यार? Just be gentle with us a little bit, yaar. Anyway, no problem. I think we are terrible with timekeeping anyway. So, bugs and we, this was one of the things I wrote. We do not know who is chasing whom. For millions of years, the bugs have stayed within us and outside. And we are in, hopefully, beneficial friendships. It's not an easy thing to sort of, mimic or dissect out, but it's a great subject. Thank you very much for your kind attention. already given me so many chadars. Oh, this is a new gift, I think. I'm watching, I saw a new load of chadars coming here, as gifts. I think, thank you very much.
Thank you, sir, for your wonderful input, sharing challenging cases you have faced during your experience and emphasizing on the importance of data. It is always pleasure listening to you. I request Dr. Suhas Karkamkar, sir, and other chairpersons to felicitate Dr. Arvind Chopra, sir. Will be presented by Dr. Girish Kakade, who is a senior consultant in rheumatology and has more than 14 years of experience in the field.
I thank organizers for giving me this opportunity. I'll be speaking about vaccination in rheumatic diseases. So for this, I have gone through these recommendations to 2019 update of EULAR recommendations for vaccination in adult patients with autoimmune inflammatory rheumatic diseases, to 2022 ACR guidance summary for vaccination in patients with rheumatic and musculoskeletal diseases, CDC recommended vaccination schedule in 2022, and ACR COVID-19 vaccine clinical guidance summary for patients with rheumatic and musculoskeletal diseases. So first of all, vaccines can be categorized into mainly two groups: inactivated vaccines and live vaccines. Live vaccines are measles, mumps, oral polio myelitis, oral typhoid, varicella zoster, and yellow fever, and all others, especially pneumococcal vaccine, influenza vaccine, tetanus toxoid. These vaccines are inactivated vaccines. So as per CDC, they have defined what is immunosuppressive therapy. According to CDC, glucocorticoid use more than 2 weeks in dosage equivalent to or more than 20 mg of prednisolone in case of adults, and in children 2 mg per kg of body weight. Then methotrexate more than 0.4 mg per kg per day, azathioprine more than 3 mg per kg per day, and 6 mercaptopurine more than 1.5 mg per kg per day. So this is a definition they have used for immunosuppressive therapy. Any doses below this can be called as low-grade immunosuppression. The newer rheumatological medicines like biologics and targeted synthetic DMARDs, they can be classified into immunosuppressive therapy. So this is from the 2019 EULAR recommendations. These are the overarching principles for vaccination. The most important thing, the first principle they have made is vaccination status and indication of for further vaccination in patients with rheumatic disease should be assessed by a rheumatology team, and it is a primary responsibility of treating rheumatologist or rheumatology team to look after the patient's vaccination status. So the second principle is this individualized program for vaccination should be made after discussing with patient about risk and benefits. Third principle is vaccination in patients with rheumatic diseases should preferably administered during quiescent disease. Whenever disease is active, we should probably should not vaccinate, but again this is not a rule, but it is a preference. Fourth principle is vaccines should be preferably administered prior to planned immunosuppression if possible. If it can be planned to give vaccine first and then start the immunosuppression, that should be done in a particular B-cell depleting therapy like rituximab. Fifth is non-live vaccines can be administered in patients with rheumatic diseases, also while treated with glucocorticoids and DMARDs. So non-live vaccines can be given, whereas live attenuated vaccines, they have to be used cautiously, or sometimes we have to avoid using in patients with rheumatic DMARDs on rheumatic diseases on DMARDs or strong immunosuppressive therapy. So we'll go through individual vaccine. What is the recommendation? The first one is the influenza. Quadrivalent inactivated vaccine is available, which also includes H1N1 virus in that. It is strongly recommended for majority of patients with autoimmune rheumatic diseases because patients are highly susceptible to influenza infection and serious infection. It has been found that this influenza vaccine is immunogenic even in patients with rheumatic diseases, even in patients who have been on DMARDs, except for rituximab. It has also been found that temporary discontinuation of methotrexate was shown to improve immunogenicity but still it is not yet currently recommended to stop methotrexate before or after giving influenza vaccine. This is EULAR recommendation. ACR slightly varies. Recent ACR recommendation is slightly different. Pneumococcal vaccine, next is pneumococcal vaccine. It has got two vaccines available in India. First is pneumococcal conjugate vaccine 13, PCV 13. Other is pneumococcal polysaccharide vaccine 23, PPSV 23. So in India we have got these vaccines. In US they have recently launched PCV 15 and PCV 20. So they are not yet available. So so this is the vaccines that we use in India. It is strongly recommended for patients with rheumatic diseases even below 65 years of age on immunosuppressive medicines. It is advised above 65 even in non-rheumatic disease patients also. So how to go about this pneumococcal vaccine regimen? The first, if the patient has not received any dose of pneumococcal vaccine or we don't know the vaccination schedule, you have to first administer PCV 13, that is conjugate vaccine 13, followed after 8 weeks by PPSV 23, polysaccharide vaccine 23. This 8 weeks is the minimum duration which is needed. It can be given after 8 weeks also, maybe after 1 year or so, but should not be given before 8 weeks. And second dose of polysaccharide vaccine should be given after 5 years of first polysaccharide vaccine. So this is the most common scenario where most of our patients are not vaccinated at all, and this should be the regimen that we should follow. If the patient has received one dose of polysaccharide vaccine and we don't know about PCV conjugate vaccine, then you have to administer conjugate vaccine PCV 13 1 year after polysaccharide vaccine, and second polysaccharide vaccine to be administered after 5 years of first polysaccharide vaccine. Third scenario is 0 or unknown PPSV 23 and 1 dose of PCV 13. In that case, we have to administer polysaccharide vaccine at least 8 weeks after conjugate vaccine, and second polysaccharide vaccine after 5 years of first dose. Next scenario is 1 dose of polysaccharide vaccine 23 and 1 dose of PCV 13. In that case, only second dose of polysaccharide vaccine 23 after 5 years is needed. And last scenario is 2 doses of polysaccharide vaccine but no dose of conjugate vaccine. In that case, we have to only give conjugate vaccine after 1 year of polysaccharide vaccine. So this is slightly complicated. Even if you remember just first one, that if patient has not received anything, first give PCV 13 and after 8 weeks we can give PPSV 23, or up to 1 year also we can give PPSV 23. So next vaccine is tetanus. It should be given as per the recommendation for general population. There is nothing different that is needed with rheumatic disease patients. Only thing is sometimes we might have to give passive immunization like immunoglobulins, tetanus immunoglobulins in patients who have been treated with B-cell depleting therapy like rituximab, because these patients might not develop that much seroprotection after normal tetanus vaccine. And hepatitis A and B, this should be advised in patients who are at risk, like those patients who have seronegative, they don't have antibodies and are residing in endemic countries or traveling to countries like India, like we are endemic country for hepatitis A and B. And also for hepatitis B, the patients at risk of exposure to hepatitis B, like healthcare personnel, household contacts or sexual partners of people, person who known chronic HBV infection, intravenous drug users or men having sex with men. So these are the patients who are at increased risk of exposure to hepatitis B, should be considered for vaccination for hepatitis B. Next one is herpes zoster. We frequently see many patients with rheumatic disease on immunosuppression developing herpes zoster infection. So it is advised that all patients about 50 years of age on immunosuppression should be considered for herpes zoster vaccine. It's a live attenuated vaccine, Zostavax, which is available in India. Another newer vaccine, which is newer recombinant non-live vaccine, is available in Europe. It is not yet available in India. So as this is a live attenuated vaccine, it should be given prior to initiation of biological DMARDs or targeted synthetic DMARDs, at least 4 weeks prior to that. Once the DMARDs are started, biologic or targeted synthetic DMARDs, it will be difficult to administer herpes zoster because there is a risk of infection. And also the risk of herpes zoster has been found, highest risk has been found with inflammatory myositis and SLE patients. Next vaccine is yellow fever. It is usually needed when somebody travels to an endemic country like South America or Africa. But it should be avoided in patients with rheumatic diseases because of risk of active inducing infection. If we have to give, we have to go for yellow fever vaccine, then we'll have to withhold immunosuppression before that vaccine. Another option is to measure serology in patients who have been to those countries previously. So for how long to withhold the medicines, we have a separate slide on that. How long to withhold the DMARDs. Next vaccine is human papilloma virus vaccine, HPV vaccine. We have quadrivalent and bivalent vaccine.
It should be considered in all patients with rheumatic disease. So normal for general population up to 26 to 29 years of age, in females the vaccine is recommended, but in patients with lupus it can be given up to 45 years of age. Most of the data of efficacy and safety for HPV vaccine comes from patients with SLE, females from SLE. So that's why SLE patients should be preferably given HPV vaccine, because it has been found to be safe and efficacious. And the next point is immunization of household members. The other members of the in the family should receive vaccines according to national guidelines, because that will give also protection to the patient with rheumatic disease, except they say oral polio vaccine that it might cause active infection. This is from the actually ULR recommendations. And the next point is the patient should avoid handing diapers of infants vaccinated against rotavirus for at least 4 weeks. And they should avoid contact with persons developing skin lesions after varicella or zoster vaccines. These are to avoid infection in the patient. And the one important point they have mentioned is live attenuated vaccines should be avoided during first 6 months of life in infants of mothers treated with biologics during second half of pregnancy. So any mother who has received biologics after 22 weeks of pregnancy, her baby should not receive live attenuated vaccines for first 6 months, because those biologics are transferred to placenta and its baby has got detected levels of biologics in their blood, and they are prone to get infection with live attenuated vaccines, disease from live attenuated infections. So this slide shows effect of immunosuppressive agents on vaccine immunogenicity. So the first one is the three important vaccines: pneumococcal vaccine, seasonal influenza vaccine, and hepatitis B. First is methotrexate. It has been shown to reduce the immunogenicity of pneumococcal vaccine, but ULR doesn't suggest to stop methotrexate. ACR suggests to stop it for 2 weeks. That will come afterwards. Influenza probably decreases, but not sure. Hepatitis B unknown. TNF alpha don't have much of effect on pneumococcal and influenza. Rituximab has substantial effect on both pneumococcal and influenza, similar to abatacept, a CTLA-4 inhibitor. Tofacitinib decreases pneumococcal vaccine immunogenicity, but not that on influenza. And tocilizumab has minimal effect. So mainly methotrexate and rituximab. Mainly rituximab reduces the immunogenicity. So what should be the medication management at the time of non-live attenuated vaccine administration? This is from the recent ACR guidance summary 2022. So what they suggest is for influenza vaccination, methotrexate to be held for 2 weeks after vaccination. But there is a star to that. Like if the patient is in inactive disease, then only we should consider that. If we think that there is a risk of disease flare, we can continue methotrexate. Other non-live attenuated vaccine, we can continue methotrexate throughout. For rituximab, for influenza, we don't have to stop like rituximab. We can give influenza as such we want to give. Only we want to do thing that we want to postpone rituximab for 2 weeks in that case. In other case of non-live attenuated vaccines, we have to time vaccination when the next duration is in next rituximab dose is due. Only then we have to give it and then hold rituximab for 2 weeks. All other immunosuppressive medications apart from that we can continue, apart from methotrexate and rituximab, because even though the studies show that immunogenicity is reduced, still patients get seroprotection levels even after being on other immunosuppressant medicines. This is about steroids. What dose, if the patient is on steroids, what to do about these non-live attenuated vaccines. First is if the dose of prednisolone is less than 10 milligram per day, it is strongly recommended to give influenza and other non-live vaccines. If the prednisolone dose is more than 10 and below 20, we still have to give both influenza and other vaccines, but it is a conditional recommendation. If the prednisolone dose is more than 20, for influenza we have to give, that is a conditional recommendation. But other non-live attenuated vaccines, we have to defer till the steroid dose come down below 20. So this is about what should we do about immunosuppressant medicines in live attenuated vaccines. So in live attenuated vaccines, we have to use these vaccines cautiously in patients with rheumatic diseases. So glucocorticoids, so methotrexate, leflunomide, these have to be held 4 weeks before and after. JAK inhibitors, because of shorter half-life, 1 week before and 4 weeks after. Biologics, 1 dosing interval before and 4 weeks after. Rituximab, 6 months before and 4 weeks after. And IVIG, 8 to 11 months before and 4 weeks after. This is mainly to improve the immunogenicity of the vaccine and not the safety point of view. This is about rotavirus. So even though other live attenuated vaccines in infants should not be given up to 6 months of age, If the mother has received TNF blocker, rotavirus vaccine can be given, but mother has received rituximab, it cannot be given. And this is the last slide about what should be done with COVID-19 vaccine in rheumatic disease patients. COVID-19 vaccine has to be given like general population in all the patients with rheumatic diseases, whatever may be their disease severity. Only if the patient is having serious condition and is in ICU, then only we have to not give the vaccine. Otherwise, even if active disease, ACR recommends that we should give COVID-19 vaccine. But there are a few modifications for the doses of biologics and DMARDs. Abatacept, we have to time the vaccination so that it occurs 1 week prior to the next dose. NSAIDs, non-steroidal anti-inflammatory drugs and acetaminophen, they should be withheld 24 hours prior to the vaccination. After vaccine, we can give NSAID, but not before 24 hours. Belimumab, we have to hold for 1 to 2 weeks. Other biologics commonly used like TNF, IL-6 receptor blockers, IL-17. The task force could not come to the conclusion. Actually, they could not come to the conclusion what should be done. But usually what we do is we give it before the next dose of that vaccine, biologic. Cyclophosphamide, we have to time the vaccine such as it occurs before 1 week of the next dose. Hydroxychloroquine, just 1 minute. Hydroxychloroquine, IVIG, we don't have to do anything, we can continue. Rituximab, we have to time approximately, like it happens after 6 months of rituximab dose. And next 2 to 4 weeks, we don't have to give the rituximab. And all others, we can continue. We have to hold for 1 to 2 weeks, like methotrexate, we have to hold 1 to 2 weeks after the vaccine dose. So last, in conclusions, vaccination in patients with rheumatic disease is the responsibility of treating rheumatologist or rheumatology team. It should be preferably administered during quiescent disease. Preferably it should be given before starting immunosuppression, especially if you are thinking about rituximab, if possible. Non-live vaccines can be given with glucocorticoids and DMARDs. Live vaccines are to be used cautiously. Herpes zoster and MMR vaccine may be used cautiously, but vaccine like yellow fever should be better avoided. DMARDs or biologics may have to be withheld for some duration before and after vaccination, especially if you are giving live vaccines. And COVID-19 vaccines can be given like general population. Few DMARDs may have to be withheld after the vaccination. So this is about vaccinations in patients with rheumatic diseases. Thank you.
Thank you, sir, for giving us an update about the vaccination in rheumatic diseases, which you backed up by your multiple authentic sources. Now I request all the chairpersons to felicitate Dr. Kakade, sir. I request Dr. Kakade sir to be on stage as a chairperson for the next topic. I request Dr. Agrawal sir and Dr. Jamadar sir to felicitate chairpersons. Thank you everyone. Our next session will be on the topic of refractory RA versus CIPA-UD, which will be presented by Dr. Sandeep Kansurkar, a well-known rheumatologist from Pune and also assistant professor in Bharati Vidyapit Medical College, Pune. For that, I would like to call upon the stage Dr. B.M. Karvekar sir, Dr. Suraj Dhoot sir as a chairperson.
Good evening, everyone. So today's my topic is refractory RA versus CIPA UD, and all of us know the diagnostic criteria of rheumatoid arthritis, and it doesn't. It's mostly a clinical criteria for diagnosis, and there are few points given for the rheumatoid factor and anti-CCP antibody, but to score the total of 6, actually we can skip away this serology and still can make a diagnosis of rheumatoid arthritis. So that's why rheumatoid arthritis diagnosis is mostly a clinical diagnosis. But this clinical diagnosis can sometimes create problems when you have something which is mimicking acute or chronic polyarthritis and it's not rheumatoid arthritis. There is one more entity, refractory rheumatoid arthritis. What is refractory rheumatoid arthritis? It's rheumatoid arthritis which fails to our expectations in terms of response to treatment. There is no fixed definition to it. Rather, we are shifting our goalpost. A few years back, low disease activity was our target. Then we changed our target to clinical remission. And now maybe in future we will be thinking of drug-free remission. We don't know. Basically, the refractory disease is any state of disease activity which is not acceptable by the patient. And when to call an arthritis to be refractory? Shall we wait for failure to show response even after adequate time has been given after full dose of medications, or absence of any response at all to initial doses itself, especially the glucocorticoids? So that's an initial signal that probably we are heading towards a refractory state of rheumatoid arthritis. And what to do when we encounter such a refractoriness? So check if patient has taken adequate doses of medications, adherence as well as compliance. These are two different issues. Adherence is something which patient has medicines but forgets or doesn't want to take the medicine. And compliance is something patient doesn't have medicine. Patient has to get medicines from the shop. Patient is not just buying the medicines. So both things have to be taken care of. Then test for acute phase reactant to check if for the persistent disease activity. Check for fibromyalgia. It's a common cause of complaints. Even if you have treated patient well with DMARDs, because of fibromyalgia, patient is not responding to your treatment. And then revisit the diagnosis. It may not be rheumatoid arthritis, may be something else that you should take care. So there are various mimics of rheumatoid arthritis like psoriatic arthritis, osteoarthritis, lupus, viral arthritis, reactive arthritis, arthritis of IBD, some infective arthritis, and some palindromic rheumatism syndromes. This entity CIPA-UD is chronic inflammatory polyarthritis undifferentiated. It's an inflammatory form of arthritis which has joint swelling, pain and stiffness, but it cannot be classified into a specific rheumatological disorder. And sometimes it confuses with rheumatoid arthritis. We are not worried about the confusion of rheumatoid arthritis with other classical CTDs, where actually treatment of rheumatoid arthritis is similar to the treatment of arthritis in SLE, MCTD, partially systemic sclerosis, sarcoidosis. Even if we treat with the same drug as rheumatoid arthritis, we do get response. That's not a bigger issue. Bigger issue is the seronegative RA, and it is mimicking with something else. Do pay attention to other symptoms like skin rash. If there is photosensitive rash, it may be SLE. If there is skin thickening of hand and face, it may be systemic sclerosis. Pay attention toward the rash over extensor surfaces. It may be psoriatic arthritis. Do ask for Raynaud's phenomenon. Most of the people who are encountering the rheumatological patients try to skip away with this complaint, but Raynaud's phenomenon is very, very important because it can give you a clue towards underlying undifferentiated CTD or systemic sclerosis phenomena. See, the Sjogren's syndrome, SLE, antiphospholipid syndrome, all these disorders can have Raynaud's phenomena. Look at the Sika symptoms, maybe it's a Sjogren's syndrome. Fever in seronegative rheumatoid arthritis is unusual. Acute infections like viral fever or Poinset's disease because of tuberculosis can cause fever. Look for muscle weakness, inflammatory myopathies may be present. And also look at the pattern of joint involvement. Large joint involvement, especially hip joint involvement and relative sparing of small joints, maybe spondyloarthritis, and small joint involvement and involvement of distal interphalangeal joint,
suggest psoriatic arthritis. So these are differential diagnosis for seronegative rheumatoid arthritis. So it's a responsibility. Whenever we label a patient as seronegative RA, our responsibility increases to screen for other types of CTDs. But the real problem is, looks like RA, but doesn't respond to treatment of RA. And that's a typical setting like refractory RA. Let's deal with this problem on case-to-case basis. So here is a 57-year-old man who came with a pain and swelling of multiple small joints of hands and feet, and which was acute onset for last 1 week. And there was no such previous history of attacks. So this was the appearance of feet. So it can easily be confused with rheumatoid arthritis because there is swelling and pain at MTP joints, and there is polyarticular involvement. And here if you see, the uric acid is marginally elevated and rheumatoid factor is positive. Look at the inflammatory markers, they are very high. ESR and CRP are quite high, ESR 130, CRP 106, which may not be suiting to the duration of illness of the patient, which is just 1 week. So there is a typical confusion between gout and rheumatoid arthritis. Can these two diseases exist together? Yes, they can exist together. But sometimes problem may be because of one entity more than other entity. Here in this case, if you see the tophi and the presence of attacks on the big toe go in favor of gout, while the pain, swelling and stiffness of multiple joints and the symmetrical involvement goes in favor of rheumatoid arthritis. So how to solve this case? Go for the imaging. So ultrasonography is a good imaging method where you can see this double contour sign, which is a very interesting sign in gout. And also if you have this facility of DCT scan, which we have in our institute, so it helps in diagnosis of gout with a specificity. Next case. It is a 70-year-old lady came with a swelling and stiffness of small joints of hands. Look at the inflammatory markers. They are relatively quiescent. Rheumatoid factor is 15. Laboratory normal range is up to 10. And anti-CCP antibody, patient said, I cannot afford the anti-CCP antibody. And if you look at the hands of the patient. So if you look at the hands of the patient, look, MCP joints are quite silent, while you can see the swelling at the distal interphalangeal joints. Here. This is the case of osteoarthritis of hand. How to differentiate between osteoarthritis of hand? It's not much painful condition. And second thing, the swelling that happens in osteoarthritis is mostly a bony swelling as compared to rheumatoid arthritis, where it's a squishy type of swelling that is caused because of synovial hypertrophy. The erosions is a typical characteristic of rheumatoid arthritis and not osteoarthritis. Osteoarthritis, rather the bone grows rather than bone erodes. There is erosion, but that's erosion of cartilage and not bone. So here is a third case, 60-year-old man who came with pain and swelling of small joints of hands and feet, the swelling of dorsum of foot, then trophic ulcer over left sole. In ESR and CRP are quite high, rheumatoid factor is pretty high. And he had received treatment with DMARDs, but he has got no response. So look at the face. So you can see there is infiltration around the nose and the cheeks, and there was some infiltration in the ears also. And look at the hands. There is swelling of the joints of the hands. So the case was proven to be a case of Hansen's disease, which can mimic like rheumatoid arthritis. There have been multiple reports where Hansen's disease has been established to be a great mimicker of rheumatoid arthritis. I remember even my professor used to tell that Hansen's disease can be a human model of rheumatoid arthritis. So like Chopra sir had described the same report we can see over here. And if we see the acute symmetric polyarthritis, that can be seen in 17% to 30% of the cases of Hansen's disease. Coming to next case, a 50-year-old lady, case of cervical spondylosis. She came with pain and swelling of right hand, including dorsum of hand, with early morning stiffness. ESR, CRP were normal, and rheumatoid factor anti-CCP were negative. But the appearance of hand was like this. There was swelling
of almost whole of the hand, MCPs, PIPs were swollen, wrist was swollen, and they were tender on palpation. So the diagnostic confusion in this case was because her inflammatory markers were normal and her rheumatoid factor anti-CCP were negative, we decided to do a technetium bone scan. Now technetium bone scan has 3 phases, 1, 2, 3. Initial phase is immediately after giving technetium oozes out into the joints if there is hyperemia. That's classical with inflammatory arthritis. Initial phase, it can ooze. But if it continues to stay till 3rd phase of technetium scan, that's an indication of complex regional pain syndrome. So this case was a case of CRPS occurring because of cervical spondylosis. And the classical symptoms of CRPS are persistent pain in arm, tingling sensation and numbness in the area which is sensitive to touch, and increased perception of pain and swelling over the affected area. There may be temperature changes in the involved area. This is a non-inflammatory condition. The pain basically is of neuropathic origin and not of inflammatory origin. The next case is of a 78-year-old lady presented with swelling and deformity of small joint of hands, telangiectasia over face, chronic gastric ulcers. She had receiving multiple medicines for suspected schizophrenia because she was not responding well to the commands. Then she received methotrexate and hydroxychloroquine for this arthritis but didn't have much response to it. In investigation, rheumatoid factor was negative, anti-CCP negative, ESR, CRP were almost quiescent. ANA was positive with this nucleoplasm pattern. Here she was creating a confusion where there was confusion between an overlap syndrome between a limited scleroderma and rheumatoid arthritis. But since RF anti-CCP was silent and inflammatory markers were silent, so this was the situation where we could see the swelling of the joint typical like rheumatoid arthritis and swan neck type of deformity, and there was also swelling of the MTP joints. We thought that this is inflammatory arthritis, but sometimes medicine professor has an eye to look at the symptoms. So she noticed the lady has the pill rolling tremor. Our professor noticed that she has got a pill rolling tremor. So pill rolling tremor may be an indication of Parkinson's disease. So, and she also had generalized rigidity, and she was started treatment with levodopa, and with levodopa she had significant improvement. She didn't require any anti-inflammatory therapy. Without that, she got significant improvement. So these are the striatal deformities of Parkinson's disease. So last case is of a 41-year-old lady who came with a chronic pain and occasional swelling of small joints on hands and feet for 3 years. She received intermittent treatment with low-dose glucocorticoids with which she didn't get much relief. She came with a red colored rash over bilateral feet and ankle with severe pain, and next day the gangrene was set at the site of the rash. So this was the appearance of gangrene. If you see the investigation of the patient, there was pancytopenia and thrombocytopenia now, and creatinine was raised. There was proteinuria and hematuria. The rheumatoid factor was strongly positive initially. So the case where you can get this kind of picture is typically a case of cryoglobulinic vasculitis. So the plasma when incubated at 37 degrees centigrade, it was normal, but as soon as we frozen the plasma at 4 degrees, we kept the refrigerated plasma at 4 degrees centigrade, so it developed cryoprecipitate. And as soon as we rewarmed the plasma, the precipitate disappeared. So this was a classical case of cryoglobulinic vasculitis. Patient was roaming around for almost 4 or 5 years, and she was not getting enough response to the treatment despite being rheumatoid factor positivity. The classical case of refractory arthritis. So basically the take home message from all these case based scenarios is look for alternative diagnosis if appearance is not classical. The rheumatoid factor may be false positive in some of the mimics. Use of proper imaging is key to differentiate from classical RA, and most common reason for failure of response is still poor compliance and inadequate dosing, which must be paid attention to. Thank you very much.
Thank you, sir. Use of multiple cases as examples and pictorial slides really helped in clarifying between the two diseases. I would like to request the chairperson to felicitate Dr. Kansurkar. I request Dr. Shardul Kulkarni to felicitate chairperson. We have two important announcements to make. There will be quiz for the students tomorrow afternoon at 3 p.m. We request all the postgraduates and fellowship students to attend in maximum numbers. And another announcement, general body meeting will be held in Vayu Hall at 6:15 p.m. today. For the next session, symposium on gout, which we routinely see in our day-to-day medical practice. For this, I would like to call upon the stage Dr. Nilesh Patil from Pune. He has trained by the father of Indian rheumatology, Professor A.N. Malviya, sir. He has more than 12 years of experience in the field of rheumatology, and he will be discussing on the topic of diagnostic challenges with particular reference to role of dual CT in gout. For that, I would like to call upon the stage as chairperson Dr. Shrikant Page sir, Dr. Sunil Singh sir, Dr. Om Prakash Bhosle sir.
Yes. Should I start? Yeah.
Yes, sir.
So first of all, I would like to congratulate Mukund Ray sir and team Solapur for organizing such a wonderful event. At the same time, I would like to congratulate MRACON for this third consecutive superb sessions. So since morning we have been talking about different arthritis, then spondyloarthritis, rheumatoid, and then different infections. Now I'll be talking about some aspects of gout. Hopefully it should make some difference in your life. So gout, what are the diagnostic challenges when you see a patient with uric acid crystals? So gout is one of the most dreadful arthritis, which generally starts with acute attack of the joint pain and swelling. It represents major healthcare burden due to its comorbidity, particularly in the propensity to cause severe morbidity as well as mortality in later years, because it is always associated with metabolic syndrome, coronary heart diseases, and diabetes mellitus. And so we have been seeing many patients of coronary artery disease, which we used to see in later decades. Earlier we used to see these heart attack patients in 5th or 6th decades, but now the decade has shifted to 4th or 5th decade. Similarly, in gout, we always used to say that gout happens after 40, but in our day-to-day clinical practice, we see lots of patients, young patients, coming up with gout attacks. So I would like to investigate as early as possible. If I suspect gout, you should investigate early, and that's how you can treat early. So who gets the disease? First, if the uric acid is created more under secretion of uric acid by kidneys. So CKD patients, hypertensive patient, hyperparathyroidism, alcoholism, and there are certain medicines which cause hyperuricemia. So most of these are furosemide and thiazide diuretics, ethambutol, pyrazinamide, and aspirin. Then obesity is one of the most common cause for developing gout, and sometimes in rare situations we see overproduction of uric acid. So two most common conditions, myeloproliferative disorders and hemolysis. So gout diagnosis is always clinical. So if you see a patient with high uric acid like 9, you never diagnose that patient with gout unless the patient gives classic history of some joint swelling. So high index of suspicion, age more than 40, alcohol consumption, always take proper history, whether the patient is regular has regular alcohol intake, then patient's obesity, and then other comorbidities. So the gout patient is typical patient with podagra or acute inflammation of any of the joint, particularly lower limbs. And so never suspect gout in females. So if you see a patient, young female patient with uric acid of 9 or 10, never suspect gout, because females, young females, especially pre-menopausal females, they don't get gout because they have the hormone called estradiol, which has negative effect on uric acid. So this is a garden variant of gout, where you can see a patient coming with monoarthritis, and these are 2 patients chronic polyarticular arthritis. So here you can see the podagra, here you can see the uric acid crystal deposition. And so I would like to tell that how we should investigate gout. So the most common and most frequently done and the gold standard to diagnose uric acid crystal is seeing the crystal under polarized microscope. So this is the patient, a 65-year female patient presented with left knee acute swelling, and she was referred to me from knee unit because the patient took almost 2 weeks of antibiotics, still her knee swelling was not going, so that's why they referred the patient. So when I examined the patient, I could see the knee was tender and swollen. So immediately I put the needle, I could remove some fluid, and I sent this fluid to the lab, and they could find some uric acid crystals. So this is the gold standard, but a recent paper, the recent paper in Mayo Clinic, they showed that 25% of this gout arthritis can be missed in uric acid crystals, because sometimes the uric acid, they get deposited inside the bursa or tendons. So the next modality is X-ray. So we see these patients, these clinical pictures of X-rays, where you can see there is punch out lesions, then rat bite erosions, then these are some sclerotic overhanging lesions and some lytic lesions. But these lesions develop over the period of 7 to 10 years. So what should we do? Because if we diagnose this patient late, so there are certain comorbidities in future which are going to happen. So we should try to diagnose it early. Second is high resolution ultrasound. Again, it can demonstrate joint effusion, synovitis and erosions. Double contour sign is the pathognomic of gout in ultrasound. And then we can see the activity of thickened synovium by power Doppler. But the problem is, yes, here you can see the patient has a double contour sign. Then you can see the thickened synovium, and these are the uric acid crystal deposits. Here there is the color Doppler signal in the this joint, and sometimes you can see this snowstorm appearance. So these are multiple crystals which are deposited here. So again, this is classic of uric acid crystal deposition. So again, these are the tophi. Yes, but there are certain limitation in ultrasound. It cannot image the deep structure, and it is highly operator dependence. The radiology should be expert to find out the uric acid crystals, and there is steep learning curve, and the most important, there is less sensitivity. So sensitivity of ultrasound to diagnose uric acid crystals is around 46%, but it is highly specific. So sensitivity is less, that means there is high chance, there are high chances of missing out gout in these patients. Then conventional CT, where you can see in this image you can see the uric acid crystal deposition, but you don't get any additional information in CT. So you can get some information if the patient has some erosions in the joint. So it is of no use in acute gout because there are no erosions in acute settings. So again, CT is of no value in diagnosing early gout. Then comes MRI. So MRI typically exhibits, you can get on T1 weighted images hypodense lesions, and in T2 weighted the hyperdense lesions. And MRI can depict the erosions, marrow edema, gouty tophi again, but these are not specific for gout. And often diagnosis can only be inferred if the radiology is really good. Radiology should have high index of suspicion while giving these reports. Again, MRI has low sensitivity of 65% and again highly specific. Specific again, that means if MRI is showing some uric acid crystal, it has to be gout, but again poor sensitivity. So these are some MRI images. So this is the T1 emitted image which is showing this hypotenuse lesion of gout. This is the second image, and this is a T2 weighted image which is showing hyperechoic lesion. And then what do we have? There are high chances of missing out gout in some structures like tendon, sheath or bursa. So there comes the role of dual energicity. So dual energicity is a newer modality which can depict crystals anywhere in the body, including your joints, structures around the joint and even around the viscera. So the principle is there are two tubes, tube 1 and tube 2, and then these are two X-rays which are placed in 90 degrees. And there are two corresponding detectors, and this allows image to be acquired simultaneously. So I won't go in details again, but it can differentiate between calcium deposit and uric acid crystals. So it is considered positive by the presence of color coded MSU crystals. So there are different color codes from pink to green, and if the patient has pink color here, you can see that it is a calcium crystal, when if it is green, it is a uric acid crystal. So here you can see the image on left side where the patient has gout, uric acid crystals, and these pink crystals, these pink deposits are calcium deposits. So this patient had gout and the patient was treated for 16 months with febuxostat on the left side, and with proper treatment these crystals, they got completely vanished. So here in this picture you can see that we can measure the tophi also by doing dual energicity. So it has very good sensitivity up to 85 to 95%, and recently in 2015 it was included in ACR and Euler classification criteria. Like I said, quantitative monitoring of tophi is possible, and it is particularly of importance when synovial fluid does not show any crystal. And many times a patient comes with ankle swelling and it gets really difficult to get the fluid from ankle. So there dual energicity helps us. And it also helps, like I said, extra-articular gout and tendons and bursa. So what are the limitations? Still the sensitivity is slightly less. It is still 85 to 95%. So once the sensitivity increases, we can diagnose gout quite easily, and the missing out chances will be less. And sometimes you cannot differentiate between uric acid crystal and artifacts. So that is another limitation. So I'd like to show my experience. So this 65-year-old female patient, she is known case of osteoarthritis of the both knees, hypertension, and she presented with acute onset right heel pain and Achilles tendon pain. And she was referred because she had severe pain, and she gave history of left knee swelling, acute swelling 4 months back. So when we investigated her, all reports were normal except uric acid was 6.5. So this is the patient where you can see these are all osteophytes, typical joint narrowing. So this is grade 3 to grade 4 osteoarthritis. This patient presented with acute left knee, left heel inflammation, swelling. But I ordered for dual energy CT where I can clearly see the uric acid crystal deposition, these green images, green crystals, and I could get some crystals in the knee as well. So if I would have not asked for this, I would have certainly missed the diagnosis of gout. So made the diagnosis of gout and started on treatment. Recently she underwent TKR and now she is on urate lowering therapy. Now case 2, 60 years male, is father of one of my friends who is cardiologist. So this patient was taking treatment for gout for almost 7 years. And so he never gave me any history of joint pain or joint swelling, but had intermittent pain in first MTP joint. And I could not see anything here. There was just mild narrowing in first MTP joint, and uric acid was 6. So I requested him to get this dual energy CT just to show him that the patient or his father did not have any gout. So we got this dual energy CT where we saw there is no uric acid crystal deposition, and again diagnosed with first MTP joint, osteoarthritis, stopped fevoxostat. Now patient is doing perfectly fine, no gout attack. And this is the case 3, 35-year male patient who was resident of US, and he came here, he was here for 2 weeks, then he was referred, and he is under treatment for psoriasis and psoriatic arthritis. He was on etanercept and methotrexate for 6 months, but he did not have any relief. So the doctor started on infliximab. Now he came for second opinion, and this is the patient. So his ESR and CRP were slightly raised, uric acid was 7.5. You can see this IP joint swelling. So I thought of I told the patient that the doctor is treating perfectly, so there is no doubt. But when the patient was sitting there, he was scrolling for some images, and then he showed me this image. So he told me that the image on the left side is there for last 6 months. The joint is like this, but when it started, there was some redness. So that gave me the clue that I should rule out gout. So again I requested for dual energy CT, and there I can get this uric acid crystal. So there was no crystal deposition around the joint. On this dual energy CT report, they just showed that there was some capsulitis and subtle crystal deposition on the left side as well as on the right foot. So you can see these are very subtle. So I would have also missed it, but because of dual energy CT I could diagnose it, and then patient was started on earlier colchicine, and then after 3 weeks urate lowering therapy. So this is our data where I sent 28 patients for dual energy CT, and it is an observational study, and I have not written the paper yet because I was waiting to get 50 patients, but because of this MRACON I have abstracted this data. So the inclusion criteria was acute monoarthritis, suspected gout patients, rheumatoid factor, anti-CCP and HLA-B27 negative. Exclusion criteria, clear-cut evidence. Clear-cut evidence of uric acid crystal deposition on synovial fluid. I did not include these patients on X-ray or USG. So out of these 28 patients, 20 patients have gout, and 2 patients have osteoarthritis, and these 6 patients they did not have gout, but they had undifferentiated arthritis, and one of the patients turned out to be spondyloarthritis later. So again, MSU crystals were seen in almost 20% of these patients, and 8 patients, these crystals were seen on dual energy CT, and 8 patients it was missed, and 1 patient, that lady, had MSU crystal on tendon. So by gender, there were only 2 female patients. Both the female patients showed uric acid crystals on their joint. And comorbidities, so we included diabetes, hypertension, regular alcohol intake and obesity. So out of these 75% patients, so out of 20 patients were diagnosed with gout by using dual energy CT. Out of 20, 15 patients had these comorbidities, and 25% patient did not have any comorbidity. Then normal and abnormal report. The 4 patients had abnormal reports. Those where ESR and CRP were raised, so those patients did not show any gout crystal, uric acid crystal. And age group, this is very important because like I said earlier, we used to say that gout is a disease of elderly people, but here I could see there were 25%, there were 40% patients who were in the age group of 30 to 40. So 8 patients were in the age group of 30 to 40. Then 5 patients were in the age group of 40 to 50, and only 2 patients were in the age group of 50 to 60, and again 5 patients in the age group of 60 to 70.
Dr. Patil, please conclude.
Just last slide. Yeah, and so these are the uric acid levels during the diagnosis. So only 5 patients, 5 patients did not have uric acid more than 7. So 5 patients had uric acid less than 7. 4 patients had between 7 and 9, and 5 patients had, 7 patients had uric acid more than 10. So the take-home message is always suspect gout in acute monoarthritis, even in young patients after ruling out other conditions. Dual energy CT offers great potential as screening and diagnostic tool to detect MSU crystals accurately. Early diagnosis of gout certainly helps for preventing long-term comorbidity and subsequently mortality. Thank you.
Thank you, Dr. Nilesh Patil, sir, for guiding us through the diagnosing of gout, not just clinically, but also with the help of reading radiological images, especially the role of dual CT. I would like to request Chairperson to felicitate Dr. Patil, sir. Coming to our next topic of the evening, gout, initiation and maintenance of treatment, which will be presented by Dr. Kunal Patil sir from the city of Solapur. He has more than 7 years of experience in the field of rheumatology and also a well-known name in the pediatric rheumatology.
Hello and good evening everyone. First of all, thank you very much organizers for giving me an opportunity to speak on this wonderful platform. So topic which is given to me is gout, initiation and maintenance of a treatment. So as far as rheumatologist perspective is concerned, gout is probably most overdiagnosed and overtreated problem, and rheumatoid arthritis is underdiagnosed and undertreated problem. Why overdiagnosed and overtreated, I will describe it in my coming slides. So to have a better understanding about subject, what I did, I prepared a case of gout that you see in your day-to-day clinical practice. So he's a 42-year obese gentleman, a known case of hypertension. It came with the complaints of right ankle swelling since last 8 days. You can see on the right side a swollen, tender and red joint with a history of similar episode in last 3 years. So recurrent episodes were there. On a significant history point of view, he was on the drug history was he was on telmisartan and hydrochlorothiazide, and he was on aspirin also. So for unknown reason he was started on aspirin, and uric acid on the laboratory investigation was 8.4. So a crystal clear a case of acute gout. So whenever you see any patient of gout, the few of the question comes into the clinician's mind, and I will try to answer that question one by one. Now the first question is how to initiate a treatment. So how to start a treatment? Should I treat with only NSAID? Should I start steroids, or should go uric acid lowering agent? If it is uric acid lowering agent, which uric acid agent? So these are the questions that comes in your mind when about how to initiate a treatment. Second question, how long? Okay, so I have treated that patient is pain-free for 1 month, 2 months. How long I should go? Is there in some guidelines, or is there in some boundary we can decide with it? Third question, what is the target for uric acid level? So we put target on each and every diseases. For diabetes, you have target. For hypertension, you have target. So what is the target for the gout? Fourth, when to stop a treatment? Again, he has completed 6 months of treatment, not shown any signs of recurrence of gout. Should I stop it? Should I stop each and every drug, or should I continue with something? And the last one, should I treat each and every patient who has hyperuricemia? So there are a few of the questions that comes in clinician's mind when they say any patient in their clinical practice. So before answering that question one by one, I will give a quick recap of gout. So gout is basically divided into 4 phases. Ideally, everybody talks about 3 phases, acute, intercalated, chronic, but I would take it asymptomatic also that phase. Why asymptomatic? What is asymptomatic phase? That asymptomatic phase where you have only high uric acid, but there is no clinically apparent symptoms of gout. Next phase is the acute gout, acute with which every patient comes to you in your OPD, and the most common presentation of gout, where you have excruciating joint pain, where someone has just like poked a knife in your joint. So this is the acute phase of your gout. In between acute and chronic, there is a honeymoon phase is called as intercritical, where the patient will have normal uric acid and as well the patient will not have any clinical symptoms. If your acute symptoms were not treated well, you will end up in a chronic joint, in chronic or advanced gout, where you see all the tophi and all this thing. So gout has 4 phases, and your treatment is mainly dependent upon which phase the gout has. So first question, how to initiate a treatment? Treatment of gout is divided into two parts, non-pharmacological and pharmacological. Non-pharmacological, like everybody know, lifestyle modification, dietary changes, avoid alcohol, avoid meat, you do exercise, etc. and etc. So all these things come under the, or avoid purine diet, is all these things come under the non-pharmacological treatment. Pharmacological treatment is again subdivided into two parts, an anti-inflammatory therapy and uric acid lowering therapy. Anti-inflammatory therapy is where you try to control the pain of that patient, because as I described, it is someone like poked knife in the joint. So anti-inflammatory or the pain relieving treatment is a really important aspect of treatment of gout. Second is obviously uric acid lowering therapy, the reason behind all the gout and all these things. So how to treat acute gout, or what is the anti-inflammatory therapy? See, there are three options you have for the treatment of acute gout: colchicine, NSAIDs and the steroids. Usually the colchicine and the combination of either the NSAIDs or steroids should prefer to control that acute pain of gout. Colchicine is usually given in 0.5 mg BD doses. In past, there was concept of loading dose, but that loading dose concept is out of date. The reason being the low dose versus high dose comparison has shown that low dose is effective as well as the high dose. So colchicine attains the equal amount of serum concentration with the low dose also. So that loading dose concept is totally outdated. 0.55 mg BD of colchicine is okay right now. NSAIDs, you have multiple options, right from naproxen, tramadol, endomethacin, newer COX-2 inhibitors. You can choose any NSAIDs depending upon the patient's profile. If the patient is of cardiac diseases, you can put on paracetamol and tramadol. If someone has the GI problem, you can always use of COX-2 inhibitors. Third option of steroids, I know most of people has aversion about steroids, but it do provide a good amount of relief in a patient of acute gout who has excruciating pain. So you can use steroids in the form of systemic, oral or local form. So how long anti-inflammatory prophylaxis should be continued? Ideally, the anti-inflammatory prophylaxis should be continued for at least 3 to 6 months. Why? Because whenever you start a uric acid lowering therapy, there are odds that the patient might land up in recurrent type of gout. So any sudden rise as well as sudden fall of uric acid can result in repeated flares of gout. So you should continue anti-inflammatory prophylaxis for at least 3 to 6 months. Now, what are the indications for the uric acid lowering therapy? So each and every patient should not be treated with uric acid lowering therapy. If the patient has 2 or more attacks annually, if the patient have 1 or more gouty tophi, or the patient has chronic arthritis, or any evidence of radiological evidence, the patient should be treated with uric acid lowering therapy. Now, which is the best uric acid lowering agent? So choosing between allopurinol and febuxostat is as good as it is difficult to choose between Sachin and Virat. So every cricket lover can understand that feeling. So which one is better? So drug which is there since longer period of time, which is cheaper, has proven its efficacy over the time. Someone who has a good cardiovascular safety is your drug of choice, and the drug of choice is allopurinol. I know everybody in practice uses febuxostat because of febuxostat lobby is pretty much stronger, but as per guidelines, the allopurinol is the drug of choice. So when you should treat asymptomatic hyperuricemia? At the start of my talk, I said gout is most overdiagnosed and overtreated problem. The reason being the treatment of asymptomatic hyperuricemia. So you see a lot of patients of diabetes and hypertension who was dealing with metabolic diseases, and you see that high uric acid level associated with them. But that high uric acid do not leave any sort of symptoms in that. So any uric hyperuricemia that do not leave any symptoms is known as asymptomatic hyperuricemia. So what happens if you don't treat asymptomatic hyperuricemia? See, one study has provided that if your uric acid is 8, in their lifetime, there are only 2% of chances that they will land up in a gout or any other problem with hyperuricemia. If that level goes to the 10, that will come around the 70% of time. So you probably treating 2 to 70% of patient unnecessarily. And the most important thing, you are breaking the biggest law of medicine, that don't treat a symptomatic condition. This is a law of medicine. Ideally, people should be jailed for that, for treating asymptomatic conditions. So where you should treat asymptomatic condition, asymptomatic hyperuricemia, if patient is a CKD, if uric acid is more than 12, patient is on chemotherapy, renal stone and malignancy, these are the conditions where you should treat your asymptomatic hyperuricemia. Otherwise, please don't. How long uric acid lowering therapy should we continue? The correct answer is probably indefinitely, but you can make some changes depending upon patient's clinical remission. If there is no flare from last 1 year, there was no tophi, the cessation tapering of uric acid lower therapy can be recommended, but it's the case-to-case basis. What is the target for your gout or target uric acid level? It's 6 mg%. You try to maintain around 6%. If the target is not matched at the end of month, you can step up your uric acid lowering therapy to the maximum doses. If you don't get that result at the even maximum doses, you can change, thinking of change your uric acid lowering therapy. Another important part about the managing gout concurrent is the management of concurrent medicine. See, there are drugs that causes hyperuricemia, as well as there are drugs that help in reduction of hyperuricemia. So commonest drug that you used and that cause hyperuricemia are the diuretic and aspirin. And there are few drugs that help in reducing hyperuricemia, is the losartan and fenofibrate. Among all the ARBs, losartan has some sort of hyperuricemic activity. So preferring losartan as your antihypertensive can help gout as well as in hypertension. So let's move back to case that I presented and let's see how we can manage this patient. First, as far as a lifestyle modification, you should have to ask them to do is reduce the weight. Since he is presenting with your acute gout, you have to start about colchicine plus NSAID/steroid combination, whatever you're comfortable with. Third, the uric acid lowering agent should be started and it has to be for longer period of time because it's presented for last 3 years, 3 episodes in last 1 year. And fourth, an important thing, you can change it from diuretics to some other antihypertensive and stop aspirin because it started on aspirin for some unknown reason. So you always evaluate what is the need of aspirin, especially in the patient of gout. So how does your prescription look like? This is your prescription for the first month, colchicine plus aropilanol along with naproxen. Naproxen/predmet can be used in tapering doses. Next, in next 3 months, you will be measuring uric acid again, and you may step up your allopurinol if it is nearer, if there is no target uric acid level is maintained. Next 3 months, you will be again evaluating, you will stepping up the gout nil if there is flare, and stepping up the doses of allopurinol. And the last, for next 6 months, you will be keeping this only patient on only aropirinol. So trust me, if you follow this prescription, your patient will definitely say, kaite gout, kaite colchicine, kaite allopurinol, and gout ekdam okay. So basically, I'm in Solapur, and if I'm in Solapur, I have to use these pimps, and sorry. So this is something I could. So all the chirping I done for last 10 minutes is basically for these 4 lines. 2 or more acute attack, gouty tophi is the indication to start uric acid therapy. Your target should be less than 6. Anti-inflammatory prophylaxis should be given for at least 3 to 6 months. And for God's sake, stop treating asymptomatic hyperuricemia. Thank you.
Thank you, Dr. Kunal sir, for your precise yet very informative lecture with one of the takeaway message that Sachin is better than Virat Kohli. Coming to the last topic of this evening, by Dr. Shailaja Sapnis. She is from Mumbai with more than 30 years of experience in the field of rheumatology.
Good evening, everybody. I think all of us are very tired and bored, but I thought this was very important. The way Dr. Patil described seemed very easy treatment of gout. Now, what we see is that the patients are treated, but still they keep on coming up repeatedly with repeated flares. So are we going wrong? It seems so easy, get a target of 6, but do these patients do it? No, just 1 in 4 patients check their uric acid in the past 6 months again after gout. Just 4 in 10 really believe that only that they should take their medications for long. 6 in 10 patients do not take uric acid lowering medications after they get pain relief. Fewer than half of gout sufferers say that treating gout is a very good priority. They feel pain gaya, calm gaya. 1 in 3 strongly agree that gout is just as serious as other health problems. I think more awareness is needed for treatment of gout. When we were students, we thought that gout was caused due to hypertension, diabetes, or cardiovascular diseases. Now it has been proved beyond doubt that uric acid being high itself can be a risk factor for diabetic polyneuropathy, can be a risk factor for an acute myocardial infarction or a stroke. We have seen hyperuricemia to be a risk factor for COVID deaths. So mind you, don't think gout to be very easy to treat. What happens to patients? They have a very poor quality of life when they have more than one tophi. The intercritical periods, 25% patients report pain even when there is no flare. Your uric acid might be normal, but they still have severe pain. Nearly half of gout patients have difficulty in recreation, especially if they are good sportsmen. And there is a higher risk of all-cause mortality. So it's very important to achieve the target 6 and not 8 or 10. Next slide. Now, what are the challenges with the current therapy? Allopurinol, when it was initiated with low doses, why was it initiated with low doses? Mind you, hypersensitivity reactions occur only in 2%. But when they cause a Stevens-Johnson syndrome, the death rate was found to be 25%. Mortality was so high. Major limitations what we found with gout was most patients never took 300 milligram of allopurinol. Most patients, when we see their prescription data, we found that most patients are yet on Xyloric 100 mg. So no titration was done. Many patients were given NSAIDs not knowing that their creatinine might be normal, but their eGFR might not be checked on. Now, when we saw the history of gout, or when we saw what drugs were created for gout, mind you, 1966 to a period of 2010, there was no new drug which was released for gout. Why? Were we sleeping in the world? But no, nobody thought that gout was important. So colchicine actually was started used in 6th century, but actually it was used from 1900. Then came probenecid, then use of steroids, then indomethacin as an NSAID, allopurinol. Febuxostat was launched in 2009. There are many pharma companies who keep on telling us use febuxostat as the primary drug. Many of us don't use colchicine. Then came the use of pegloticase, though it's not very easily available in India, but now we are having more and more newer drugs, which I will tell you in detail later. Now note this is the market of the pharma which is available now. From 2019 to 2028, this is going to be the market for gout. So more and more drugs are going to be created for gout, and that means all of us are going to suffer from hyperuricemia. Now the 2016 guidance, what Dr. Patil explained to us, told us that when you are having any acute episode of gout, educating patient is very important. You avoid colchicine and NSAIDs when there is CRF. So that is another important thing to note, the eGFR, when you are treating a patient of gout. So if the patient doesn't have any septic arthritis, you're very sure that the gram stain is negative. And if the patient has just a monoarticular gout, I would still prefer steroids versus colchicine. So this is very important to note. What other drugs were available? Till last 10 years, we didn't have much drugs choice. So we still use steroids as the only treatment when colchicine was not available. We tried giving injectin depomedrol to some of these patients, but now we have many other drugs coming up for treatment of gout. What actually changed? We started doing cellular biology. We realized the monosodium urate crystals being released into the joint space, they were phagocytosed by the macrophage. So we know that the macrophage had a vacuole containing all these MSU crystals. These release the activated interleukin beta, and this is where the site of science started. We started thinking about using interleukin-1 inhibitors, and that is what changed. We saw that there were a lot of cytokines which were released by this MSU crystals, and we thought that inflammation in acute gouty arthritis was treated with NSAIDs, colchicine and steroids, but we could also have interleukin inhibitors which could be used in the treatment of acute gout. So what are the newer drugs which we are going to talk on for acute gout? We had penicillamine, now we are using bucillamin. Interleukin-1 inhibitors, which include anakinra, rilonacept, and canakinumab. Now, canakinumab and rilonacept was used in CAPS, that is the chiropyrin-induced fever episode. Is it easily available in India? No, not yet, but it will be in the future. Selective inflazome inhibitor, that is the dapinsutril. Corticotropins, that is the ACTH and the melanocyte stimulator. Capsase inhibitors, which are yet under phase 2 trial. Now coming to IL-1 inhibitors, which are yet not easily available, they are expensive, but still we can get them. So what are the indications? One, refractoriness to NSAIDs, colchicine and steroids, renal impairment, peptic ulcer disease, or GI hemorrhage. The disadvantage we have already discussed. Now what is anakinra? It's an IL-1 inhibitor. It's used 100 milligrams subcutaneously for 3 days. It's yet off-label use in refractory gout. What is the only FDA-approved drug is canakinumab, which is the monoclonal antibody against IL-1, which is 150 milligrams subcutaneous daily. It's approved by the European Medical Agency. Rilonacept and zevokimab is yet not approved. They are off-label indications, they are being tried, and they are in phase 2 trials. So maybe in 2 years from now, we would have these drugs in our market too. Now ACTH, which is used, that is your adrenocorticosteroid stimulating hormone, what does it do? It triggers to release the endogenous steroids. MSH, in fact, stimulates the melanocyte 3 receptors to decrease the inflammatory response. As well, these patients are drugs are very useful in the post-renal transplant. Butylamine, again, not only affects the IL-6, the IL-1B, but also works as an antioxidant, thus decreasing inflammation. So these are the few very easily available drugs. They are available in the US or in the European market, some of them not available in India yet. Anakinra is the only drug. I was talking to a hemato-oncologist. He says he imports them only when necessary. So yet Indian market, it's difficult to get. But I think in few days we should get. Dapinsutril is an inflazome inhibitor. It blocks the IL-1 and the IL-18 via the capsase 1. So it's an oral molecule. It could be used from small doses of 200 to 900 milligram. And it also decreases the joint pain within 6 hours. So what are the gout guidelines, the ACR 2021 guidelines? That do you continue urate lowering therapy indefinitely over stoppage of urate lowering therapy, which was discussed by my colleague just before. So what they have discussed, the green indicator indicates that these patients are strongly recommended indications. So these are the ACR guidelines. The pink guidelines, there is a question mark. It's an indication to continue treatment, but they are not continuously to be given. So what they have recommended is that you have to continue any urate lowering therapy who have more than 1 flare, but if they have less than 2 flares, you might not continue the therapy for more than 1 year. In patients who have severe CKD and the serum uric acid concentration is greater than 9 or urolithiasis, you have to continue it. And in all patients who have this, their first gout flare, you need not continue or even start urate lowering therapy. Now what are the newer uric acid lowering therapy for chronic gout which are available? The uricostatic, that is your xanthine oxidase inhibitor topiroxostat, which is again coming up as a big lobby. In fact, when they gave us all the answers to my questions, when we had asked about the updates, they told me that febuxostat has a black label warning, which I'll come to it later. So what are xanthine oxidase inhibitor? We all know that it blocks your conversion from your xanthine to allantoin, which is not available in human beings, so they are used. We have the uricolytic drugs, that is the pegloticase, pegsiticase, and the SEL-212, which are under trial. Pegloticase is easily available in US market. Rasbiuricase is available in India even now. You have the ABCG2 activator which increases the GI excretion of uric acid. The renal excretion, which is the uricosuric drugs, are the lesinuride, dotinuride, verinuride, and the tranilast, and the canagliflozin, which is a diabetic drug. Now we all know uric acid is excreted in your glomerulus. Now the 100% uric acid which is excreted in the glomerulus, hardly 12% is excreted in your urine. So maximum is reabsorbed. So what happens is, what is the principle? Close to 100% of urate which passes through a healthy kidney is already filtrated by the glomerulus, but the renal excretory system of patients with gout may be less responsive to the rising serum uric acid levels. Hence, we need certain drugs which actually stimulate the urate 1 to absorb or reabsorb the uric acid which is secreted in the glomerulus. You could also stimulate the ATP binding cassette transporter G2 in the intestine, which could excrete the uric acid through the stools. Now, what are the drugs? We already know about febuxostat. Topiroxostat is the new molecule which not only binds to your xanthine oxidase inhibitor but also binds to your covalent bond with the molybdenum. Now, just 1 minute. They have had lot of trials. The cardiovascular risk of topiroxostat use was much lesser compared to febuxostat, but all the EMA agency, the European Medical Agency, or the long-term renal studies which they studied showed that febuxostat and topiroxostat are equally effective. There is no difference in the cardiovascular risk. Some claim that topiroxostat decreases uric acid much faster than febuxostat, but whatever reading I did not show any difference. So I feel primarily it is your choice. Even in CRF patients, you could use topiroxostat 20 milligram versus febuxostat 20 milligram. So only in patients who have real bad EGFRs could you think of using topiroxostat. So this is what I told. Topiroxostat, start with a lower dose, even as low as 20, and you can shift up to 120 milligram, but preferably 40 to 80 milligram is the better dose. Now, what are the various uricolytic drugs? Rasbiuricase, pegloticase, pegsiticase, and SEL-212. Now, what is most important is that when we are using rasbiuricase, which was approved in 2002 for tumor lysis syndrome, a dose of 0.2 milligram kg monthly IV infusion was used. But what was the problem? You developed antibodies. But in patients who had CRF or who had transplant, who were already on drugs like whether they were on drugs like cyclosporin, they found that these rasbiuricase worked better. So now they are trying it with pegloticase, that is the pegylated part of the rasbiuricase. It definitely decreases uric acid. Only problem is the cost, and yet it is not very easily available in India. Then they found that the antibodies yet developed after 6 to 9 months. Now recently they are doing trials with use of mycophenolate as well as Folitrex, as well as use of methotrexate along with these drugs for decreasing the uric acid. The dose of pegloticase was 8 milligram IV, which was given every monthly. Pegsiticase is developed from Candida utilis, and SEL-2 is still under trial. Now, what are the uricosuric drugs? Lesinuride came with a bomb. It was the urate-1 and the OA24 stimulate inhibitor, which promoted uric acid to be excreted into the urine. The dose was 200 milligram. It was available in US, but the cost was so high that it was stopped from treatment. Verinuride is still yet in phase 1 trial, which is given as an oral monotherapy. Dotinuride is available easily in Japan. Just a small dose of 2 milligram orally is given, and there is no renal dysfunction. Canagliflozin, which is your diabetic medication, 100 or 300 milligram orally is being used as an uricosuric drug than along with as an anti-diabetic drug. Arahoflolate, it reduces uric acid while also causing as an uricosuric as well as IL-1B inhibitor. So it's a dual mechanism action, and its combination for febuxostat decreased uric acid within 2 months. So these are the newer drugs which are under lot of discussions, trials, but we do not know when it will be available in India. So it's very important to note that newer drugs are coming up. We need to study, but we also need to have a cost-effective therapy. Thank you.
Thank you, ma'am, for the extensive update on the newer modalities of the treatment in gout. I request all the chairperson to felicitate Dr. Sabnis, ma'am. I request Dr. Yogesh sir to felicitate all the chairpersons.
I also thank the organizer for doing such a wonderful duty during COVID, arranging the whole sessions and seeing to it that the time management was done. Thank you very much.
After mindstorming back-to-back sessions for the whole day, which were houseful, everyone would be eagerly waiting for the entertainment tonight. I request you all to be a part of the grand banquet and the entertainment session, which start at 7:30 p.m. With this, I would like to end the first day of MRACON 2022. I thank all the delegates, faculties for your attendance. I expect the same for the tomorrow. Thank you.